afternoon, everyone. On behalf of KLB, Oculus, and Chairman of the session, Professor Devan Titiyal, sir, who will be joining shortly, I would like to extend a warm welcome to everyone. Uh, this whole meeting, the next 4 to 5 hours, is a really good experiment to conduct a virtual meet on one topography machine. It just speaks volume about how important topography and imaging are there in our practice today. So I would not wasting much time because we have a long evening. I would request my co-panelists, Dr. Gitansha Sachdev from I Foundation, Dr. Rajiv Mukherjee from Delhi, Dr. Vishal and Dr. Tushar to take over the session. After every 3 talks, we'll have a question and answers. For all the panelists, you have a chat box. You can text your questions, and we'll see that all your questions will be answered. If something is not answered in one session, even at the end of the sessions, we'll make sure that everything will be done. Dr. Gitansha and your team, please take over.
Thank you so very much, sir. So we'll begin with the first session, which is Basics of Tomography Map Reading. So without further ado, I'll call Dr. Sujata Mohan. Ma'am, Basics of Topography Map Reading.
Are you able to see it?
Yes, ma'am, it's visible.
Good afternoon, everybody. At the outset, I'd like to thank Dr. Devesh Shetty for making me the opening batsman for this Indian Pentacam League. So what is tomography? Just to have a difference between a topography and a tomography. Topography, actually what it looks at the surface, whereas tomography looks at the cross-section of the different sections of the body that we're studying. So when you look at that approach to a patient who needs refractive surgery, it's important that we decide on which are the maps that we're going to follow and to have a repetitive examination so that you will form, your mind will start registering what is the right map and what is the left, what is not good. So it is just like looking at the cut surface of a cabbage. Person who's been cutting the cabbage will know this is a red cabbage. But for a person who has not done any of this, it just might be a geometrical design. So the maps that I normally look for is a 4-map refractive, which contains 4 maps in itself: the pachymetric map, the refractive map, and the Bellin-Ambrosius map. The fallacy in the curvature map is based on a reference axis, and if you have a decentered apex, it can cause an abnormal steepening to look, and this is probably one of the biggest fallacies in using only an anterior topography map. And this can lead to the normal maps may look abnormal. This is like taking a look at a shuttlecock ball as an end-on view as well, versus the side view, and hence the need for elevation maps. So when these are the 4 maps that I'm referring to, it contains the anterior sagittal curvature map, the front elevation, back elevation, and the pachymetry map. It also has the corneal parameters on the left-hand side. It tells us about the quality of the picture it has been taken, and the K reading, the astigmatism of the map, the pachymetry at the center of the pupil, the center of the cornea, the thinnest point, the maximum K, which is also important, and anterior chamber depth, which could be important, particularly if you're planning for a phakic intraocular lens. On the right side, it has a KK prediction index and also the pupil coordinates. So when you look at the yes, hello. When you look at the anterior sagittal map, you can see this map is with the rule astigmatism, symmetrical. Both the axes are radial to each other, and there is no asymmetry at the 5 millimeter zone. Whereas this map, you can see there is an inferior steepening, and also a little bit of skewing. And there is again this other map, which just coming up now, which shows a significant skewing. So the important thing is for you to keep on looking at these maps so that you recognize if there is even a little bit of abnormality. So these are the different types of map that you can get on the anterior sagittal curvature. So when you look at the elevation maps, it describes the height of a surface in comparison to a reference surface. For example, here you can see the sea, and on top of it, the iceberg, and the reference surface being the sea. So the reference surface that we use commonly in refractive surgery is a best fit sphere. There are some people who prefer the best fit toric ellipsoid. However, the reason why I prefer best fit sphere because it is able to identify the cone much earlier than a best fit toric ellipsoid. And any point above the reference is expressed as a plus value. The red color dome represents the best fit sphere, and the yellow line outline represents the cornea. And any elevation above the best fit sphere comes out as a plus, and any depression below is minus. It's important to look at the numbers rather than the color-coded maps, because in some of these it can be reversed. And the elevation maps also calculate the difference between the reference body, which is generated by the computer, which could be a best fit sphere or a best fit toric ellipsoid. The importance of using a best fit sphere is because a best fit toric ellipsoid can mask the cone. And so most of the refractive surgeons prefer the BFS. And the ideal diameter is usually 8 millimeters. And this is again a representation showing how the steep and the flat meridian do. And the enhanced display actually does exclude a 3.5 millimeter zone of the thinnest cornea, so that the best fit sphere again changes, the reference surface again changes based on the exclusion, and you're able to identify the cone in a better fashion. So looking at these 4 maps, you can see this is a 16-year-old female who came to us with slightly blurred vision. This looks like a decent map, except that she has a steep cornea of 51.9, but the thinnest pachy was 572. The anterior and the posterior elevation look pretty good. But when you look at the refractive map, you can see that the indices show up as a keratoconus grade 1. And the Bellin-Ambrosio map, you can see that definitely there is some abnormality. The first 2 maps on the top are the standard elevation maps, which are based on the best fit sphere of the cornea. And after exclusion, you get this map called the exclusion maps. And you can see that the areas are now popping up strongly. You can see that the plus signs have gone up, which shows that once you exclude the thinnest area and you create another best fit sphere, you're able to see the cone much better. And you can see the difference between the float here is 5.5, and it's become flatter here, it's become 5.53. And then this difference map, it has got only 3 colors, the green being normal, yellow being suspicious, and the red being definitely abnormal. It also shows indices here, which gives the same idea. So this is again the map of the other eye. You can see the abnormality. You can see the posterior elevation coming up. You can also see the increase in pachymetry at the CTSP. So next is the pachymetric evaluation map. You can see that the corneal thickness is shown at the apex, the thinnest point, the location of the thinnest point is also seen. And also you can see these 2 graphs which represent the corneal thickness spatial profile, which enables early identification of an ectatic disease. So here we all know that the thinnest point of the cornea is in the center, and as it goes towards the periphery, it becomes thicker. But however, in ectatic disease, the thickness increases rapidly. And this red line belongs to the patient, and you can see that the thickness has increased quite significantly, as well as the percentage thickness increase. So this is again some of the parameters. You can see the thinnest area of the cornea. You can see the inferior temporal location and the distance between the apex and the thin location, which gives us the difference. So any difference higher than 1.2 is significant. So this is the other pachymetric map, which I already explained, the corneal thickness spatial profile and the percentage of thickness increase. You can see a significant increase in the as the line goes peripheral, and it does not follow the normative data. These are some of the indices which can be got at the refractive map. And case 2 is a 32-year-old male, and he had a high sphere and a slightly less cylinder. And you can see that most of the maps are normal except for the CTSP. There is a definite drop in the CTSP here. And Kmax is 47.2. And these 2, there are some parameters which are abnormal here as well, but this patient probably can have either a surface procedure or he can go for a phakic intraocular lens. This patient came to us referred as a keratoconus patient, and you can see the inferior steepening. This is the right eye, the left eye was normal, and other maps are perfectly normal. So when you looked at the slit lamp of this patient, you could see that there's some amount of epithelial irregularity as well as staining, which showed that the patient had, on questioning, had recurrent corneal erosions and formation of epithelial cysts. And you can see that the thickness of the anterior segment OCT map showing 71 microns corresponding to the area of steepening. So this is again a patient, young patient, who was only 20 years old and came to us with just a normal refraction in the right eye, and the left eye was plano, but she was complaining of some sort of discomfort, not happy with her vision. And you can see that this, again, the tongue-shaped elevation pattern rising at the posterior elevation, And in the right eye, you can see a significant posterior elevation changes, which is actually not picked up in the previous map. You can just see a slight amount of steepening and very minimal asymmetry. So this shows the importance, and this is also seen in the left eye. And this shows the importance of having a tomography rather than a topography alone. And refractive map is a very simple map. It has just got three parameters and also the indices. And this, just in one glance, it will let you know what if the patient has any abnormality. And this patient has a post-LASIK ectasia. You can also look at the comparison maps. For example, this is a map which has shown the difference between the pre and post topo-guided PRK. These maps are also helpful for planning intacts, as you can see, looking at the posterior float as well as anterior portion. And this is again a comparison map. So summarizing, elevation-based tomography has been in use for more than a decade and has given us a better understanding of the corneal parameters, particularly in planning refractive surgery. So early detection of the ectatic disorders and early management has shown us better outcomes. And thank you. It's just an overview of tomography, corneal tomography.
Thanks, Dr. Sujata. My presentation?
Yeah, carry on, Ritin.
Yeah, we move on to the next presentation. It's Dr. Ritin Goyal reading the elevation maps right.
So I will just be in a second. I think it's gonna. Gitancha, would you like to take some questions in the meanwhile?
Would you take a while to get connected?
Yeah, I'm just trying to get the preferences right.
Okay, I just see if there's any questions.
If there are any questions, we can quickly take one question. Or maybe I can ask Dr. Sujata, ma'am. So one of the questions that is commonly asked is about the tangential curvature map, so which obviously picks up finer changes, but also picks up the noise. So any applications where you find that to be more useful than the sagittal curvature map?
Actually, I'm not a big fan of tangential curvature because I feel that it's totally distorts of the idea. So I'm quite happy with this, but we do use it for contact lens fittings. We don't use it normally for the regular refractive surgery screening. Though I know that a lot of people who use it, I'm not a big fan.
Okay, all right.
Ritin, if you're not ready, we can move to Dr. Rajiv and then back to you. Is that okay?
I think so. I think we'll do that. Dr. Rajiv, and then we'll go to Ritin.
So sir is going to do his talk on the posterior elevation and what's the true picture. Rajiv sir, please.
Can you all hear me?
Yes.
Yes, perfect.
So I'll be talking on a very basic subject, which is importance of posterior corneal elevation and how should we actually look into it. You see these ectasias like keratoconus, post-arc ectasia, post-LASIK ectasia, they visit our premises and our clinics in various shapes and sizes. And you get these subtle signs that you can see these vertical deep lines like Vogt striae. You can see the Flesher's ring in the cobalt blue light. These are subtle signs. Again, you see a little apical scar with prominent Vogt striae in these cases. And the spectrum can go from central corneal thinning, paracentral corneal thinning, to even peripheral corneal thinning, like in Pellicet's marginal degeneration. And there are obvious signs we see very rarely, which are extreme ectasias like what you see right now, keratoglobus kind of a picture. Now, I'll come on to this particular patient to kick off what I'm trying to project here, trying to show you a patient, a young lady, 26-year-old, with a manifest reflection of minus 1.25 with 0.75 at 175 degree, improving to 6/6. She was very keen on getting a refractive surgery done. Clinically, normal looking eye, no dry eye, no problems. Corneal thickness at the center was 500 microns, and the thinnest point of pachymetry found was 494 microns. And you can see on the bottom left, the Placido corneal topography showed a symmetric bow tie pattern, which is absolutely normal. So it will be a very juicy proposition for any refractive surgeon to take up this patient with a low refractive error quite safely. But as soon as we take this patient up for a Klein-Fluke based Pentacam analysis and doing the Bellin-Ambrosio enhanced ectasia, we clearly see, as Dr. Sujata just pointed out, that you can see an ectatic posterior surface, and this patient would have been a potential for disaster after refractive surgery. So here comes in my point that we have been trying to pick up ectasias classically and historically with the placido-based devices, where our criteria were photokeratoscopic Myers showing egging, feature of egging of Myers. There'll be a central localized or a paracentral area of localized increasing surface power with concentric areas of decreasing power, and there'll be a huge disparity or a difference in the inferior and the superior dioptric power of the cornea. We usually said that the central keratometry more than 47.2 diopters, difference between the two eyes in the central keratometry of more than 1 diopter, and the SIM-K reading more than 45.7 diopters, all pointed towards a suspected case of keratoconus. One of the pathognomonic signs described by Rabinowitz et al. Was skewing of the steepest radial axis, or the SRAX pattern, where they said it's around 30 degrees of deviation of the hemimeridian was a classical feature of keratoconus on photoskeratoscopic analysis of these patients. Now, then what went wrong with this patient? As you can see on top left, you see the classic bow tie pattern of the patient. And as I said, would have been a very juicy proposition for any refractive surgeon. But as soon as we took this patient up, where we analyzed the posterior surface as well, apart from the other features of the cornea, we immediately saw a central ectatic area. So hence, we have to look at the posterior surface, and any component of ectasia will be defined by two things. One is the corneal thinning and the ectasia, and both have to go hand in hand. So it's essentially a chicken and egg story, where did the anterior ectasia come first or the posterior ectasia comes first? Let's speculate. Now on your left side, I'll show you a series of slides, one after the other, speculative all in nature. On your left side will be the normal representation of a cornea. On your right side will be a clinical condition, which I've tried to depict. This particular slide shows a case of post-myopic LASIK and ablative surgery, refractive surgery done on this patient, where we can clearly see the flattening of the anterior surface of the cornea. So if you notice, there is thinning here, but there is no ectatic element. So this does not fit into the classification or the criteria to call this patient a patient of corneal ectasia. A case of disciform keratitis, you see, there is ectatic element. You see the anterior corneal surface bulging, but there is thickening, not thinning. So again, we do not have both thinning and ectasia going hand in hand. Now look at ophthalmos. Here we have a stretched out cornea. So both the anterior and the posterior surface bulges outward, but there is no thinning, no element of thinning. Hence, this again does not fall into the criteria of having corneal ectasia. Now, this is an interesting slide. If you notice very carefully, there's a bulging of the posterior corneal surface, and there is an element of thinning. This is a subclinical keratoconus, a kind of a case that we just discussed with the 26-year-old lady. And this is something that you can only pick up if you analyze the posterior surface of the cornea and leave aside your placido disc imaging analysis to diagnose these cases. In the past, these cases were definitely missed because we relied only on the placido-based anterior corneal curvature analysis. So now let's take this one step further. So we now have an anterior bulging and a posterior bulging. But unless you have the posterior bulging more than the anterior bulging, there will never be any thinning. So both planes have to move forward, have to bulge, have to be ectatic, and the posterior plate or the posterior surface of the cornea has to bulge more than the anterior surface to cause thinning. So this is what the genesis of keratoconus is. You have to have the posterior corneal surface bulging much before the anterior corneal surface, and the posterior corneal surface will always bulge more than the anterior corneal surface. And here lies the importance of picking these cases up earlier, much before the anterior corneal bulging, and then maybe treat them with various modalities available. And this thinning and ectasia is what causes the biomechanical failure, and the posterior corneal ectasia occurs first, then occurs anterior corneal ectasia. So checking the backside of the cornea is of utmost importance. So to become a better refractive surgeon, a surgeon who operates on an eye which is normal and just for cosmetic reasons has to use the technology, has to be completely upgraded with the technology, as I said, so that they can analyze the cornea the best they can in today's era. So what is Schleimflug imaging? Schleimflug imaging is basically, if you notice the bottom two regular camera in the Schleimflug camera, in the Schleimflug camera, the plane of sharp focus and the film plate and the optics, they are all not in the same plane as in a regular camera. So hence, compared, if you look at the two rear loads in the bottom, you can see here clearly with the conventional camera, you have a select and a specific area of focus, whereas in a Schleimpflug camera, you have a wide and selective depth of field. This is the technology used in the Pentacam. This is the technology used in the Pentacam, which enhances our three-dimensional analysis of the tomography that was just described in the earlier talk of the cornea. So the Pentacam, the rotating Schleimpflug camera, scans the whole cornea limbus to limbus and gives us a three-dimensional view of the entire cornea. So I think importance of posterior corneal elevation mapping charting is extremely important. Thank you very much.
Thank you, sir. Ritin, if you are ready with the presentation.
Yes.
Just 1 minute. I'd like to welcome Professor Titial, sir, who is the chairman of our meeting. Welcome, sir. We just started with 2 talks.
Thank you, Rohit. Good afternoon. I just missed the first part. I was busy with some other thing.
Thank you, sir. We thought this is Dr. Ritin is going to speak now on reading the elevation map right. Dr. Ritin, all yours.
Thanks, Dr. Rohit. Sorry for the little mess up. Great presentations by Dr. Sujata Mohan and Dr. Rajiv Mukherjee. They're really making my job easy because I think they covered in 10 minutes what I've been struggling to try and cover in even an hour of presentations. So just to start with, I'm going to be talking about reading the elevation maps right, and I'm going to try and restrict myself to just the elevation maps and nothing else. This is a 4 map of my eye. I'm a normal e-metrope. I have never had refractive surgery, and these are the maps that I will be talking about: the elevation map front and the elevation map in the back of the posterior surface of the cornea. Now, just to give you what to look for in elevation maps within a minute, as a refractive surgeon, I'll put it across. It's very simple. The anterior elevation maps, if you have elevation more than 12 microns in a particular area, just like you can see on your top right here, like 14 microns, then this is a suspicious looking map. And if in the posterior elevation, you have something more than 23 microns, then it's a marker for early ectasia, looking at the posterior elevation maps. As compared to a normal eye, as you can see, 5 microns and 11 microns, this is the maximum elevation that you get. These numbers, 12 and 15 microns for suspicious and diagnostic for anterior, and 18 and 23 microns for posterior, are not absolute. Different papers talk about different numbers. And I'm going to go into that, why we don't just look at these numbers and try and look a little bit deeper. So also the Bellin-Ambrosio display, as described by Sujata ma'am prior to in the first presentation, talks about anterior difference maps and posterior difference maps. And I'm going to explain those again also. In a normal eye, you would see these bottom maps to be absolutely green, mean that there is hardly any significant elevation. And in a keratoconus eye, you would see these to be red, meaning that there is significant elevation, both in the anterior as well as the posterior surface. So what is elevation? Elevation maps have been around for a while. If we look at all different types of geographic charts, we can see contour line maps, and this is a contour line map of a mountain. If you draw a segment through the segment A, B through this mountain map, you can actually get the actual surface of this actual contour of this mountain, as you can see right here on the bottom. Try and compare this to the reference surface, which is in orange at the bottom. Now, how does this apply to the cornea? We could draw a line through the point of highest elevation right here. And what we'd see is something like this. If our reference surface was flat. However, as described by Dr. Sujata, the best reference surface for corneal elevation is a best fit sphere. Remember that the pentacam is of your eye. And these photographs could be 25 in case of a pentacam or 50 in case of a pentacam HR. And these are the images that the pentacam is actually acquiring. The pentacam stitches all of these images together, analyzes that data, and then generates all these color maps that we see and that we're so used to seeing as refractive surgeons. So what is this best fit sphere and how does it help us? A best fit sphere is a sphere that actually fits well into the normal cornea. It fits well into this normal cornea, gives us a good idea that what is the elevation on top of a sphere and why are we doing this? Because we want our keratoconus eyes where there is focal protrusion to actually come elevated on top of the best fit sphere. Remember that for the same cornea, if we have a large best fit sphere, we could see our artifactual protrusion. And if we have a small best fit sphere, we could lose out on focal protrusion even in case of a keratoconus eye. The recommended settings for looking at elevation maps is setting the dia to 8 mm. What this means is that the best fit sphere should be calculated for the points only within 8 mm of the central 8 mm of the scan, leaving out the periphery, as we know that the cornea is prolate and flat in the periphery. So we don't want artificial protrusion right in the center. Setting it to float. Float means that it brings the cornea, the protruded part of the cornea right on top, and it floats above the surface. And it's important to look at the actual diameter of the best fit sphere. Now, in case you have a cornea where the best fit sphere is very small, that means that the cornea is steep to begin with. Even in the absence of significant elevations, we could be dealing with a cornea that is biomechanically weak. So I'm going to come here and go ahead and talk about the elephant in the room. Uh, let's call a spade a spade. We are all laser refractive surgeons who want to do specs removal safely for all our patients who actually want uh, freedom from glasses. So what we want to do is follow all the guidelines for residual bed thickness. We want to leave out any cases that are suspicious. So elevation maps precisely only are going to uh, tell you what are these suspicious cases. Cases of clear-cut keratoconus can anyways be made out on good slit lamp examination or even on a basic topography machine. But tomography really helps us to pull out these cases, which could be of early ectasia, and any laser refractive surgery could be a disaster, as just explained by Dr. Rajiv. So I'm going to talk about this case. I'm going to try and explain these Bellin-Ambrosio images right here. And if you look at the front elevation and the back elevation maps, they are carried over in the Bellin-Ambrosio images as it is. The top two maps are the front and back elevation maps as seen in the regular format, excluding the central 3 millimeter area. And Bellin and Ambrosio are very clever. What they do is they actually look at the pachymetry map from here, draw a 3 millimeter circle around the thinnest point of the pachymetry map, and exclude that area for calculation of the best fit sphere. So the size of the best fit sphere goes up from 7.9 to 8.2. So you have a flatter best fit sphere and you're able to appreciate the differences much better. And that is seen in the form of a front difference and a rear difference. Just to explain this, keratoconus eye fit with a regular best fit sphere will tend to catch a best fit sphere which is much smaller in dimensions as compared to a normal cornea. So because this best fit sphere is much smaller, the elevations appear much lesser. However, Bellin-Ambrosio, because it leaves out the area where there is corneal thinning, it actually is able to pick out the area of elevation much better. So I'm just going to show you some few interesting cases where I thought that elevations sometimes made sense and sometimes didn't. If we look at the sagittal curvature maps, I think they look great. If you look at the pachymetry, it's about 609 at the thinnest point. The elevation maps are completely normal. But if you look at the Bellin-Ambrosio display, I think it falters here. The posterior elevation map shows that there is a significant amount of posterior elevation, and even the front elevation map shows that there is something going wrong. So what did we miss here? Why is Belen Ambrosio losing out on its sheen? I think the primary reason here is that Pentacam is included in the Belen Ambrosio map is based on normative data that was collected at the time that Pentacam was launched, and then this data was updated. Primarily includes Caucasian population who have larger corneas. This patient has a corneal white measured by the Pentacam of about 11.5 mm and has an abnormally thick cornea. This is probably not a very common type of cornea which was included within the normative database, and the Pentacam tends to falter these cases. I just wanted to show you another map that you could come across regularly. This is what a post-LASIK uh, Belen Ambrosio map looks like. The Belen Ambrosio map post-LASIK is completely useless because the anterior surface of the cornea has been completely changed. The pachymetry has been changed. However, the posterior surface of the cornea is untouched. As mentioned by Dr. Rajiv, you will see that post-LASIK maps of all these post-LASIK difference maps on Belen Ambrosio would always be green unless patients actually show up ectasia. This is a patient who actually has post-LASIK ectasia, and you can make out that there is some early changes in the posterior map even before the anterior. The other eye of this patient had frank post-LASIK ectasia. Now, this is another map where you can see lots of inferior steepening. Any cornea refractive surgeon knows to stay away from this. But if you look at the elevation maps, Belen Ambrosio seems to have missed a trick here. But if you look more carefully, because I cropped out the picture on the left, there's a lack in the scan quality of this map. So I think it's important that you don't miss out, that you have an adequate scan map, and that it's reliable data that you're looking at. This is a map that was shared with me by someone just to understand what's going on. I'm sorry for the poor quality of picture. If you can see here, this is a very 38, 39, 40. And the thinnest location is 573. This is a fairly thick cornea. It's a very flat cornea. But Belen Ambrosio seems to think that there could be something that is ectatic here. And same is the story in the other eye. The point that I'm trying to highlight here is that don't close your eyes on Belen Ambrosio. Don't close your eyes just on elevation. Elevation is really important, but elevation data can make a mistake. You have to look at the entire cornea. I'm just going to end with this one last case. I think this looks like a completely normal looking eye. Even the elevation maps are normal. The K readings are completely symmetrical, and the corneal thickness is very good. But Belen Ambrosio team tends to miss out on this. Again, I think it is because of corneal thickness, corneal diameter being very small in this case, only 11 mm. And that's something that we miss out on. Thank you.
Thank you, Ritin. So there have been a couple of questions, and Sujata ma'am has already answered. I'll put some of them for our discussion here. So if we had a question from Pakistan which says, so Naeem says that if you have to pick just one reading from the whole Pentacam report, what would that be? So ma'am has already answered that she would, prefer a refractive map, which is an interior, posterior pachymetry and back elevation and CTSP progression. So we can discuss it further. So can we actually pick a single reading, or it is always multiple reading?
I think this is a very interesting question. I think we can ask, we'd like to ask with Professor Titial sir, is there one map we would like to pick up? And then I'll come to Dr. Namrata ma'am, all very senior experienced refractive cornea surgeons. Do you think that is one map which you feel, you don't have time and you have to just read one map? Is there something like that in your practice, or you advise to read all the maps together?
I think what has been highlighted very nicely by speakers also, a single map is not a good idea to look into when you are looking for a refractive cases. Anyway, any pentacam reading in that way, you should be looking all the maps together. And if you would like to see the looking into a Berlin Ambrosio, then I think D value will be the one parameter you like to see in those cases. But I would say you have to see all the maps and then decide. Don't leave it to one map.
I would go one step further, sir, if you allow. It is always wise if you have the capability and the infrastructure to do an epithelial thickness mapping whenever you're trying to diagnose keratoconus. Because a lot of times we falsely diagnose keratoconus because there are epithelial irregularities, as Dr. Sujata showed in one of her cases, that there was a recurrent corneal erosion and there was indeed a epithelial thickening in the area. So these are the things we miss. I think hand in hand, looking at one map is never a good idea. You should get as much as data you can from whatever sources you can to make a good and an accurate diagnosis.
Dr.
Yeah, correct.
Ma'am, what's your favorite scan?
One map, I think, is out of, I would say out of question, because even if you take, for the same patient, if you take two maps 5 minutes apart, they would be different. So based on your finding of just one map is not a good idea. Sometimes you need more than one map. Sometimes you need map on more than one topographer or more than one instrument. Sometimes you need epithelial map. And then you would find that, even on two topographers, they will tell a different story. So confusing clear-cut cases is okay, but whenever there is a doubt, and if you have to rule out a keratoconus, and if you have to plan a case of refractive surgery, I think it is not a good idea to use single map and then do it.
I think what Rohit wants we to answer, if you are looking into pentacam as such, then which map will be most useful in a pentacam? But I would go with a posterior elevation map in a pentacam. But if you want to have other criteria, then I look for a system which has a pellucidal disc based anterior elevation maps. If you are look for anterior elevation, I'll look for other system rather than pentacam. As Rajiv talked about. But if looking only on a pentacam, then a posterior elevation map be the one map which you look into.
I would agree with Professor Tityal on this point. I mean, obviously, we would require the entire quad map, but certain advantages of the posterior elevation float would be that multiple studies, including computational modeling, has shown that it's a focal weakness, and keratoconus very often starts on the posterior surface of the cornea. And the other things, tear film or epithelial thickness, they have more of an impact on the anterior surface of the cornea, but the posterior surface actually is not dependent on these factors. So if you get an elevation on the posterior surface, it could show you a focal early ectasia, which could be missed, which I feel is one of the major advantages of the Pentacam over the earlier models like Placido slit scanning, in the sense that it truly measures the posterior corneal elevation and it is not extrapolated from the anterior surface of the cornea.
There is a question, again, very interesting question. Two questions are very interesting. We did not, Dr. from some Samath, we did not understand how the bad D would be different because of corneal diameter. Can you quickly tell it again, Dr. Ritin? It's a very, very important point because many patients have been labeled as keratoconus because of a posterior elevation. They've been labeled as posterior keratoconus. You got a very nice point, which has been discussed by Dr. Iman meeting also, that the smaller white to white, thicker volume, your whole deviation of normal is different. So they falsely show you as a very elevated posterior cornea without any change. But in your case, I would like to add one thing. When you have a 630 microns corneal thickness, it's also best to do a specular microscopy to see early subclinical guttae there, because many time if you have small guttae changes, the light, the Scheinfeld imaging itself can create some mess with your posterior elevation. Can you quickly tell about the white to white and its relation to bad D again? There are two people have asked this question.
So I'm coming to just to understand the white to white and how it actually affects posterior elevation. Don't just think of the bad D. Okay. Bell and Ambrosio display is only looking at anterior elevation, posterior elevation, and three other factors. Now, the anterior and posterior elevation is calculated separately, actually, from the data that is measured directly by the pentacam, as Gitansha just said. There is no extrapolation here. The pentacam actually creates a three-dimensional structure of the posterior surface and tries to fit in the best fit sphere into it, and then looks at the elevation. Based on this elevation, on top of the best fit sphere, based on the diameter of the best fit sphere, it tells how off is it as compared to the normative database that it has. Now understand that this normative database is based on Caucasian population, where most of the time the horizontal corneal diameter is more than 12.5, going up to even 13.5 mm, while we don't see that in the Indian population at all, I would say. So when we have corneas that are smaller than 11.5 with a horizontal white to white less than 11.5, the rate of change of corneal thickness from the center to the periphery is much more. What ends up happening is the pentacam is trying to fit in a much larger best fit sphere into these, and ends up seeing a lot of elevation which it can't explain as compared to its normative database.
Perfect.
An abnormality.
I think very perfectly explained, Ritin. And there are a few questions which a lot of these answers will be over time, so we will not go into them again. But only thing is about some diurnal variation during menstrual cycle. There's a lot of work being done because there is hydration. When you have hydration, you will see some changes out there because there is epithelial swelling also. There's a lot of work on that, so that also factor. And the day of the scan is also important if you're looking at the progression data. So I think we have answered more or less all the questions, Dr. Gitanksha. I think we can move to the next set of speakers. And some questions have not been answered, but these are all going to be covered up as subsequent topics. So we don't need to discuss about it right away.
Thank you. Just one point I'd like to add regarding the best fit sphere. As Dr. Ritin's really comprehensively explained that an 8 millimeter is the best because it's not too steep or too flat. There are certain conditions of peripheral degeneration like PMD where you should actually increase the best fit sphere to about 9 to 10 millimeters because there might be subtle abnormalities in the periphery which might be missed out if you're using an 8 millimeter BFS. So that would just be the one place where a larger BFS would be more important.
That's one question here we can quickly answer. How much dilatation affects pentacam? Any dilatation affects, because if you want to compare it future, because your line of sight will be different and all the stick changes. Would endothelial abnormality affect pentacam? Absolutely. Any endothelial, even a small changes in your endothelial structure can make your the light to change, and you'll see some subtle abnormalities. I think we will finish with all the questions, Gitanksha. I think go to the...
Oh, sir. We'll move on to the next talk, deciding when and how to do Smile Extra with Pentacam. Dr. Sheetal Bara.
Thank you, Dr. Gitansha, and I would also want to thank Rohit sir and Oculus India for inviting me to this very informative meet. I'll be sharing my slides now. Are my slides visible?
Yes, Sheetal, yes.
Okay. So I will be talking about the use of Pentacam in deciding when and how to do Smile Extra, or rather any extra procedure. So quite often we come across such topographies where either the cornea is thin, or there is an asymmetric bow tie pattern, or there is an inferior steepening, or just a posterior elevation in isolation, as we were discussing just now. So these are features of borderline or suspect topography, but sometimes if the other maps are not showing evidence of keratoconus, it is difficult to label them as keratoconus as such. And in these cases, the decision making regarding this refractive surgery, corneal refractive surgery, can be quite challenging. And this is where the role of refractive surgery with simultaneous cross-linking comes into play. These procedures are known as extra procedures or plus procedures. So depending upon the procedure, whether PRK, LASIK or SMILE, they are called PRK extra, LASIK extra and SMILE extra respectively. But we see that a lot of surgeons are hesitant in adapting to these procedures because of certain reasons. Firstly, the eligibility criteria are not clearly defined. Also, the cross-linking protocols are not very clearly defined. Different surgeons are using different protocols. So it's not sure which protocol really works and which doesn't. And there could be a chance of potential side effects such as haze, which can affect the visual results. And also in the long term, a chance of having a hyperopic shift due to the cross-linking. And it also increases the overall cost of the procedure. Due to these reasons, these procedures are not really very popular. However, in our experience with SMILE extra procedure, which we published in 2015, we found at the end of 1 year that there was no loss of BCVA, and the procedure was quite stable, and its stability was as good as the routine SMILE procedure. So decision making for extra procedures. So specifically for SMILE extra, this is the algorithm which we follow, and we are also going to publish this in IGO very soon. So what you have to essentially see is look for some risk factors if they are present or not. So most importantly, age less than 30 years, spherical equivalent more than 6 diopters, a suspect topography, but of course not keratoconus. Thinnest pachymetry less than 480 or less is again a risk factor. Residual bed thickness between 250 to 280 microns. CBI and TBI parameters more than 0.5 and bad D more than 1.6. Or if there is any positive contributory history such as a family history of keratoconus or a history of allergic eye diseases. So if there are 2 or more of these risk factors present, then it is recommended that a simultaneous cross-linking should be performed along with the corneal refractive procedure of your choice. You can also look at Randleman's ectasia risk scoring system and PTA metric. However, these are not these are optional and not essential. The criteria which I have just discussed are what we are following. So regarding the procedure, it's very simple. You just remove the lenticule from the pocket, and after that, you inject 0.1 milliliter of riboflavin. Now, this riboflavin should be, the strength should be 0.25% in saline without dextran, and this should be applied to the interface for 60 seconds, and then it should be washed. And finally, the eye is exposed to ultraviolet A radiation at 45 milliwatts per centimeter for 75 seconds through the cap, and the total energy thus delivered is 3.4 joules per centimeter square. So now coming to how Pentacam would help us in decision making for refractive procedures, for extra procedures, and I'm specifically talking about SMILE extra here. So we all know, we have also discussed about the Bellin Ambrosio enhanced display map, which combines both the anterior and posterior elevation as well as the pachymetry data to provide a 3D representation of the corneal shape, which is then compared to the standard database of controls and keratoconus, and thus it enhances the detection of keratoconus. So the cutoff value is more than 1.6. If it is more than 1.6, then it could be a suspicious cornea. So this is, we already know, but in addition to the Pentacam bad D, now we have integration of Corvis ST with the Pentacam, and this has given us additional indices such as the CBI and TBI. CBI is Corvis Biomechanical Index and TBI is Tomographic Biomechanical Index. So CBI essentially is a comprehensive biomechanical screening tool for keratoconus detection, and this is based on corneal thickness profile and deformation parameters. The normal value of CBI is within 0.5. The TBI integrates Pentacam data along with the biomechanical analysis and uses artificial intelligence to optimize the detection of ectasia. And the normal value of TBI is within 0.29. So let us look at some case scenarios where with the help of combined tomographic and biomechanical data, how it helped us in the decision making. So this is case 1, 26-year-old male, high myopia of 6.5 spherical equivalent, and the thinnest Pachy of 516. So if you just look at the curvature map and the corneal thickness map, they look pretty normal here. The RST also is above 300. So if you just see the quad map in this case and just do your calculation of RST, you would think that it's a normal routine case. I would just want to go ahead with the SMILE or LASIK procedure. But only if you look at the BAD as well as the CBI and TBI, you see all the three parameters are not normal. So BAD is high 1.68, CBI is high 0.73, and TBI is also on the higher side. So, and if you look at the keratoconus staging, it is within normal. It is A0, B0, C0. So it is not a keratoconus, but it is borderline cornea due to high indices of BAD, CBI, and TBI. And in this case, this is a perfect case to perform SMILE extra. So in this case, we performed SMILE extra. And then this is case second, 25-year-old female. Now she has a low myopia, 1.75 sphere. Pachymetry is fine for the refractive error. RST is also very good, 373 microns. And if you just look at the curvature map and thickness map, they are absolutely normal looking. But only if we see the BAD is 1.96, quite high, and the TBI is 0.68. So it gives us a kind of an alert that this may not be an absolutely normal cornea. Although it looks like normal, the pachymetry is good for the refractive error, but only because of these parameters being on the higher side, you would be cautious, and probably in this case, you may want to perform a SMILE extra or simply a PRK procedure. Case 3 is a 26-year-old male with moderate amount of myopia. Pachymetry is on the thinner side, so 485 micron, and the residual bed thickness is also fine, 295 is okay. But when you see the BAD, CBI, TBI, all parameters are high, and definitely in this case, because it's also a moderate to high myopia, and the keratoconus staging is also stage 1, so you would not want to perform a corneal refractive procedure, or just go for a ICL or do not do anything. So just quickly, I would want to discuss the results of a retrospective study which we performed recently, where we looked at corneal topographies of all the patients who underwent SMILE or SMILE extra from Jan 2014 to June 2018. And what we found was that a total of 4,600 odd topographies were analyzed, out of which almost 4,000 were normal and 698 were borderline. Now in this borderline category, 176 cases underwent only SMILE. So ideally we should have done SMILE extra, but we did only SMILE for these, and 522 underwent SMILE extra. So what we found was that at the end of this study, all these patients had at least a follow-up of 2 years. And we found that none of the eyes in the SMILE extra group, where we did SMILE extra for borderline corneas, developed any ectasia, whereas 5 eyes in this group, which underwent only SMILE, they had ectasia. And also we had 2 eyes in the normal group where only SMILE was done, they developed ectasia. So this is very significant, because at the end of this study, with the results of this study, only we actually came to know that these borderline cases have to be taken very seriously, because all the ectasias which developed were only seen in the borderline category, which underwent only SMILE and not extra, and in the extra there was no ectasia. So based on the results of this, the percentage of extra procedures now in our practice has actually increased to up to 18 to 20%, and earlier it was about 5 to 8%. So this is how this study has helped. So to conclude, at least in our experience, SMILE extra is safe and effective for prophylaxis of corneal ectasia in the borderline corneas. And the advantages of combined 3D tomography with corneal biomechanics are that it increases the safety from the patient's perspective, because the risk of ectasia is taken care of. And also from the surgeon's perspective, it improves the efficiency and the confidence in decision making in these challenging eyes. Thank you so much for your kind attention.
Angsha, can you ask the discussion, because Pooja is going to connect for a live demo. It takes a few minutes to connect the Pentacam software.
Sure, sir. So the same question has been asked repeatedly on the chat. It's for Dr. Sheetal. It's a question even I had actually. So the question is, in these borderline corneal tomographies, why not do a surface ablation or a PRK extra instead?
Yeah, you can always do. We can always do, again, depending upon the refractive error.
Okay.
Yeah, if the refractive error is, of course, we all know that PRK may not be a very good procedure for moderate to high refractive errors. So in our practice, we limit it to up to 4 diopters of spherical equivalent. So if it's a low refractive error and the cornea is borderline, you can always go for PRK.
Sheetal, I have one question for you, and that is obviously you would have started doing Smile Extra later and you would have done all the smile procedures before. And again, likewise, the ectasia would appear earlier in Smile, and you still would be having Smile Extra patients whose follow up will not be as much as the Smile patients whose follow up would be longer. So did you try to compare that? And also another question was that post CBI LVC, in all those cases where you did Smile Extra, did you look at the post CBI LVC laser vision correction biomechanics post op, and what was it like?
Yeah, that's very interesting.
Did it improve or did it remain the same? And did you try to do a SSI or in these cases?
So regarding your first question, ma'am, we actually started doing Smile Extra almost during the same time when we started Smile. So we started Smile in 2014, October. And the first case of Smile Extra in our practice was done in December of 2014. So it was almost around the same time when we started both the procedures. It was only that the decision making was a little different at that time, because there was this thing that Smile is more biomechanically stable. So we did treat some borderline cases with only Smile and not Extra, because we thought that it should be okay. So this is how those cases eventually ended up having ectasia. And this is what we learned over the time, that these cases have to be also should have been planned with Smile Extra. The second question, whether about the biomechanical stability of Smile Extra. So post-operatively, we are doing a study comparing two groups where the eyes are matched for refractive error, age, and corneal thickness. And we are looking at the post-operative biomechanical indices. And what we have so far seen is that the deformation amplitude, which is the main index for the corneal biomechanics, which we mainly see in the corneas, is the value is much lower. It is less in the Smile Extra group compared to only Smile. So probably this could give us an indirect evidence that post-operative cornea in Smile Extra may be more stable compared to only Smile.
Ma'am, if I can make one more point. Initially, what Dr. Sheetal was saying was, it's very hard to say how to, actually prove that actually it's becoming biomechanically strong or not post LASIK or post Smile Extra. So with the help of actually the PSOCT or the polarized OCT, now actually we're able to actually see the changes, post Smile Extra. We're able to see the structural changes, when you compare regular Smile and cross-linked, Smile Extra and a LASIK. It's very significant changes are there. So sometimes, when you see it visually, visual changes in the structural changes which is happening, that gives you more convincing this one.
Dr. Sheetal, I have one question to ask for you.
Yes, sir.
Looking into borderline cases in your series of around 175 cases where you're not done Smile Extra, 5 cases developed ectasia.
Yes, sir.
This is a significantly high number of cases.
Yes, sir.
So that gives a point. People who do not have access to all these equipments like Corvus, they can't do biomechanical studies.
Yes, sir.
The same thing what we have been doing is, such borderline cases, we wait, see these patients, how they behave in next 6 months, 1 year.
Certainly.
Then plan subsequent procedures, because this shows that, they do have a very high chance of ectasia happening in these cases. And the second was in your series of cases where you have done cross-linking, SMILE extra, what refractive correction or a modification you have done in these cases compared to routine SMILE patients? Because we know that after a SMILE extra, the things will be different, no? The corneal remodeling.
Yes, sir. So yes, it's a good idea to observe patients over 6 months or even 1 year if you see that there is something suspicious. If anybody doesn't have access to Pentacam or any high-end tomographer. In our series, when we do SMILE extra, actually we do not, the refractive planning is no different from a SMILE case. So for a routine SMILE case, we use a nomogram of 10% for sphere, and cylinder also 10%, 10 to 15%, depending upon the astigmatism, whether it is with the rule, against the rule, or oblique. So regarding the planning, actually there is no difference. And we are also doing a long-term study where we have actually seen that there is no difference in the post-operative pattern of regression or stability between both the procedures. So we have not really seen any hyperopic shift occurring over time. We have data of more than 4 to 5 years for many patients of SMILE extra, and they are very, very stable. So no myopic regression, I mean minimum, as you would see with SMILE, almost like by about 0.1 or 0.2 diopters per year, almost the similar it is. Okay. So there's, at least in our experience, we have not seen any hyperopic shift, and we don't plan it differently from SMILE.
Dr. Rohit, would you like to make a comment here?
I think it is a very valid question, because cross-linking itself has been used to treat myopia. So low grades of myopia. Dr. Rohit, would you like to comment on it?
Because your assessment of collagen's fiber, peripheral and central, there's a difference between cross-linked corneas and non-cross-linked corneas. That will definitely have a refractive impact,
What is happening is, what we are seeing is it's a very, very minimal change in the corneal at the interface maybe. It creates some kind of very strong barrier. It is not cross-linking the whole cornea, that is for sure. And what we see is maybe it's cross-linking some part of your cap also.
Cap.
So it is, Pooja did some work with the cornea being stiffer or weaker on many. All the cases don't follow the same pattern of biomechanics. But one thing which is consistent is, if one eye, if you do SMILE, other eye you do extra, some patient actually, most of them remain, the eye which is you've done extra says that it is, the stiffness has not changed, which is good. And compared to the eye which is very odd, it's become weaker. So there is definitely a meat in it. And I think that, we need to have multi-centric work to be really see if there is really a long-term change. But what she says, I kind of endorses, and there is definitely something in it. Only thing is we need proof, which takes long time because we don't have technologies yet to pick up that proof.
I think also the fact that we're using an accelerated protocol would induce less of flattening over a period of time. And there is a less tendency for a hyperopic shift with these extra procedures.
Hitansha, will move to the next one, please. Next session, then we can discuss.
Sure,
whenever. So we have.
Sure, sir. So we'll move on to the.
Sorry.
We'll move on to the next speaker, Dr. Pooja Kamar, who will be doing a live demo discussion with the ABCD classification. Dr. Pooja.
Hello, everyone. Thank you, Hitansha, and every KLB, Oculus, everyone. So what we'll do is I'll just show an overview of how the ABCD classification is. And we can discuss few cases here. It's just not me who's going to be presenting, but it's going to be an open discussion by everyone. So this is how, when you do a scan, your first map comes out to be. It's a Kleinberg overview. You click here, there are multiple maps here. Most of them have been discussed. So I'm going to go to the ABCD classification. So now when the ABCD classification first came in, you go to the topometric KC staging map, and here is where your ABCD classification comes in. So this is like a very early keratoconus. This is how ABCD comes as. So initially, you all know about Amsler-Krumek classification and everything, but they used to take your they used to take your central thickness or the Kmax reading into consideration from the anterior surface. But we all know that this is the disease of the entire cornea, and also the posterior surface is involved. So what Bellin did was, Bellin came up with a classification known as ABCD, which involves all the layers of your cornea. If you see here, it's the ARC, PRC, thinness pachymetry, and the BCVA. So now let's see what each of them mean. So if I, just 1 minute. Okay, so what ARC is nothing but the, sorry.
The software is a little slow here.
Okay, so everyone can see here what the Bellin ABCD keratoconus staging means. So ARC is nothing but the anterior radius of curvature. It takes your average curvature in the 3 millimeter zone, but here the center is of the thinnest location of your cornea. Not the center of the cornea, but the thinnest location of the cornea. From that, the 3 millimeter zone, it takes the average on the anterior. Same thing for the posterior radius. For the posterior cornea, it takes from the thinnest location of your cornea, the 3 millimeter zone. It also takes, most of the classification only takes your central pachymetry into consideration. But however, here it takes the thinnest pachymetry into consideration. And the visual acuity till date has not been taken into consideration by any of the classifications. So Bellin's ABCD classification also added the distance best corrected visual acuity. So whatever the best corrected visual acuity of the patient is there at that visit, it takes into consideration. So based on all these parameters, okay, it gives a value, it gives a stage of your disease. Is it stage 0, 1, 2, 3, 4? First, it gives the stage of each of this individual parameter, which is the anterior, the posterior, the thinnest pachymetry, and the distance visual acuity. And also it takes into consideration you have to enter whether there is scarring or not. And based on this, you can stage the disease of your eye, whether it's from stage 0 to 4. Why is this more helpful is we all can very nicely differentiate the stage 2, 3, and 4. But to differentiate the 0 and 1 or the suspicious or the ectatic corneas are very much important. So this is how the classification helps. And here you enter the distance. This distance visual acuity is not entered by the software. So whatever subjective refraction you have done, you have to take the best corrected visual acuity and enter here and press save. And then based on this, it gives you a classification. All these indices, we all know that this have been there since a long time. So based on this, further how they went ahead is, this was just one visit. But we all know the comparative display maps. Bellin ABCD, they added the ABCD progression display. So in Bellin's ABCD progression display, you can compare various visits. That is the first thing. And the second thing is here they have a confidence interval of your normal population, which is the green, or the 80% and the 95% of the normal population, which falls here. And it also has your confidence interval of keratoconus population. So that was just the ABCD general staging. But however, he went ahead and did a comparative display where you can compare your different visits to see whether your patient is progressing or not. And here it is how it is seen. If you see the first visit of the patient, all the parameters, the anterior, the posterior, the thinnest location, and the distance visual acuity, they're all within the normal range. So this was saying that, this is probably a suspicious cornea. It is not a keratoconic cornea and you can wait. However, if you see at the second visit here, the patient has progressed drastically, and the progression is such that it has now fallen into the keratoconic category in all the anterior, posterior, and your thinnest location. This actually is just not the change between the two. It takes the relative change. It is not between the two visits, but it takes the change from the previous visit into consideration, and it also takes into vision into consideration. So this is how your ABCD comes up. Comparison display comes into the picture. Anyone has any questions, we can discuss this, or we can see different cases.
Pooja, I had a question actually. So I have been using this ABCD display. The only issue that I've had with it sometimes is, when we do a comparative map where we look at 2 time points on, say, our axial or the tangential curvature and the elevation, and they don't really show much of a change. But then when you look at this, it suddenly shows that it's shot past the 95% confidence interval. So would you cross-link a patient if you see that when the other parameters are doing relatively okay, or would you not? That is the question.
Okay, there is a disclaimer here, Rushad, and for all the panelists and everyone here, the ABCD classification again is the normative data. The confidence interval of the keratoconic and the normal population is based on the Caucasian population. It is not based on our population. And the second thing is the repeatability is a bit questionable. Because even if there is some amount of your blinking pattern complaints, or you have any data gaps present in your scans, the ABCD is very sensitive and it doesn't pick up. So that's why it shows gross progression. So I would probably rely on your comparative maps than this one.
Basically, Rushad, what happens is if you are using this, I would put this more for a very subtle grade 0 to grade 1 keratoconus, where the change is not going to be huge compared to grade 2 to 3. For example, this is something useful if you are looking at somebody where you're trying to see whether you need to operate a PRK or not to do anything, and you were waiting for, say, a year or so, where you're worried about the subtle changes, not just the pachymetry change. If it's not a keratoconus, like Professor Titial sir said, that you wait. When you wait, this is probably more useful. I would not put too much of benefit of this on a grade 2 to grade 3 keratoconus where you are looking at your normal maps. Like Pooja said, the thickness and everything is completely different out here. So you probably would use it for your early stage.
So the one more issue was, I just wanted to ask you regarding post cross-linking follow-ups. Would you also use this, or would you avoid it?
I'm not using this because major challenge with the ARC, the PRC, and the thinnest location is your scar completely changes your repeatability. The repeatability of a mesh pentacam is 0.5 diopters. The repeatability of after cross-linking is 1 diopter. That means even up to a 1 diopter, then if you imagine how much of ARCs and all this will change. So, and your vision will also drop in the first 3 months, 6 months. So this is just for a virgin corneas. At this point of time, honestly, I would use for somebody where I'm waiting in that 1 year time.
I have a question, sir.
In that also, sorry. Yes, Vishal, go ahead.
You can ask.
No, what I was saying is this is more of corroborative. I mean, you have to have other, features with it. As a standalone, I don't think you can rely on it. And cross-linked corneas, the cases that we've done, it is just haywire. Sometimes it doesn't even pick up, sometimes it doesn't come, and sometimes the readings are erratic.
That's why I was asking, ma'am, because I've also faced the same thing with it.
Yeah.
I think, honestly, it would be very useful to look at it from a very, very early change from 0 to 1, or maybe just around 1. Don't use it for something more than that.
So if we want this to be a sensitive parameter, why are we taking only 3 millimeter of the cornea while coming to a conclusion?
So it takes the 3 millimeter from your thinnest location of the cornea. So they your thinnest, that's what he has done. When your Emsler screwman can all take your K-max or your center corneal thickness into consideration. So that is why it says that it is probably more sensitive than your other classifications. Okay. So
there is a question here from one of the things. Do you have a natural keratoconus progression result using ABCD display in very early stage? This is exactly what I said. That is where this is going to be very useful, where you are in a borderline and you're waiting for the patient to know whether this is going to tilt towards a KC or not. And this is where I think this will be very useful. Visual acuity with spectacle, this is best corrected. Whatever is the best corrected, I think this is something which you need to use, whether the contact lens or the glasses, whatever the patient's best corrected is.
Yes, and this is, you have to enter for each of the visits here. So that's how also it plays a role.
I think this is Dr. Shizuoka Ku from Japan who's asked this question.
Yeah. He was with us in the cross-link biomechanics last week. So can we go to the next module, the densitometry, quickly, and then
Yes.
So any questions so far? Because this software takes a little bit time to load. Can epithelial mapping by ASOCT be of use? Yes, I think we have some cases lined up after 4 or 5 o'clock, which should explain about this. Better not to do any refractive surgery on suspected patient until the topography and pentacam stability for 2 years. Would like to ask Dr. Namrata ma'am, what is your time you wait for somebody before considering on the first visit the pentacam is having a suspicious topography? Till when do you wait? Let's assume the patient's age is 23 years.
So we'll call them after 6 months initially. And if everything is stable, then we don't wait for 3 years. It also would depend on the age, like you said, Rohit. And if it is 23 years, then you would probably wait only for 6 months and then see if it is stable or not.
If this is a gender, it's a female, unmarried, and she has a suspicious topography, you would use the same criteria for the female 23 years unmarried versus a male 23 years?
Well, it will be different because in pregnancy, we all know that, keratoconus progresses. So I think, again, as far as the gender is concerned, I would be more, even for cross-linking, I would be more more radical in cross-linking a female than a male patient who, you would know that in pregnancy will not. I mean, a female patient who in pregnancy would progress.
I can make a small comment. So I personally believe, like ma'am is saying, that in terms of female, definitely, and especially the suspicious corneas, I personally believe that if you do have, if you're also doing phakic IOLs, simply if the patient is suitable, then simply go ahead with it. Instead of taking all these little borderline, a lady who's specifically very keen on getting all this power removed just for the marriage sake, and these kind of cases, it's better to just go with the phakic IOL, and then I think that way the cornea is left alone.
Yeah, ICL is definitely one of the options. I think we have a session on that also. This is a small module about, a lot of people have asked, how do you use densitometry and where do you use it, both corneal and optical densitometry? Pujak, if you can just quickly go and run on this.
Okay, so the corneal densitometry, again, you go to the display and there's a corneal optical densitometry, you click there. And this is what the map you get. So I have just kept this patient to explain everything. These are your corneal layers, and you can choose layer 1 and layer 2. Layer 1 is basically from your anterior surface. Layer 2 is from your posterior surface. And this is how your gray, the map looks like the overall cornea from 0 to 12 millimeters of zone. And the values which you are seeing here are the values of haze, which are presented in the grayscale units. So your values of haze will be given to you in your grayscale units. Anything below 20 is your normal. Anything above 20 is your haze. A lot of times you don't see haze on your, clinically you don't see haze in your patients, but when you go back to your pentacam, this will show you that if there is any subclinical haze present or not. Now, how do we look for haze? It's not ideal to look for your haze at 0 microns, which is on your surface. You technically look at your haze, the subepithelial level or at the stromal level. So the machine automatically will give you this map at the 0 microns, which is on the surface. You can actually change it here and make, whatever value, you can scroll your cursor and take it subepithelial or in the stromal level. So now here I have kept it at around 100 microns at both the areas. So this is the sagittal, the cross-sectional image which you see. And now we are seeing what amount of haze is present here at 100 microns. So if you see here in the center, there is you can clinically make out also that yes, there is haze and the values are about 20. And as you go towards the periphery, yes, it is reducing. This is a post-cross-linking patient, so this helps us in knowing what amount of haze or scarring is present. The more importantly here, there are two maps, which is the corneal densitometry average and the maximum. Now, a lot of people have a question is what is the difference between the average and maximum? The corneal densitometry average is nothing but the average of your entire cornea. Like, the entire cornea at that place, of, for example, here, it gives you the value of that place. But the maximum is a more sensitive tool, and it gives you the amount of haze present, like the maximum amount of haze present at this point. So, for example, if I change from if I go back to average, if you can see here, it's the average of the entire cornea. So, for example, your posterior stroma or anything doesn't have any haze, it will negate its effect. The average will reduce it and show you a pseudo value. So it's always better to take a corneal densitometry maximum to see what amount of haze is present at this value. Now, this is the map of corneal densitometry annulus layer averages. So it shows at different levels, like 0 to 2 millimeters. This is the center. From center 2 to 6 millimeters, 6 to 10 millimeters, and 10 to 12 millimeters. So and it is also at anterior 120 microns. It takes into the central layer, which is excluding your anterior 120 and the posterior 60 microns and the posterior 60 microns. So at each of these zones, it gives, and at each of these layers, it gives you the amount, the value of the haze in grayscale units present. And this total is just nothing but the average of each of this. So it is a very valuable parameter when you would like to consider, you would like to know that what is the amount of haze present. And this is nothing like this average and maximum of the let me just minimize my screen. So this is from your layer from corneal densitometry layer. This goes from the anterior to the posterior average max. So the straight line, the blue which you are seeing is the normative value here, and the red which you are seeing also is the normative value of this one. So anything, the dotted line which you are seeing here is the amount of haze the patient has on the densitometry. So it is much above and at different zones from 0 to 12 millimeters. And same here, it gives in the percentile of how much amount of haze is present in this patient from anterior to posterior. So this is how you read your corneal densitometry maps. Why is it important? Why you need to read your corneal densitometry maps is it has a lot of applications like your post cross-linking, your post PRK, your Fuchs dystrophy. In Fuchs dystrophy, you need to go to the second layer, then see how from the inferior layer how your haze is. Post cross-linking, if clinically also you don't see haze, if you go to a comparative map, it shows a progression. Go back to your densitometry maps and see if there is any amount of subclinical haze present on your densitometry maps present or not. Because if any amount of subclinical haze like this picture post cross-linking is present, it will affect the repeatability of your scans. And if you are seeing a progression or excessive flattening, it is just because there is some amount of haze present, and the machine's repeatability is affected. We can discuss this now. Vishal, Tushar, Dr. Rushad, if you have any questions, or if you want to add anything to this.
No, I think excellently explained. And I would want to ask you, so does this ever define post cross-linking? Does this ever define your baseline measurements? So you would want to follow up your patients post cross-linking and see the measurements in curvature, right? So only once the haze has cleared out adequately, would that be scanned? Could that scan be considered good enough? So do you ever look at this and decide which one would be your baseline scan?
I think baseline scan here, I think what you have is your pre-ops, because otherwise from the day one of your surgery, once the epithelium has healed, the values are going to be affected. Or after, what you would consider is once the haze has come down both clinically and on your densitometry maps, that's when you will say that yes, this map is a good map and a repeatable map. So till then, if you feel anything vague on your or anything out of the normals in your patients or on your comparative maps, I think you have to decide with caution whether it's a true flattening or a true progression.
How sensitive is Julia?
Okay. I think you all, like our team only has compared different machines when it comes to densitometry and the repeatability of it. what we have seen is between OpScan, Galilei, and Pentacam, that Pentacam is the most repeatable. I would not say that, okay, you go and vouch on this and you blindly follow this. Again, this is a machine, you cannot blindly follow anything on it, but Pentacam is the most repeatable amongst all the tools when it comes to your haze and repeatability.
Thank you.
I think Dr. Ritu Arora has written here that it is very effective tool post DSEC and post DMEC. And
Yes, ma'am.
yeah, so for corneal surgeons who do that, it is useful. But one thing is there that have you done this densitometry in the initial part of, I mean, on post-op day 1 or 2 or 3 or 4 of cross-linking? Because at that time you tend to have a little bit of corneal edema, and then again, you know, the values go again haywire. So after post-op week 1, it is okay. Even then, you know, best would be to do it after post-op month 1. Then it kind of gives more predictable values. But I don't know, what is your experience on it, Pooja?
Ma'am, nothing below 1 month, I think, is ideal to watch because these patients are on a lot of drops, lot of edema. So 1 month or beyond is what we would look at.
Yeah.
And even if it is a cross-linking patients, I think even if you want to see the outcomes, the ideal time would be 1 month or beyond.
And one important take-home point before we move to the next talk is if you are looking at stability of a cross-linking, it is very important to first look at the stability of the haze. That means if the haze is getting better, your stability of repeatability of your reading is getting better. That means if the pre-op level is 20 or of units, and if the patient is coming closer to 20 in a year's time, that means your scan stability is going to be better. Anything in which causes haze, clinical or subclinical haze, is always going to be very, very difficult to evaluate the stability of post-crosslink eyes. I think that is something which is very important tool for cross-linking purpose, other than other refractive error. It also helps in monitoring your PRK haze also. If a patient has haze and you want to document it, this is a very beautiful tool to know whether your steroid is working, whether you need to really give him more steroids, change the drops, medications. I think it has a lot of application. It is one of the least utilized tools in Pentacam. So I thought this was a nice.
Yeah,
if I can add one more, yes, ma'am.
There's one more thing. I mean, I'm saying it from the, again, corneal transplantation point of view and corneal decompensation. Dr. Ramesha has again written that they use this, you know, when they treat corneal early Fuchs dystrophy with Rho kinase inhibitors. And, you know, they use this as a tool to monitor the progression of those cases. So I think it has a role to play. Only thing is it is underutilized. We have not, you know, used it very often in these patients.
If I can add one more use of this particular setting is, especially whenever we see pre-refractive surgery, you know, we have one or a couple of tiny corneal scars. And, you know, sometimes decision making in whether to do a femto or a microkeratome and then do the surgery, you know, so this might, you know, help you to, you know, guide you through the process. Right now, we don't have a specific number, but I think we are working on it.
I think, Itansha, can we move to Dr. Prema's talk now? And
Sure, sir.
waiting, I think it will have a nice flow.
So the next talk is deciphering combined corneal pathologies. May I request Dr. Prema Padmanabhan to give her talk?
When she's getting ready, there is one question with Dr. Gitansha, if you see if you can answer this, because I've seen your work. Question on, 1 minute. Question on corneal curvature with accommodation. Would small cyclotorsion, which could occur during accommodation, cause an issue? And how do you factor corneal accommodation as an influence of corneal mapping? It's a very difficult question to answer because cyclotorsion does have an effect. That's why you need very fast scanner to actually image your eyes. And that is one of the reasons why Scheimpflug imaging was better than the slit scanning imaging of OpScan. One of the major issues with the slit scanning is the amount of cyclotorsion and induced accommodation and all the movements you have, microseconds you have. So a lot of this is taken care by faster scanning. Once you have a faster scanning, the accommodation component and cyclotorsion component to a large extent is taken care of. Gitanshi, you want to add anything to it?
I think this is a separate field, completely, which requires again a lot of inputs and insights, and I think it is not that well understood as of now.
Ma'am, I think like to request Dr. Prema Padmanabham, ma'am, to give a talk on decoding combined ectasia. I think this is going to be a nice sum up of all that we discussed in this session. Ma'am, I think
Dr. Prema ma'am is there?
the slides are there. I think she's muted, I guess. Yes, I can see that she's there.
I'm trying to unmute her. It's not responding.
I think somebody has to call her then.
Can you give her a call? Pooja, can you give her a call, please?
Yes, sir, I'm doing that.
She's not responding.
So can we move to the next session then? Because we can come back to her once if she's able to.
Ma'am, I'll ask the host to do it. Just 1 minute. Yeah, 1 minute, ma'am. Sunil, can you unmute, ma'am? She's not able to do it. So if you can do it, she will.
I've been trying this for last 1.5 minutes. She's not starting the camera, neither she's unmuting herself.
No. You need to. She's not able to do it on her own. So if you can help her unmute, like if you can do it, you are the admin.
Okay, I've just asked her again.
Okay.
So let's see if there's any other question which needs to be answered.
I think there was this question for the ABCD vision with glasses and pinhole or vision with contact lenses. Pooja, which vision will you take for best corrected visual acuity?
I think Deepthi has answered it here. She says that vision with glasses and a pinhole.
My video. Yeah.
I think ma'am is coming.
Yeah.
She's there.
Ma'am, we can, ma'am, please take.
Yeah, I'm so sorry for this. I was not able to unmute myself.
No problem. We are all waiting.
Thanks a lot, right? And I think as the number of people who are using Pentacam is increasing and the number of ways we are using the Pentacam is also increasing. So meetings like this are really very relevant. In the vast spectrum of, why am I not able to advance my slides also? Can you help me?
Ma'am, just move your mouse, ma'am, and press it in the center of the screen. It should move. Move your mouse and press it in the center.
Yeah. Okay. Yeah. So in the spectrum of corneal thinning diseases, keratoconus, keratoglobus, and pellucid marginal degeneration are distinct entities which come under the umbrella of corneal ectasias. Now, although each of them have distinct clinical and topographic characteristics, sometimes they coexist. And they may coexist in the same patient or they may coexist in the same eye. And that makes diagnosis more difficult and the management less straightforward. So what I would like to do is to take you through a few cases where we have found these diagnostic complexities and how we used, exploited different features of the Pentacam to try and unravel them. I realize that all of us are seasoned, have been using the Pentacam, so this slide is really redundant for most of you. But I would just like to emphasize the importance of making these measurements before the ocular surface is disturbed by either any drops or any other procedure. Like any diagnostic tool, the reliability of the measurements depends on the attention we pay to these little details. So here is the first patient, an 18-year-old young lad who came with a cornea that looks obviously steep. Now, with the Placido-based system, we have a bunch of indices which are displayed, and these don't seem to make up their mind about what cornea is about. And even though some of the indices are obviously abnormal, they don't fit into the criteria for a keratoconus screening device, screening software that is the most popular in these devices. Now, capturing the same surface with a Scheinflug-based instrument gives us a host of new information. It tells us, for instance, although the SIMK values are more or less the same, it tells us how much and where the steepest part of the cornea is and how far removed it is from the thinnest part. And if you look at the box on the lower right corner, you will find that it displays this disparity between the location of the pupil center, the thinnest point, and the Kmax. And when you see such a disparity, you know that such a cornea requires greater scrutiny. Now, you would expect a cornea with such a high Kmax to be a highly prolate cornea. But in fact, this isn't. And if you look into this box, you will find that a predominant part of the cornea is actually oblate. Now, when you look, although going back for a minute, now when you look at this cornea, it seems to look sort of featureless. And that is because of the color coding and the scale that we use. Now, if we want to look at further details, we need to first change the scale and use the tangential curvature map to be able to pick up subtle changes. And now we're beginning to see that there is an annular mid-peripheral steepening in the mid-periphery, which corresponds with the area of a mid-peripheral posterior elevation. But if you look at the thickness maps, you will now find several areas of peripheral thinning. The important thing is these parts of peripheral thinning lie beyond the area of steepening. This is a feature that is typical of PMD. You will also notice that the thinnest point is far removed from the steep area of the anterior surface. Not only this, when you look at the corneal thickness map, you will notice that the cornea is globally separated. Now, the elevation, again, was not significantly high. And that is the reason why the enhanced ectasia display does not pick up a keratoconus. Remember, the previous speakers were talking about how this is formed, and this is based on elevation, not on curvature. And therefore, even though the cornea has got a steep curvature, the elevation was not too high. And that is why it is negative for keratoconus. And if you look at the corneal thickness spatial profile, you'll find that the profile is more or less flat, again, suggestive of a PMD. When you look at the Scheinflug profile, the most obvious feature is the keratoglobus, but in the periphery, you also see a PMD. A second case, where the cornea looks somewhat similar to what we saw the first time, with almost a similar Kmax, but here the corneal thickness pattern is different. You find that the highest elevation more or less corresponds to the area of thinning, which is very typical of a keratoconus. So there is no doubt that this patient does have a keratoconus, but again, the Kmax is far removed from the area of thinning, and this cornea is not as prolate as you would expect it to be. Now, when you go back to these 6 maps, you'll find that there are areas of paracentral steepening, which correspond to areas of corneal thinning, and that the keratoconus is undisputed in this case. But in addition to this, you see these areas of peripheral thinning, again, which lie beyond the area of mid-peripheral steepening, suggestive of a PMD. So this eye seems to have a combination of a PMD and a keratoconus. And when you look at the enhanced ectasia, the posterior cornea still it picks up the keratoconus. The corneal thickness spatial profile is flat but has a somewhat downward trend. And the Scheimpflug contour has both the elements of keratoconus and the PMD. Now, in these cases, in this particular case, the aberrations that the Pentacam offers is also very useful in these cases. Notice that the cornea, if you recall, was an oblate cornea, and an oblate cornea typically is associated with a positive spherical aberration. The negative vertical coma is a characteristic of keratoconus. So even from the aberration profile, you see a combination of PMD and keratoconus. A third patient with an obvious superior steepening, this looks like a superior horseshoe, but the thickness pattern is very different. The corneal thinning seems to be occurring not in the steeper part where you would expect, but in the flatter part. The reason for this, for me to show this patient, is to show the importance of coverage, as Kitansha pointed out some time ago. By default, the Pentacam gives us an 8 millimeter coverage. But when we are looking for peripheral pathology, it is important to expand this coverage. And now when you expand it, you see that the little area of thinning that was lying obscured by the 8 millimeter coverage now starts to show up. So this explains why the thinning is more on the inferior side, although the steepness of the cornea is more superior. And when you look at the Scheimpflug contour, you will then see elements of both the superior keratoconus and an inferior PMD. Again, a very unusual combination. And finally, this patient who has a steep cornea where the corneal thinning and the posterior elevation all seem to coincide. The patient has got a high negative prolate, a hyperprolate cornea, which all seems to fit in, so it has keratoconus written all over it. But if you look at the anterior chamber depth, it is unusually high. Now we go back to these 6 maps, and while the keratoconus is quite obvious, notice also that there is an element of PMD where the thinning that occurs in the periphery beyond the area of the steepening, but also notice that this cornea has a global thinning. So this is a very unusual situation where we find elements of all 3 ectasias in the same eye. The ectasia enhanced ectasia display picks up the keratoconus. The corneal thickness spatial profiles picks up the combination of keratoconus and PMD, where it is flat with a slightly downward trend. And if you see the thickness map, you see that the thickness extends almost limbus to limbus. Now, again, the aberration display is very useful. We can make out that when 3 ectasias are together, obviously this cornea is highly aberrated. And if you notice that there are aberrations, higher order aberrations, even up to the 6th level, are unusually high. But what is interesting in this combination is what it does to the spherical aberrations. The keratoconus tends to create a negative spherical aberration. The PMD tends to create a positive spherical aberration, and they to some extent compensate for each other. Just to put it in perspective, this is how a normal cornea would look with a very low spherical aberration. This is how pure keratoconic cornea with about the same refractive error in all 3 patients. But here the spherical aberration is very high value. So the combination of keratoconus and PMD seems to bring the spherical aberration down, but of course the other higher order aberrations are extremely high when when there are multiple ectasias. So the Scheinflug image confirming that there is an element of keratoglobus with a normally high anterior chamber, a globally thin cornea, a keratoconus in the center, and a PMD. And just to take you back to where we began, if we were to go back in time, and if we had just stuck to the placebo-based system, we would have remained clueless in this situation. Thank you very much. Now, just to summarize these what I learned in these looking at these maps is that these ectasias sometimes do coexist, and we need to exploit different features of the pentacam to be able to put these jigsaw pieces together. And when we do that, we're able to disassemble the complex nature of these corneas. But of course, what the question that remains unanswered is whether all three are really part of the same broad spectrum of ectasia, or are they different, phenotypically different diseases or variations of the same? Thank you so much.
I think excellent presentation, ma'am. Excellent presentation. And your such fantastic cases have confused the pentacam also.
Thank you, Namrata.
Excellent presentation. I mean, this is these are such rare cases, and to have all indices of those.
Thank you so much. Thank you.
So I think we have come to the end of this session. There will be one small segment, but that we'll do it in the cases section. We'll go to the next segment, which is the corneal biomechanics, and to thank all the co-panelists for this wonderful session. The biomechanics session will be, the panelists for this will be Dr. Namrata ma'am, Dr. Prema, Dr. Kumar doctor for this. And you can start the session, please. Yes, I think before they're getting ready, I think Shreyas needs no introduction. He comes from Eye Foundation, very, very good speaker, and he's done a lot of work on multiple combination of one of the pioneers to start this work on combining biomechanics and tomography together. Dr. Shreyas, would you like to start your presentation?
Sir, thank you so much for the kind introduction, sir. And at the outset, I'd like to thank Rohit sir for the kind introduction, and as well as inviting me over to this wonderful program. First session has been really enticing and a lot of learning and take-home points. I hope I'm able to live up to that with this talk. So today, taking a step further from topography into combining topography with biomechanics, and obviously that has happened because of the combination of the Pentacam with the Corvus. So before we go into it, what is the real need for this? We obviously have better screening criteria now. We are slowly seeing that there is a greater and definite shift towards a need for understanding the biomechanics of the patient. We also have procedures which claim to increase or increase the biomechanics, like in cross-linking, or which decrease the compromise on biomechanics in smile. And we have combination procedures which have been discussed. And despite all the multiple parameters which so many of our equipment give us, wonderful parameters like the overall D, as well as from other Scheinflug devices, while these are excellent in differentiating normal from keratoconic patients, but where we really need, as far as refractive surgery is concerned, is the ability to be able to differentiate normal from form first. And there's still at least about 8 to 10%, even the best of indices lag behind by about 8 to 10% in the ability to be able to differentiate normal versus form first cases. So with the advent of corneal biomechanics, which earlier started with the Aura, and now you have the Corvus, which is available. And essentially, it is an air puff which causes a deformation. And as you can see here in this picture, the deformation is more when the cornea is weaker or softer. And based on the amount of deformation, and using a very high-speed Scheinflug camera, which captures multiple images from the initial state to the state where the cornea becomes a slightly flattened surface, which is at the first point of applanation, going on to the area of highest concavity, and then the rebound. Based on all this, various parameters have been brought about based on the applanation length, the deflection amplitudes, the deformation amplitudes, and as well as the bend radius. So I will not go into the details of each of these. In fact, the entire dynamic corneal response has about 22 parameters in all, which is provided by the Corbis machine. But the issue with the earlier part of Corbis was that while we had a lot of parameters, they were fairly sensitive, but the specificity was quite poor, and it did throw us off on a number of occasions. With the advent of the newer indices, which is essentially the CBI, which takes into account a number of parameters but lays emphasis to four major ones. One, which is the DA ratio, which is essentially the deformation amplitude from the 0, 1, and 2 millimeter, comparing from the center to just outside the center. You have the integrated radius, as well as the Ambrosio's relational thickness along the horizontal profile, which goes from temporal to nasal, and then the most recent, the novel stiffness parameter. Now, this stiffness parameter is essentially, it's a new index which has been developed. We've been looking at it quite a lot. I think Rohit sir will also have some wonderful inputs on it. Seems to be fairly quite sensitive, and is a new index which has been added, which actually takes into account the amount of pressure required for the deformation, which is corrected for the biomechanically detected, that is BIOP, biomechanical IOP, and in relation to the amount of deformation that it has caused on the central cornea. So overall, these indices has led to the development of the comprehensive CBI, and a 0.5 or beyond 0.5 is the index which is the value which has been given as what you would consider as abnormal and something you need to look into. So just to take you through a couple of quick examples, this is an example with a patient with an absolutely normal tomography, overall D being white. But if you look at the CBI, was in 1, was not even borderline, was in the extreme in a cornea which had absolutely normal tomography. Looking at the fellow eye, the patient had frank ectasia in the fellow eye. These are really the patients which we want to detect, and biomechanics probably is taking us towards this. Subsequent to this, there was the advent of CBI, was this publication by Vincigera's group, where they showed 12 eyes with unilateral KC, absolutely normal tomography in the fellow eye, which had keratoconus, where while the Pentacam was not able to detect anything abnormal in the fellow eye, the CBI was able to show a grossly abnormal values. And this was definitely a step further. And taking it even further, where some cases you had where the CBI was either overdiagnosing biomechanical weakness, or at times even failing to show up on certain cases, where we really felt that there was a need for combining these two technologies, that is the marriage of tomography along with biomechanics, and the Scheimpflug tomography along with using the Scheimpflug images provided by your CBI, by your Corbis. Along with artificial intelligence came the new index, which is TBI, which is essentially a combination of the CBI values along with the bad D values, the Kmax values, which are already given, and each of them have a slightly different weightage to give rise to the tomographic biomechanical index, which puts together both tomography as well as biomechanics. Now, taking you into a little further into detail of tomographic biomechanical indexes, initially there was this study which showed that this under the ROC curves, which validated that TBI was actually having a far greater sensitivity as compared to CBI and bad D. So just to allude to this very important study published by Ambrosio and in combination with Vincigera's group, this is a study conducted in both Brazil and Italy together, where they had a large cohort which comprised of 480 normals, 204 keratoconus. But this was possibly the cohort which was most valuable and very difficult to find. 94 patients who had very asymmetric ectasia, that is ectasia in only one eye, but it is this fellow eye which we classically diagnose as, or we classically call as form first keratoconus whenever we are evaluating or validating any index. So these fellow eyes which are tomographically normal but have ectasia in the fellow eye. And looking at that, when they compared each of these indexes, the bad D, when it came to the very asymmetric ectasia fellow eye, was almost similar to that of normal. CBI gave a very wide range of values, but was not able to differentiate very clearly from normals as compared to keratoconus or very asymmetric ectasia. Bad DI is similar to bad D, is just an index which makes it for easier computational. They've converted it to an index which is between 0 to 1, but even that was not very efficient. But when you looked at the TBI, the values are much tighter. It was almost similar to differentiating normals from KC, normals to very asymmetric ectasia, as well as the fellow eye of very asymmetric ectasia. This index was able to differentiate it from normals. So this was definitely a real step ahead and something which we were not able to have any time before. I'll close with this one particular case where just to provide a contrarian view, where a patient with an extremely thick cornea, so thick a cornea that I had to look at the endothelium and to rule out that there was no Fuchs dystrophy, which this patient did not have. Completely normal Bellin-Ambrosio ectasia display. CBI is completely normal. TBI was also normal. But this was the fellow eye of that patient who had almost moderate to severe keratoconus. So we still have a way forward, and probably something like brilliant microscopy, which is able to actually not look at the overall cornea or the whole globe, but actually individual layers, is probably the step forward. Yes, it is. We've been talking about it for a long time, and it is still in the development stages. I don't know if it is going to see the light of the day in terms of actually reaching out to the mass public, but probably a device which has only been able to show us that cross-linking is also possibly effective, being able to differentiate the anterior cross-linked cornea from the posterior cornea, which is not cross-linked. So in that way, this is probably the only device which has been able to show us. So plethora of new investigations are really available to us today, and early diagnosis, and which will really help us in timely and planning appropriate interventions. Thank you so much for your kind attention.
Thank you, Shreyas. Just before we can just keep asking Shreyas questions, just I wanted to plug in a live one from Dr. Pooja to just show that SSI, what you showed. So both you and Pooja can, so people who are using Pentacam will know an idea about from a live demonstration what this all means. And this is what Dr. Shreyas has told. And there is this parameter called SSI, which is a new one. Dr. Prema has done a lot of work on this. I would request Dr. Prema ma'am to just comment on this. Pooja, if you can put the cursor around the SSI.
Yes, sir.
Yeah, the SSI is a new index which for the first, you see, most of these biomechanical properties are affected by corneal thickness and by intraocular pressure. So, sorry. So, whenever you see data that reports biomechanical parameters, we also need to know that they are confounded by the corneal thickness, by corneal geometry more or less, and the intraocular pressure. And for the first time using finite element analysis techniques, they were able to bring out an index which is related to a tangent modulus of elasticity, which is a true biomechanical property of the cornea. And the most important thing was that it does not correlate with corneal thickness and intraocular pressure like the other parameters.
Okay.
That's the importance of the SSI.
And the value closer towards 1 would be the better value, the stronger cornea, right?
1 was chosen for a fifth. You know, when they studied this with respect to age, they found that it was correlated highly with age, and for the patients around the age of 50, they found that SSI was 1, and so they took that as a kind of a reference point. But it does not mean that all patients with less than 1 or more than 1 are abnormal.
Basically, to summarize on SSI, it is the only parameter in the corneal biomechanic measurement which is not affected by the corneal thickness and the intraocular pressure, because every other parameter is heavily influenced by these two parameters. Am I correct, ma'am?
Absolutely.
That's the most important take-home point. There is one more parameter which is here, which is very important, which looks at when you compare two visits. Now the machine is loading itself.
I just wanted to ask one thing. Ma'am said that the SSI, the age group that has been studied was 50 years of age. Is it correct, ma'am? Then are there any values like for, say, pediatric eyes, or are there any values for, say, age which is adolescent or age which is,
Yeah,
less than 50?
it's not that there is a lot of overlap. But what they found was that SSI is influenced significantly by age. So if you take the same patient's SSI and follow him up with age, you'll find that as he grows older, his SSI will start to show that it is getting stiffer. But it is not an index that can be used as a diagnostic index. So it's not that an SSI of this much is normal and this much is abnormal for any individual.
It will just tell you the change, stiffer or softer.
That's right. That's right.
Shreyas, I again had a question. Are we on it live? Do you want to show it, Rohit?
Yeah, this is something which Pooja can explain. This is a very nice, you can show again, Pooja, where do you go to look for this? Because this will tell you the comparison after, it can tell you how the biomechanical comparison display after you do any procedure, whether you've done a cross-linking or smile. Or Sheetal is not here, but this is one of these parameters. This is very useful to see your extra works or not. And in this case, Pooja, if you can just explain, you have the cursor with you.
Yes, so this is one of the case of post topo guided PRK cross linking. So as everyone asked, we had a discussion about smile extra. There's always a debate also that, when you do a laser based cross linking, it makes your cornea weaker. So this is the one patient, this is the pre-op, the A here is, it's like your Pentacam comparative or any topography comparative map. Your A is the pre-op measurement, your B is the post-op measurement of your biomechanics. And very beautifully what it gives us, it gives you the value of comparison. It's becoming softer, has it become softer than before, or there is no change in your SSI, or it has become stiffer. And this, if you can see here, the video of overlap of the pre-op and post-op visit. If you see the blue one, which is the pre-op visit, is indenting more than your red, which is the post-op visit, suggesting, yes, it is also suggesting that, post-operatively your cornea is becoming stronger. This is, however, not a very, ideal way of looking at it. So SSI, it very nicely gives you your cornea, how much change of biomechanics is there compared to your pre-op values. So this is one of the case of your cross-linking, which post-operatively at 1.5 months, it's showing that it's becoming stiffer. So this is many times the question of biomechanically, whether your cornea is same or getting stiffer, you can analyze it in this way that what happens to it after surgery. And these are the other parameters of your deformation amplitude ratio, your integrated radius, your thickness, and everything. All these values are given between non-significant, stiffer, or softer. So this is how you can analyze your...
Yeah, sorry. These values are all dependent on your IOP, your corneal hydration and thickness. But the only thing which is not dependent on all this is your SSI. And that is why the SSI probably could be a very nice tool. And you can see this map here. The red one is deforming less. That means the cornea is deforming lesser to the same amount of pressure with the same amount of intraocular pressure inside.
I just wanted to ask one question, Rohit. Why was age 50 years? I mean, I don't know whether we can answer or the manufacturer can. 50 years taken for SSI parameter, because when you do refractive procedures or you do collagen cross-linking, you tend to do it in a younger age group.
Yeah.
Why was that not, taken maybe 25 years or maybe?
Abhijit is here, one of our head scientists of research. If Abhijit can answer this question, he works closely with Oculus. Are you aware why If Abhijit can answer this, do you know why it was taken as 50 and not as 25? This is exactly the same question, which is I'll try to find it out before the end of the session.
I think Rohit, that they happened to find that it was one for the 50-year-old, and so it was just convenient to use one as a reference point, and it turned out that that one was the value found for age 50.
But
it was not like it was done intentionally. It in their study of a whole lot of normal eyes, they found that the SSI index was 1 for the age of 50.
Okay.
Ma'am, but biomechanics is usually like we routinely use it for our refractive surgery procedures.
Yes.
So if like a lot of patients we see across is less than 1. So
Yeah.
how can we use this parameter in our refractive surgery practice? Because all these patients are younger. They are younger than your 35 or 30 maybe. So
True. It cannot be used as a screening index.
Okay.
It cannot be used to screen a patient for refractive surgery. What it can be used is like what you're showing, to see whether after cross-linking, does it get stiffer or does it not? To see whether a keratoconus is progressing, because all the other parameters, if there is a change in corneal thickness, the other parameters are not going to be reliable. But an SSI will tell you whether when you're in doubt about a keratoconus progressing, it will show you that it is getting softer.
So maybe the comparative display is more useful to us as refractive surgeons than the.
Absolutely.
Oh,
yes.
And I think this also clarifies the fact that SSI is not only for pre and post-op cases, but also for natural progression of cases. Ma'am,
Yes.
our understanding correct?
Yes. So to study progression in keratoconus, this would be one of the parameters, I'm sure, that will be useful.
As speaker, Dr. And sir, are you ready?
Yes.
Yes, sir.
Good afternoon, everyone. And at the outset, I want to thank Dr. Rohit Shetty, who has organized such a wonderful webinar on biomechanics, and also KLB and the Paul for having me here for this session. And a lot of my talk has made easy by the previous talk of Shreyas Ramamurthy, because he was also talking nearly the same thing. The only difference is that I'll be talking more of the tool of biomechanics for the screening and decision making in the refractive surgery. And the important fact is that it is still impossible preoperatively to identify all patients at risk for post-keratorefractive corneal ectasia. We have seen that those with risk factor for ectasia may not develop the condition following laser vision correction, and some without obvious risk factor may develop ectasia following laser vision correction. So there was a need to understand as to what causes ectasia in all these cases, where we thought with the current, before the biomechanics era, we thought that they are okay for going ahead with the refractive surgery. And then we found that we are in a soup, we have had a complication. So there are a couple of things which came into being, and there's novel corneal stiffness parameter, which is a very important parameter to understand. And it fulfills most of the demands of the corneal refractive surgeons. The pre-refractive surgery screening also the effect of corneal cross-linking, and to great extent predict the outcome after refractive procedure and customized treatment in refractive and corneal surgery. And this was a combination of pulse pressure at corneal surface and deflection and vertical displacement at the time of first applanation, which as we go forward, we will find as to what is first and second applanation while we are doing the Corvus. The evaluation of stiffness of pre and post LASIK has been aptly, explained by Rohit and his team earlier. So this is another graph which says that okay, after the post LASIK, there is a change in the stiffness towards worse from before. And also we understand that change in biomechanical properties like PR in LASIK and SMILE were worse than after PRK. So this is again a factor which made us believe and understand that the PRK seems to be a safer procedure for all refractive, corneal refractive laser procedures. So the novel stiffness parameter evaluates biomechanical property. The important fact is that it was not available in vivo before, but now Corvus is the first device of measuring. And that is why this gives a very nice, refractive surgery screening tool, along with keratoconus detection tool, corneal, indications for corneal cross-linking and customization of treatment in refractive. And this is what we are trying as to what best treatment is possible in those particular patients and we want to customize the treatment. The original, as we have seen the video before, in the initial stage, there's the first applanation, which is the first puff of the air, which is given on the corneal surface, and then there is a deformation of the cornea, and there's this amplitude by which the cornea deforms, and then once it has gone down and become most concave, it comes back, and then there is applanation 2 as to how much time it takes from recovering from this concavity to the original applanation A1 situation. And this is what is important to understand as to how soft or hard the cornea is. So the first applanation and then deformation and highest concavity, which is peak distance, and the applanation 2 as this video has been explained, earlier. And this is the earlier video of superimposition of all the three situations, the normal, pre and post corneal refractive surgery, what happens after the refractive surgery. And this is how we superimpose 3 to find out what is the situation of the cornea after the procedure. Now there is a issue which is very important as to what is deformation and deflection. As the air pressure reaches the cornea, it flattens the cornea, and also with the impact of the puff, the eye itself deviates or is pressed inside the socket, and then the cornea comes back. So this dynamic corneal response, whole eye motion includes whole eye motion and also the corneal motion. And when this whole eye motion is removed, that is called deflection, and that is more important than the deformation. So this integrated radius area under inverse radial curve is again very important, because here this movement of the eyeball is totally taken care of and is removed from the overall distance which is there. Now, in Vincigurai screening report, which was explained earlier by Shreyas, 755 patients enrolled, and best parameters to evaluate corneal biomechanics were, evaluated, and they were HC radius, the inverse concave radius, deformation, and deflection amplitude. And all these factors were, they were considered when they were independent of IOP and correlate with CCT or corneal thickness and age. So single report for screening of biomechanically weak corneas is defined by Vincicora and compared to the normal ranges and dependency of BIOP. And this is how the CBI or the Corbis biomechanical index was arrived at. So this first parameter of corneal biomechanical index was first parameter or first index which was arrived at, and we found that CBI seems to be very, very important when we are contemplating on doing the refractive surgery. And as we go forward, we will talk about CBI and TBI as to what will define as to what procedure will be most suited for that particular eye. So influence of pachymetry on and intraocular pressure of dynamic corneal response parameter in healthy patients was this, study was published. And this was found that when we are able to remove these factors, the results are much superior. And there is this is the time when we wanted to biomechanical response was made independent, like we were talking about the SSI and other factors or indexes. So this was the Vincicora screening report, and it has been explained earlier about the screening and deviation of the cornea, and normal ranges of parameters for each step of BIOP, and then the standard deviation for the regression line was arrived at, and then Corbis biomechanical index, and we found that higher the CBI, the versus the corneal situation or the corneal strength, to find out to go ahead and do the procedures. And that is why we were to choose between PRK or LASIK or SMILE or ICL, and this was very important in making decisions regarding what is the most suitable procedure for that. This is another CBI was 658 eyes from Brazil and Italy were studied, and this includes 5 parameters, and this ROC for training set and ROC for validation set, and we found that these are very sensitive and specific index to separate keratoconus and normal, and it might be helpful to diagnose ectasia at an earlier stage than tomography or topography, and that is how we combine the two to make to reach a situation of TBI. So this was something like iceberg, where tomography was giving us information about the cornea, not to a great extent, and the better information or complete information was arrived at with the combination of tomography and corneal biomechanical properties. And earlier, the keratoscopy or slit lamp examination was considered sufficient, and then topography, and then tomography, and we were quite a number of years we were dependent completely on tomography and to decide whether the patient is fit or for the procedure, or to do a combined cross-linking along with the procedure or extra procedure. And now, but the future and today, belongs to a combination of tomography and biomechanical response, and this combined tomography and biomechanical assessment, or TBI, is the most important or combination of two machines, so that we are in a situation to decide whether the cornea is fit for any refractive procedure, or we have to not do any corneal procedure in this particular eye, or do a combination of cross-linking along with the refractive procedure. And here, if you look at this eye, this is it's a false negative tomography where everything is looking good here, but in the CBI and TBI, you see this is falling in the red area, and they are nearly going towards the more than 0.75 and more than 0.5. And these are the cases where based on tomography, we would have gone ahead with the corneal refractive surgery. But when we combined it and have the TBI, then we find that these are cases which have gone into ectasia at a later point in time. And that is where we found that, we were lacking in the devices where they could give us a very correct idea. So this is the distribution of healthy patients and keratoconus patients. And this is the TBI. If you find, this is where this falls into red areas. And when this falls in the red area, then it is not suitable for the corneal refractive procedure. Like in this case, despite the fact that refractive map was good, still it was not suitable for the TBI was not good, and that is why. So there are limitations of the BAD or the Bellin-Ambrosio display, that even with the high, when there is the accuracy of BAD for detecting milder or subclinical cases is much lower than when detecting frank KC. If it is criteria of BAD higher than 1.22, in fact, what we use is 1.6. But if it is what we are talking about, 1.22 provided higher sensitivity, but higher than 1.6 provided a lesser sensitivity as compared to the 1.22, and average, a median value of 1.43 also was not as accurate. So that is why BAD display was not something which we in fact depended so much on when we were doing refractive surgery, say about a year or two back. But now I feel that BAD display has got its own limitations, and we must go ahead and use TBI. And in those cases, we find that there's a 92% sensitivity and 98% of specificity of the TBI in all these cases. So TBI seems to be it's a very important tool in to use enhance specificity in cases with mild asymmetric bow tie or topography in post-LASIK eyes, fellow eyes with no ectasia development. So this graph was already talked about, and this shows that there is the prediction accuracy of TBI is very high as compared to other. And this is a case of unilateral keratoconus where one left eye is on the BAD display is kind of nearly normal, but the other very highly having keratoconus. In the right eye, it is nearly normal. But when we look at the TBI in this particular eye, this is in the right eye. This is very high on the red side, and this indicates that even the right eye doing a procedure will not be a good idea. So combination of Pentacam and Corvus provides safer and more efficient refractive screening. And this is one of my own cases where this patient is nearly okay in all this parameter, but the TBI value is very not very good. It is all borderline here. CBI is in red, and it is all these cases. This is all in the BAD display. If you look at it, it's on the nearly on the normal side. It's very early it's nearly 1.6 or maybe 1.7, but not 1.66. But this was not a good case, and these are the cases where we should not be doing any corneal refractive procedure, rather than opting for the ICL. So this is when we have the combined topographic and biomechanical assessment. this is very important to understand that at 2.35, you can go ahead comfortably with LASIK, SMILE, PRK, trans-PRK eyes, or anything. But as it goes down, there is up to 0.75, you can maybe do PRK, and still down the line, you can do something like ICL at a later point. But anything more than 0.75, you must follow the patient up for at least 6 months to 1 year. I would say 1 year, and then take a decision whether the patient is progressing or stable, and whether there is a possibility of FFKC in all these cases, and then decide what is the best refractive procedure in all these cases. Thank you very much.
I think Naren is next.
Sure, sir.
I think excellent presentation by Dr. Bharti sir, covering the entire gamut of TBI and CBI and when to perform which surgery. Very comprehensive, sir. Thank you, sir.
All right. Good evening, everyone. So today I'll be talking about how do we use the indices of Pentacam and Corvus in looking at myopia. So as we know, the progression of myopia may be closely related to the progression of biomechanical degradation of the sclera, and the corneal biomechanics may be closely related to the sclera because it's also a collagenous tissue, maybe a different meshwork. So when we looked at the association of the age and myopia with the cornea and the extraocular tissue stiffness, we found the extraocular tissue stiffening with age, but the cornea deformation parameters weren't affected by age and myopia. So we thought we need to look closer. So here's the T1, T2, T3. I won't go into the details about this. Now, what we did is we took the Corvus data and created our own biomechanical model to look at the corneal stiffness, the extraocular tissue stiffness, and also extraocular tissue viscosity. Now, when we did this, we found the corneal stiffness and extraocular tissue stiffness correlated negatively and positively with the grade of myopia, respectively. So now we know that definitely there is association with myopia, but can we actually predict myopia? So why we did this particular study is now we have a lot of parameters of Corvus and Pentacam. Now, among all of this, can we actually combine all of this and find a better marker for diagnosing myopia and its progression? And how do we do this? This is where the AI shines. So what we did is we used AI in choosing the right parameters for looking at the myopia and its progression. So the whole purpose of the study is to look at the association of tomography and biomechanical indices with subjective refraction using AI. This is something to look beyond just axial length. Now, here we used about 1,156 eyes from 1,156 children. One eye was chosen randomly, and the age group was between 7 to 17. And we grouped it under ametropic, low, moderate, and high myopia. So now, when we look at the Corvus, we have about 61 indices, and the Pentacam has 27 indices. Now, together, maybe out 88 indices. Now, can we use this to predict? So what we did is we took the data of the indices of the Corvus and Pentacam, fed it into AI, used cross-validation logistical regression AI algorithm, and we analyzed the data or the efficiency of the prediction by using area under the curve and classification accuracy values. And this was the distribution of our results. And when we look closer, the AI showed that these were the best indices among the Corvus and the Pentacam. Now, if any of us were asked which would be a better indices in diagnosing myopia, I think most of us might go towards tomography. But what AI showed was actually the Corvus or the biomechanic indices were better predictors for myopia compared to the tomography. And when we combined it together, they have a very accurate way of diagnosing myopia. Now, what this study is, basically, it is one of the first attempts to associate the tomography and biomechanic indices to myopia. And the biomechanic indices definitely, it looks like it's much better in predicting the pediatric myopia, and also helps, or it is better in tracking myopic progression. And this is one of a novel technique. Really, it's going to change our way of looking at myopia and how it progresses. So in the future, we might be able to predict subjective refraction objectively by just looking at biomechanics and topography. And we should be able to even predict what the final myopia or the myopic progression will extend in the future. Thank you for your time.
I had one question, Naren. The subjects are huge. You had so many. I mean, I want to know what was the age group? Was it children or was it
7 to 17.
7 to 70. So there's a again.
Not 70, man. 17, man.
Okay, 7 to 17. So it's adolescents and school children, basically.
Yes. Yes.
Naren, very good study looking into myopia and its progression.
Yes.
But we know that myopia has, you have axial myopia, you have an index myopia, you have a curvature myopia.
Yes.
The other factors, would you include in your future studies to look into incorporate axial length modification, biometric modification happening these days? Because that will also make a huge difference,
That's true, sir. Actually, backend we are including other parameters, sir. But right now, I've just showed only these two parameters which we have included, and with just the two data of topography and the biomechanical values, actually it looks very promising on how it's turning out. But only thing is to predict the progression part of it. It's going to be a very long-term study, because you need finally what is the final myopic. I mean, at what point that eye stops, at what power. I think once we feed those values, I think into AI, I think it should be doing a much better job.
Especially for a higher myopic group, they may have a more of a axial progression.
That's
apart from a biomechanical changes happening in these cases.
True, sir.
And that also needs to be put into that.
It's been added, sir. It's been added, sir. Yes.
Biomechanics would also depend upon the status of the vitreous, which in these high myopes may be, different, maybe more liquefied or whatever. I mean, there'll be multiple factors which will come in. The scleral rigidity is again very low in these cases. That will also play an important role. So I think multiple things would come in between.
Yes.
Naren, would you recommend doing a cross-linking in myopic patients? A study in future?
We have to see, sir, because I think the future is going where they don't want any surgeries, more of a conservative treatment. I think probably once we really understand how myopia and how it's changing, how let's say just doing outdoor activities for 2 hours or 3 hours, we're just giving a random number, but actually, we really on a long-term basis, how conservatively, I know it's a loss for us, but I think that is the future where we need to prevent or put a stop to the progression. Definitely.
I think that is a better way of looking. If you see your biomechanical is the major predicting factor, then we know that atropine study group also there's a rebound phenomena happening in all these cases.
Yes.
So we need to have something which is more long lasting. So maybe this is a good way to look into for future. Rohit, what's your comment on this?
Absolutely, sir. Absolutely. I think next to one, there is a small case and there is one small AI-based one, which I want to bring it up now.
Okay.
Because it will flow in sync with the discussion. So I thought I'll make a small adjustment in with your permission.
Sure.
Because this is very important with what Shreyas said and what Prema ma'am said, because this case explains that we are still not reach the stage where we have every parameter under our control. It is just a case which we did very recently. I think we can have a lot of discussion. I know we are a little, I'm not trying to rush through any session here, because this is a Pentacam user meet and people who are seeing are the Pentacam users and the biomechanics users. So I think this few hours should be dedicated to understanding more to all of us. So that is what my whole goal is. So Dr. Krati, if you're ready, you can just present it. It's a small case, only there are all 5-6 slides, but extremely important for us to understand many things. This summarizes the last 2 sessions discussion about extra and all that pattern. Pratik, can you start? Yeah, we can hear you. Can you start speaking? I think you're muted, I guess.
Yes.
Yes, perfect.
So, good evening, everyone. Thank you, sir and NN, for giving a wonderful opportunity to be a part of this webinar. So, the case here will actually tell us about biomechanics and epithelium map refractive surgery planning. This was a 22-year-old female who wanted to undergo refractive surgery. She came to us, and her best corrected visual acuity was normal. Her OP showed a power of minus 3.5 at 65 in the right eye and minus 3.5 diopter cylinder 105 in the left eye. The rest of the anterior and posterior segment examination limit. So we decided to go ahead and get her scans done so as to go forward for the refractive. And the imaging was done for this particular patient, and as you can see, the corneal topography shows that the axial sagittal map was quite suspicious. The anterior and the posterior elevation were fairly normal. Also, the biomechanics, the CBI and the TBI are normal range, whereas the BATI is subnormal.
Kriti, just hold on here. And I would like the comment from all the people out here. I mean, whoever wants to comment on this topographies, we didn't want to crowd this whole slide. We definitely see there is a posterior elevation, there is an anterior elevation, and the epithelial map is from a different machine, from MS39. You can see this. SSI, we know that from a pre-op refractive status, it is not important. And we know that the CBI and the TBI are all in green, and the BAT-D is one which is in red. So now I would like to start with Dr. Titial, sir, and anybody can comment. This is something which we can free for discussion. If Ritin is here, he spoke about the posterior elevation. He can also pitch in here.
Yeah, to me, Rohit, most of the maps looks within normal limits, except for a bad, which is in a yellow zone. So maybe if you look into epithelial mapping, it is ranging from 50 to 54. 50 to 55, there's a definite pattern in epithelial mapping. Otherwise, anterior posterior elevations are looks all right. So maybe we have to look into a keratometric sagittal map and relate with the your topographic map. And in this case, I think you would be better to talk about the stromal mapping in this particular case.
The stromal mapping on the map was perfectly normal, sir.
Okay.
There was no change. The only
there's no thickness map here.
Thickness map, I can ask Pooja to take it out, but it was not very significantly different, but I will get that out for you. But what is important is this donut shape pattern of epithelial map, which is a very, very suspicious of keratoconic eyes. Many keratoconic eyes do have this donut shape where the center where the cornea is elevated, it is very thin compared to the periphery, which is very thicker. Here, I mean, the difference may be 4 or 5 microns, but still it is significant in a keratoconus in a normal eye. Shreyas, would you like to comment on these kind of pictures where you have a CBI and TBI being normal and your BAT-D is on a little suspicious range?
I was just going to add that point actually. As far as epithelium is concerned, this 4 to 5 microns on an epithelial map, I would definitely consider is quite significant. It's quite a significant value and shows a donut shape pattern. But I agree with Titial sir that with the sagittal and elevation maps, I don't see anything grossly abnormal. But coming back to, though we've been talking a lot about CBI and TBI, I still feel when it comes to this kind of pre-refractive screening, I tend to go more with the values on our Pentacam and BAT-D. There is still, while our understanding of the Corvus parameters are still evolving, there are a number of cases which throws us off which shows, rather I feel we are overdiagnosing form first keratoconus in number of these cases, with CBI being fairly high. But on the contrary, like in this case, CBI is low, but if a repeat scan also confirms the same suspicious parameters, and if the refractive error is high, I would probably consider a phakic intraocular.
Rohit, can I make one comment?
Yes, sir, please.
Looking into, I know this donut-shaped epithelial changes, and you said stromal mapping is normal and CBI is also normal. So I would rather look into some other, source for this change, maybe a ocular surface disease or some sort of a tear film abnormality in this particular case, rather than diagnosing this as a, early keratoconus.
Absolutely.
So that's why I said a repeat scan, it would be necessary for confirmation, sir.
Shreyas, I think all the scans showed the same kind of a picture, including the OCT-based tomography. I will just let's start with the case, and then we'll. It's quite an interesting case, which completely makes us understand a lot of things in the cornea itself. Kritik, can we keep moving?
Yes, sir. So that led to confusion, and
she was not a contact lens. Yeah, this is a Berlin
no, she was not a contact
lens.
And it is your display map. Also see the thickness here. It was 507 microns in this patient, which is fairly normal. So after looking at so many topographers and we felt that we are actually looking at this case separately from each perspective, like how the blind men look at. So we need the dots, we need to connect all forms of imaging and complete the picture to actually see what this case actually has. So we decided to first go ahead and decode the biomechanics in the epithelium. We wanted to know mechanics really strong. That's when we decided to image the collagen itself through our polarization sensitive OCT and found that the retardation map of exactly same as like how a normal patient would be. So that brings us to
just a minute.
Mechanics is normal and the
just a minute. Can you just put your cursor in the pattern? This is how a collagen map looks on a polarization sensitive OCT. This is a research tool. The plus marks is the what you see in dark blue is the collagen in the center, and the green and yellow is the anchoring fibrils in the periphery. See, wherever you see the green, those are our anchoring fibrils. If you go back to our the histo to the ultrastructural level of how a collagen is, the central fibers are all straightly patterned, and you have, when they become circle and become anchoring. This is classically picked up. This is how a collagen should look at when you have a normal eye. And if you have this pattern, you know that you are looking at a normal collagen. And the same patient's collagen, I mean, of course, because a patient has some lid, she has long lashes and other things, you see some changes, but the pattern is more or less the same. That means that one thing is good in her, that her collagen is perfectly normal as far as the imaging is concerned. But still, the question always comes, what are we missing? So that's when we did the next slide. Can you show the next slide, please?
So this part has already been
then this part is covered. This is how a go back. This is important because this is how an epithelium of a keratoconus patient is. And this is one of our patients. This has also been paper by Dan Reinstein with his Artemis. He classically showed that the donut shaped epithelium is how, and this is what Sunil Morekar has put up as a paper, is that donut shaped epithelium is a classic find in keratoconus, and this is a very, very early sign of a pre-existing form first keratoconus. So this is why I was more concerned about the epithelium in this patient than the bad D or the biomechanics. So what we decided that she was not very keen on the ICL pattern. So we decided that we'll do a PRK, and doing PRK for many years, I know that PRK is much safer. This is a small power, the corneal thickness is decent, and we did the PRK. Can you place the next slide? Your voice is jarring. That's why I'm speaking on your behalf. Okay.
Yes, sir.
So what happens is we have also done a lot of work from molecular signatures from the epithelium, genetic signatures of collagen. You can pick up collagen, lysyl oxidase, all that epithelium produces all of them. So it is important that we can probably see. So even though I did a trans PRK on them, next slide, I mindfully what I did was, and this is mindfully what I did was, I actually collected a little bit of epithelium, a small bit, and we went and did a gene expression, because genetically I wanted to know, is it following a pattern of keratoconus or it's following a pattern which is completely normal? Because that's the only proof of this case was from the genetic analysis. And genetically, go back, genetic analysis, we could analyze what Professor Titial so beautifully mentioned about the dry eye and inflammation. Yes, MMPs, lysyl oxidase, and all collagen can be analyzed. And BAX and BCL2 genes are responsible for cell turnover. That means if they are altered, it means that epithelial cells are turning out at a much aggressive scale. We wanted to check for these two specific genes because the epithelium had becoming quite irregular, and it is following a pattern of a keratoconic one, which is what we have published, that these genes are responsible for changes in the donut shape pattern of the keratoconus. So come back to the next slide, please. And in the gene analysis, this is the map she's already mentioned about them. One thing which was very important is the collagen 1 and collagen 4 was very normal, which means that what the polarization sensitive OCT picks up the collagen. So now decoding the elephant, now when you look at the elephant, one part of the elephant is clear, that what the machine imaging was showing is the retardation, all the maps were normal. And so you're genetically, the corneal collagens expressed in the epithelium were also normal. So this was completely, even though it was little on the higher scale, we don't know why it is higher, maybe it's a reactionary change. But that means that the biomechanics, this is where Dr. Shreyas, the biomechanics of CBI, TBI was normal in this case, because the collagen was actually no more than expressed than what a normal person would do. The controls are patients who undergo PRK with the similar refractive error, same gender, and who have exactly the same refractive power and the same kind of a corneal thickness. So they matched for that, so that we don't have a bias on this. And then next slide. Very interestingly, the lysyl oxidase of this patient was extremely low. And the BAX and BCL2, which is responsible for the epithelial turnover, is very high, which explains what Dr. Krati showed, that irregularity of donut shaped. So, and what is interesting, what Professor Titial sir, is that metallic metalloproteinases, ocular surface was high, and high level of MMPs, low level of LOX. Low level of LOX cannot be picked up by your biomechanics. It cannot be picked up by your Corvis. It cannot be picked up by Brouillon. It cannot be picked up by any other biomechanical tool. The BAX and BCL2 explains the change in the epithelium. The ratio explains the change in the epithelium. The metallic metalloproteinases explains the high level of inflammation without any dry eye in this patient. There's no dry eye or meibomian gland disorder, and the LOX is low. That means, next slide, this probably is a disease in evolution of this patient. So the hypothesis based on a lot of our work in the past is that high level of inflammation cleaves the LOX, and that could change. And go back, and go back, and the normal collagen. So you could have a perfectly, next slide. You could have a perfectly normal collagen with, when you have a perfectly normal collagen, you will have a perfectly normal biomechanics. When you have a perfectly normal biomechanics, your CBI, TBI, based on all your deformation function, will be normal. And that is clearly explained in this patient, that his collagen is normal, his PSOCT is normal, but there's an early changes which is happening in your epithelium. And this epithelium changes is picked up by these two genetic markers. So that means ectasia can be very, very early, can be picked up probably on your epithelial surface much, much, much earlier than your stromal surface. And that is where I think the future is going to be, not only just looking at these parameters. I think probably in 10 years down the lane, we have a user meet, we'll be talking about mixing all this as easy as talking about a Pentacam map today. Today, it may look a little bit out of box, out of context, out of syllabus. The question I wanted to ask, only one slide more, is why is MMP9 so important? This is completely taken from Dr. Pooja's PhD work, where you induce the inflammation by MMP9 on a collagen matrix. This is the same collagen matrix which is there on your lab, and they did some analysis. When you use such amount of collagen, when you use such amount of MMP9, the lysyl oxidase actually drops down. And this, Krati, you can explain this very well and then correlate to our patient, because this is a beautiful case which completely makes us look at an elephant as a whole.
So basically, in this experiment, we found that the LOX levels go down and the MMP9 increases when an inflammation is induced in vitro. And this correlated very well with our patient, wherein also we can see the MMP9 levels are high and the LOX levels are low. This has also been published previously in our work, wherein we had described the smile ectasia patient having a molecular markers of MMP9 and LOX. So what would have happened if we would have advised a LASIK in this patient? This, as Sir rightly mentioned, this was a disease in evolution. So it could have led to a post-LASIK ectasia. Hence, the correct decision was that we took.
I don't know at this point of time, am I correct or wrong? That is something which I don't know. Like, I would need to wait for another 10 years for this. But I did change a thing. After I got this genetic analysis, I changed my pattern. I kept her on a little longer tapering dose because I feel that inflammation reduce should not affect my LOX or regeneration. A tear substitute, even though patient does not have dry eye, I wanted to keep it for a longer time. I added tab doxycycline because it has got a lot of MMP9, anti-MMP9 activity. And cyclosporin, I would keep it for a longer time because this again blocks a lot of this inflammation, which could make the collagen turnover better or epithelial turnover better. And that would also help in better epithelial remodeling so that epithelial changes should not cause a change. This is what I thought I would do for the time being. Like I said, if we had this analysis without epithelium, which one day we will, then we could probably have pushed her more for an ICL than just a PRK. I mean, this is my take on this particular case. This is open for discussion at this point of time.
Thank you, sir.
You can stop sharing this screen.
I think Rohit, with your hypothesis and analysis of cases, you feel that inflammation, which is mainly responsible for all these changes, they are seen more in the epithelium first. Then subsequently, your collagens get disrupted, and you have an ectasia coming up in these cases.
Sir, I personally believe, and there's a lot of
because keratoconus, as said, we know the disease of starting from ectasia happening from posterior to anterior.
But sir, what happens is a lot of this lysyl oxidase and everything is produced by the epithelium. The epithelium is the source of all these activities. And there is a huge amount of, so there is a school of thought now which is coming up, which believes that KC is an epithelial disease. And post-LASIK ectasia is driven by epithelium. That's the reason earlier this concept about posterior corneal elevation is now moving towards an epithelial thinning concept in that zone. So there is a lot of new thought process which is coming in, which is making us believe that it could be driven by the epithelium itself.
Sir, I want to ask you a question, Dr. Titial, sir. Now, Rohit had access to, all the markers and he could do it in this single isolated case, but I'm sure most of the practitioners don't, have that access. So just going by the fact that BAD-D was 1.72, would you have taken this case for surface ablation or SMILE or LASIK, or done nothing about it or followed up?
No, we normally, take BAD-D very seriously, as Suresh also talked about. I would have seen this patient for another 6 months. I reviewed the, topography or tomography again. Maybe, as Rohit said, maybe lubricant drops for a longer period. See the patient more carefully, and luckily this patient didn't have a contact lens use also. So normally, any parameter which is coming yellow and red, we like to wait and see how patient goes. And we normally don't jump for early surgery in all doubtful cases as such. And unfortunately, I've not been a very surface-oriented refractive surgeon, so I hardly do a PRK. But looking into many people now looking for a lower myopia group, maybe we should think of PRK as a procedure in these group of cases. But better to wait and see how this patient goes, because this map might change in next 3 to 6 months.
Ma'am, there's a specific request for you to give comments on this case in the chat group. Dr. Prema, ma'am.
I had a question actually. Rohit, this is a very interesting hypothesis, and I was wondering, is this also a chicken and egg kind of situation? Because the epithelium can be the driving force for the subsequent changes, but on the other hand, it can be the epithelial behavior can be affected by the stiffness of the stroma itself. We know that and even at the junctional complexes are affected by the stiffness of the stroma. So whether the epithelial changes are the cause or the result of changes in the stroma would again be a very difficult thing to separate.
I would. I mean, each person has their own opinion of what school of thought you believe in. My school of thought is, because epithelium, many of us look at epithelium as just a few layered structure, which is of no use but a covering. But epithelium produces a lot of things which is necessary for the strength of your cornea. So epithelium is not just a surface covering cloth. It produces lysyl oxidase. It produces triggers for a lot of keratinocytes synthesis. It produces a lot of enzymatic proteoglycans. It produces virtually the strength of your cornea is produced by what an epithelium does. And that is one of the reasons it is so important that is what actually drives what happens below. Like in this particular case, because there is some changes happening, your collagen is not actually changed. Your collagen is still the normal change. But if you allow this to happen, I'm just talking physiology of this case, not about what we could have done for this. But if you look at this case is all about physiology. If you look at the physiology here, this case, my hypothesis, if you leave this case and you see eye rubber for the next 5 years, then what will happen is that epithelium produces all those collagenolytic enzymes like MMP, which will cleave the collagen 1, 4, and all of them. And then you start seeing changes. And posterior happens because the collagen, the intraocular pressure starts pushing up when the cornea is weak. That's why your posterior pole starts becoming bulging up there. So I would believe, my school of thought is that I would believe it's an epithelial disease driving it down.
One more thing I wanted to ask you, how sensitive is the Brilliant microscopy in terms of when you are comparing, form first keratoconus, subclinical keratoconus versus normals?
Brilliant microscopy has the limited knowledge and what we have experienced, we have is a lot of hydration to image your cornea. And it takes in, if you really look at it, it takes in at least present brilliant microscopy takes in at least 20-25 minutes for you to image one eye, and they are not been able to make it faster at all. I think a lot of people are trying to move out of brilliant and try to look at interferometrics and a lot of other principles than this, because it is impossible for a patient to sit for 20 minutes for one eye examination. So I think that is something which is going to be very difficult in a clinical use.
Another point I would like to make here is that many of these imaging devices, yes, you image them, but how do you correlate what you image with true biomechanical parameters? That establishing that link, I think, is also going to be a challenge.
That's the only reason, even though this is one case, and we have many cases like this, but this is one case which had a nice fit. So we wanted to show that there are times when things don't match. It's not that it's something wrong with the machine or the parameter. It's just the physiology of the body and the eye is trying to play hide and seek game with us. And when you have a hide and seek, then what happens is each parameter is talking, like Prati beautifully said, it's a six blind man elephant, and we only try to look at one parameter of it. This is one case, even though it's an hypothesis, it kind of connects the whole physiology to your imaging, and you explains why something is normal. For example, your cornea doesn't look healthy, bad D is abnormal, so your biomechanics should have been abnormal. The biomechanics is normal because when you look at the collagen imaging, the collagen is very high in this patient. Compared to a normal patient, he has more of collagen. That means his collagen is much stronger and stiffer. That's why your biomechanical is stiffer.
So perhaps then, in such a case where you have been lucky enough to, get that little window before before even biomechanical changes have occurred, will give you an opportunity to medically treat this patient to prevent a keratoconus.
Absolutely. I mean, that is where I feel the imaging with genetic markers is the future. I mean, now imaging is one part of an elephant. If you include the genetic and molecular factor, it becomes a whole elephant. Thank you, ma'am. I think we move to the next session, and I would request Dr. Geetansha to give her talk, and then if you have time, discuss it later.
Is my screen visible, sir?
Not yet.
It is not visible, Geetansha.
Just a moment. Now, ma'am?
Now it is visible. Now.
Yes, perfect. Go ahead. Thank you.
So thank you, sir, for this opportunity. My talk today is on the application of Pentacam for topo-guided planning in keratoconus. I have no financial disclosure. So now we're all aware that CXL is the treatment modality for all cases of ectasia. Now, although it halts the disease process, it does not cause a significant curvature regularization. Hence, CXL Plus has evolved, wherein we combined a refractive procedure along with the cross-linking to reduce the corneal irregularity and have better refractive outcomes. So how does this procedure work? Topo-guided PRK essentially entails the combination of a myopic and a hyperopic ablation, wherein you have a myopic ablation which flattens the area of maximum curvature or the cone, and we have a paracentral hyperopic ablation which steepens the cornea anterior to it, thereby giving you corneal surface regularization. Now let's look at the general guidelines. The main indication for topo-guided PRK is mild to moderate cases of keratoconus. However, there are certain principles that one needs to keep in mind while planning these treatments. I will be discussing these in the subsequent slides. What is the minimum thickness that one can treat? Various studies have had slightly varying protocols, but the general consensus is that the minimum preoperative thickness Epi on should be at least 450 microns, or after the procedure, the thickness after the epithelial removal and the topo-guided PRK should not go below 350 microns. So the maximum ablation is roughly around 50 microns. However, there have been handful of studies wherein they have shown good outcomes with ablations from 60 to as high as 80 microns, provided preoperatively we have thicker corneas, and at the end of ablation, the residual bed did not go below 350. Again, unlike refractive procedures, as in this, the main aim is to regularize the corneal surface. One could reduce the optic zone to about 5.5 in order to save some tissue. Emetropia here is never the goal, and one has to take into consideration the fact that the cross-linking additionally will have a slight flattening or a refractive effect. Hence, we undercorrect both the sphere and the cylinder. The conventional approaches are associated with more haze and greater flattening. So a 40% undercorrection is what is recommended. Whereas when we're using an accelerated protocol, the undercorrection could be around 20%. Again, does it work in both centered or decentered cones? There have been studies that have shown that there is an improvement in the vision and the keratometry in both cases. However, significantly better outcomes have been shown in corneas where the cones were better centered. This has also been used with the conventional wavefront guided protocols, wherein lesser ablation depth at the thinnest point would be one of the additional advantages. But we all know that getting a repeatable wavefront is challenging. You don't only get the aberrated cornea, it is also dependent on internal factors such as the pupil size and the state of accommodation. And obviously a corneal tomography would be much more repeatable. So let's begin with the step-by-step planning. The first important thing that one needs to keep in mind is that we need repeatable scans, wherein the mean absolute deviation should not exceed 0.1 diopters. So what one needs to do at this stage is to remove the outliers. This can be done by either visually inspecting the graphs and removing ones which look grossly different, have a lot of data gaps, or you could also look at the quality of the scans here or the keratometric readings to see if there are some cross discrepancies. After removing the outliers, we still need a minimum of 5 to 6 scans, and then we confirm that the mean absolute deviation should be less than 0.1 diopters. The next would be what sphere and what cylinder do we treat. So the spherical value has to be taken from the patient's refraction as such, because the topalizer does not have the ability to measure the axial length and can give you no clue regarding the sphere. The cylinder, however, is taken from what is measured on the topalizer. So we begin at first by having a modified at 0, wherein we set it at correction of no sphere and no cylinder. So what one gets right now is a map which only has the higher order aberrations. We are not correcting any sphere or cylinder at present. What you can see here is a coma centrally and a band of trefoil peripherally. Now the first step is to make sure that this correlates very well with the curvature maps, where you can see that the myopic flattening here correlates with the area of the curvature, and you have a hyperopic band superiorly. The next step is to debulk the cylinder. Here, debulking the cylinder is of prime importance, and if at all there is some tissue left after that, do we go in for treating the sphere? So we've here corrected about 3.5 diopters. We could not go higher because you could see that we have reached the maximum ablation of about 50 to 55 microns. Ideally, you should correct about 80% of the cylinder if possible with the accelerated protocols. One can also see that we reduce the optic zone in order to save more tissue and debulk the cylinder to a greater extent. Now, what about the cylindrical axis? Now, in these cases where there is an absolutely wonderful correlation between the refraction and what is measured by the topalizer, there's nothing that one needs to think about. You just enter the same axis and go on with the treatment. However, there will be certain cases wherein there is a gross discrepancy between what the patient accepts on refraction and what is measured by the topalizer. So in these cases, one should take the reference of the anterior elevation map, and you should see the axis of the anterior elevation map and the correlation with the axis on the treatment. We can see that 165 here correlates much better, whereas 100 would have a treatment which would be more vertical and would correlate not as well. Another important caveat that I would like to say is that if the patient accepts a hyperopic treatment on refraction, one should go ahead and treat that as well. So you can see here right now we have treated, we've entered the debulking of the cylinder at 147 degrees, and we've reached a maximum ablation of about 55 microns. However, if we also include the hyperopic correction with the same cylindrical debulking, we consume less maximum tissue and are able to ablate further. So these are just some of the pentacams of the patients who've undergone the topo-guided PRK. You can see that there is a gross improvement in the iris asymmetry on the anterior curvature with subsequently better outcomes. Now, even though centered cones work very well with this treatment, you can see that this is a well-centered cone where more than half of the posterior float elevation is within the 3 millimeters, and the patient has done exceptionally well following treatment. Decentered cases can also do well. So this is a case of a decentered cone with a high iris asymmetry, wherein the elevation lies outside the center 3 millimeters. But the patient went on to get a planar corrected distance visual acuity of 20/20 postoperatively. These are certain other cases where you can see that the iris asymmetry has grossly reduced with improvement in the corrected vision. Nipple cones, which are centered, do exceedingly well as well, where you can see that there is almost no trace of the disease on the curvature map postoperatively. Now, one of the other important points that one needs to discuss is, would a laser ablation be better than perhaps manually or alcoholic assisted debridement of the epithelium? As we've already discussed, the epithelium in the keratoconus is irregular and it's thicker over the depressed areas and thinner over the cone. So when we take the preoperative scan, it is done with the epi on. However, once we manually debride the epithelium or use alcohol, what we get on the stroma does not mirror the preoperative scan as well. So transepithelial PRK or PTK would be a better approach because you would uniformly remove about 50 microns, and what you treat on the underlying stroma would be a better image of what was taken preoperatively. However, there are still certain unanswered questions when it comes to this technique. How much ectasia can we treat safely? What should be the attempted correction? Can we debulk the entire cylinder? Do we go beyond the ablation depth of 50, say 60 microns? And could we also combine customized cross-linking perhaps with this procedure to get better results? So I'd just like to conclude by saying that topo-guided PRK with cross-linking is a promising procedure, especially for earlier cases of keratoconus, and it affords to the patient a certain degree of spectacle independence, which would not have been possible with the cross-linking treatment alone. Thank you.
Very nice presentation, Dr. Gitancha.
Thank you.
So if the cone is eccentric, even then you would go for 5 millimeter optical zone?
Yes, sir. Even if the cone is eccentric, I would, it depends on the amount of tissue that I have to play with. So I'd rather debulk more of the cylinder as compared to the optic zone. I'll give more preference to debulking the cylinder. If I could have a larger optical zone, it would be better. But if I need to debulk more tissue, I would go in for smaller optical zones of about 5.5.
Yes, thank you. So we go to our next speaker, EKR map reading by Dr. Lucy Kaveri.
Thank you, sir. Is my screen visible?
Yes.
Okay, so now shifting the gears from refractive surgery, let's move to equivalent keratometry reading map. Thank you, Dr. Rohit sir and Oculus for giving me the opportunity for this presentation. I'll be covering my topic under the following headings. First, what exactly is this equivalent keratometry? Reading the EKR map, how to use it in different clinical scenarios, and a brief synopsis in the end. So on Pentacam, we have different corneal power maps. Based on the anterior surface, we get axial or sagittal map and the tangential map. These maps measure only the anterior surface of the cornea, and then based on the laws of Gaussian optics, give us the power of the cornea, assuming it to be a single refracting surface. The refractive power map measures the anterior surface and uses the Snell's law of refraction to give us the power. The true net power is calculated using both the anterior and the posterior surface, but it assumes a refractive index of anterior cornea as a tissue to measure the anterior surface and of the aqueous humor to measure the posterior surface. So individual sagittal maps are calculated for both anterior and the posterior surface. They are aggregated, and then a true net power is derived. Now, because it uses two different refractive indices, it cannot be used for our routine formulae, which have a refractive index of 1.3375. Similar is the thing for total corneal refractive power. Because it is calculated based on ray tracing and separate maps are derived for the anterior and the posterior surface, it cannot be used for a routine formulae. But this is not the same for equivalent keratometry reading. Why is it so? Because to calculate the equivalent keratometry reading, the Snell's law of refraction is used to derive a map for the anterior cornea. And similarly, based on the Snell's law, a posterior refractive power map is derived. The two powers are aggregated and some adjustment is done. Now, this adjustment is based on the normal cornea. In a normal cornea, there's a fixed ratio between anterior and the posterior surface, where the radius of curvature of the posterior surface is 80% of that of the anterior. So a EKR value, or EKR 65 as it is known now, is derived such that in a normal cornea, this EKR 65 value should match the SIMK values which are derived from the anterior surface. Therefore, these can be used with the formulas which use a refractive index of 1.3375. How to read this map and to use it, I'll divide them into separate parts. The top upper box gives the patient details and the quality of the scan. The graph on the left up gives the details of the keratometry value, equivalent keratometry value in different zones centered on the pupil. It gives you flat and steep K and EKR 65 mean. This EKR 65 mean means the smallest value, which includes the 65% of the value in that zone, which differs from the global mean, which includes all the points measured in that zone. It gives you astigmatism for each zone starting from 1 to 7 millimeters, standard deviation, and the number of points measured in each zone. The graph on the left up box gives the graphical representation of different values to the zone and ring diameter. The graph in blue gives the mean zonal EKR versus the zone diameter. Red represents the mean zonal axial or sagittal power to the zone diameter, and the green is the axial ring values against the ring diameter. Below is a histogram which represents the frequency of different powers which varies in the zone selected, which by default is 4.5 millimeter. However, based on patient's mesopic pupil size, this can be altered. It is rarely symmetrical. It has multiple peaks, and the values usually range between 2 to 3 diopters in a normal cornea. The center is a box with all the indices. It gives you flat and steep K, EKR 65 mean, and all other parameters for the zone selected. In order to determine irregularity also, in a normal cornea, this EKR 65 mean and global mean EKR and highest peak EKR vary less than 0.5 diameter. It also gives you the pupil diameter. This is usually less than what we measured with using infrared pupillometry, because the room where the machine is placed and the lighting conditions all affect the pupil size. However, it gives us the rough estimate for using the keratometry reading for our IOL power calculation. The lower right graph is a graphical representation of equivalent K reading in different zones. Now, how to use it? In literature, there have been studies for use of this equivalent K reading for post-refractive surgery in keratoconic eyes. There is mention of it, of how it varies in untreated corneas and in irregular corneas. This map was first introduced and the pilot study was done on it and published in 2009 by Dr. Jack Holliday. In this study, they had used 100 eyes of hyperopic and myopic LASIK who did not have cataract. But 3 months after the procedure, they had used this for calculation of equivalent K readings and 41 eyes of radial keratotomy which had undergone cataract surgery. Now, historical method was used to calculate the theoretical post-op keratometry and it was compared to the equivalent keratometry. They found that the equivalent keratometry in the 4.5 millimeter zone was optimal and it matched to the theoretical post-operative keratometry for post-refractive surgery eyes. Hence, by default, the value in the EKR map is 4.5 millimeter. Now, another prospective study was done using the 4.5 millimeter EKR value combined with Holiday 2 formula, and it gave very good results compared to other calculation. This Holiday 2 formula is a paid software. So at our center, we have been using this EKR values because lack of Atlas ring values, we have been using this EKR value in different zones coupled with ASCRS online calculator to do our calculations for myopic, PRK and RK eyes for almost a decade with good results. In keratoconic eyes also, there is the similar problem that the ratio of anterior and posterior cornea is altered. So those Placido disc-based topographers which measure only the anterior cornea are unable to give you the total power or the effective power. In most cases of keratoconus, the calculation of the keratometry is overestimated, thereby resulting in hyperopic error. So in this study published in 2018, they had compared 40 keratoconic eyes to 40 normal eyes and used the EKR values of 2, 3 and 4.5 millimeter zone and compared it to T-cone keratometry with LenStar. There was no difference in the control group when it was compared to the keratometry based on Placido disc with T-cone attachment to LenStar. But in keratoconus, there was a significant difference between SIMK and EKR values. The difference increased as the zone increases. In their discussion, they concluded that none of the Placido disc-based topographers are able to give you accurate measurement, and thereby this results in IOL calculation errors in diseases which involve the posterior cornea. They also mentioned that the difference in the EKR and the anterior surface, this variance could lead to more precise measurements as compared to Placido disc-based topographers in diseases which involve the posterior cornea. There were no prospective studies regarding the same, but there was one more study where in post-DSEC eyes, pseudophakic patients, it was a retrospective study where they used the predicted refractive error based on the keratometries from SIMK values, EKR, and true net power. And in their retrospective analysis, they found that the EKR 4 millimeter zone was the most accurate to the actual postoperative refractive error that was found. So in any disease where the posterior cornea is involved, the equivalent K reading with the currently available formulas, the EKR 4 or 4.5 millimeter values gave the best results. Now extrapolate why we cannot use it for untreated corneas or the naive corneas. So in this study, where it was a non-randomized prospective study, 45 normal eyes for cataract surgery, again, different zones of EKR values were compared to IOL Master 500 keratometry. Here, Holiday 2 and SRKT formulae were used. Mean absolute error was lowest for IOL Master keratometry, and next it was to 4.5 millimeter zone keratometry for Holiday 2. So in case we have to use this for any of untreated corneas, the 4.5 millimeter zone keratometry values gave the best outcome when combined with Holiday 2. Similar thing when it was compared to SRKT formula, the 4.5 millimeter zone gave the least predicted error as compared to 2 and 3 millimeter EKR value. However, the best outcome was always with IOL Master keratometry. So in untreated corneas, the EKR values were inferior or slightly non-comparable compared to that of the Placido disc-based topographer. Now, extrapolating the same to irregular corneas, we do not have any literature which spoke about irregular corneas, but at our center, we have been using EKR as a tool to decide toric or non-toric in cases of irregular corneas. Like this is a case example of a pellucid marginal degeneration, where we can see that the anterior cornea shows astigmatism of 8.4 diameter. When we did EKR mapping, first to look for regularity of the cornea. So if you see the amount of astigmatism and first the axis in each zone, sparing the 1 millimeter zone, the axis in 2, 3, 4 and 4.5 millimeter is fairly close to 4 to 5 diopters, 4 to 5 degrees, sorry. And when you look at the amount of astigmatism from 2 to 4.5 millimeter zone, it ranges between 5 to 6 millimeters. Now the pupil measured here was 2.4. Now, considering the fact that this is slightly smaller than the patient's mesopic pupil, we decided to treat the 3 millimeter zone with toric IOL. When we use these keratometry values for calculation of toricity, we need to remember the fact that it has taken into account the posterior cornea already. So the posterior corneal astigmatism has to be, should not be checked, and that should not be considered in your calculator. Now, giving another example, this is a case of post-LASIK ectasia, the left eye of the patient after stabilization when it came for cataract surgery. The anterior surface here showed astigmatism of 3.8 diopters. When we look for the EKR value, if we look for the axis till the 4.5 millimeter zone, the variation in axis is less than 10 degrees and the amount of astigmatism is fairly similar. So this patient is a good candidate for toric IOL during cataract surgery, and the EKR values from the 4.5 millimeter zone could be used. The other eye of the same patient showed astigmatism of 5.5 diopter on the anterior surface, but when we checked in different zones and taking into account the posterior cornea, the astigmatism had disappeared. So this is one of the cases of irregular cornea where it is good to go ahead with monofocal IOL. This EKR map has been used for calculation, or rather the keratometry from it we have been using also for ICL calculation in keratoconic eyes, where the ICL is done for visual rehabilitation. So to summarize, equivalent K reading is one of the important tools for a refractive cataract surgeon. It was designed mainly for post-refractive surgery or treated corneas where the ratio between anterior and posterior surface changes. It can also be used in ectasias and irregular corneas because here again the same principle is there. With the availability of newer formulae where the effect of the cornea is negated or the effective lens position is not taken, or those formulas which consider the total corneal power, and Barrett where we can use the total keratometry derived from IOL master, maybe its effect is not that valid, but still for those where the newer formulas are not available, EKR can be used, but then the optical constant optimization is needed to achieve the best results. Thank you.
I have a question, Lucy.
Yes, ma'am.
The EKR does not take corneal thickness into account, right?
Yes, ma'am. It doesn't take thickness into account.
So isn't that a source of, could be a source of error?
Ma'am, because it is based on Snell's law of refraction and the two values are computed together. So whatever be the thickness, the power which is calculated for the anterior and the posterior surface, they are independent of the corneal thickness per se.
Yes, but that ignores the passage of light through a medium of a different refractive index, and that may vary depending on the thickness of the cornea, right?
Yes, ma'am. But because it gives us in different zones, we can have individual value in the places where the thickness is more and where the thickness is less. So that way it will help us judge whether the cornea is the same throughout or is it varying.
Okay, thank you, Lucy. That was really excellent.
Yeah, Lucy, wonderful presentation.
Thank you,
Dr. Tityal here. As far as refractive, post-refractive surgery patients are concerned, if you use the newer generation formulas, especially Barrett's TK with IL master 700, I'm sure there may not be a comparative study yet, but this is a good option for our patients with post-refractive surgery patients. But I'm pretty sure with
Yes,
ectasia
sir. Since it was
keratoconus,
introduced.
yeah,
Yes, sir.
ectasia keratoconus patients, I think EKR is a better parameter to calculate the IOL power. Correctly said. Yeah, you're saying something?
Yes, sir. At our center, we have been using this map for almost a decade now, and it has been giving good results. When I did literature search, I didn't really find studies, so probably it's time for us to go back in our data and publish it.
Yeah, I think you can also compare with this new Barrett's TK
Yes, sir.
for post-refractive patients,
Yes, sir.
post-laser refractive patients. Yeah, good one. Very nice.
Thank you, sir.
Okay, we can shift to Dr. Bhavekar.
Yes, sir.
Yeah.
I hope you can see my screen.
Yes, yes.
So good evening, everybody, and thank you, Professor Rohit Shetty, for giving me this opportunity. I'm going to talk on posterior corneal astigmatism in cataract surgery. Acknowledgements, Dr. Saurav Sahni, who has been my partner in crime. So when we are measuring the corneal power, what are the difficulties? First of all, 10% of the errors which are caused in estimation of the IOL power are because of corneal power problems. So ideally, we should be subtracting the posterior corneal power from the anterior, but measuring the posterior cornea is difficult because there is a very small difference between the refractive index of the cornea and the aqueous, and there is no gold standard to compare with. So we go to the second best method, that is extrapolation. In that, we use a PA ratio, that is a posterior curvature to the anterior corneal curvature ratio of 82%. Okay, and so from anterior we derive the posterior corneal power. But for this, we have to change the refractive index of the cornea to 1.3375. And to compensate for this error, we have to introduce A constant and regression analysis and optimization at an individual level. But this PA ratio is not constant. There are so many studies which show that this PA ratio, the mean may be 0.882 or 0.816, but it is goes haywire in many cases. And I'm not talking about post-refractive cases where definitely it is different, but there are many outliers in normal population, and it can cause a refractive surprise of around 0.5 in IOL power. So this was okay once upon a time when we were happy with plus or minus 1 residual spherical power error. But today's world, when we are thinking of 0.5 or less, this is not good enough. So what do? Estimating the PC power is the alternative. So these are the four things we can do. Number one, extrapolate with a fixed ratio and regression, which we already spoken about, and their limitations. Second is improvise algorithm for estimation of the PC power and regression, and also using regression that is done by Graham Barrett. And we know how accurate this is. So there was a significant jump over there in the our estimation. Then third is the directly measure posterior cornea, and fourth is artificial intelligence. Artificial intelligence right now we are restricted to spherical power only, and we are talking about the astigmatism. So estimating posterior corneal astigmatism, additional difficulties. It was work of Douglas Koch in December 2012 when it was realized that while doing toric calculations, we are ignoring the posterior corneal astigmatism, and 87% of the population has ATR on the posterior cornea, and the mean magnitude being 0.5. Further studies proved that the mean magnitude was slightly less, 0.37, and there was further classification. 96% of the WTR anterior patient have ATR on the posterior surface, and 74% of the ATR anterior have ATR on the posterior surface, and so on. It was also noted that unlike ACA, PCA does not change with age. Our own work showed that there is a direct correlation between magnitude of the WTR anterior astigmatism to the posterior corneal astigmatism. But when it comes to ATR cases, the magnitude was only between 0.2 to 0.25. So the first step in correcting was Baylor nomogram, where he subtracted a fixed value from the WTR anterior and added a fixed value to the anterior ATR and astigmatism to correct this. However, Abulafia came with a better nomogram where they extrapolated the corneal power on X and Y meridian and for different classes of patients, depending upon what type of astigmatism the anterior cornea has. And then came Barrett. We are all aware how accurate it has been, and it has changed the world. And our accuracy in getting toric patients bang on target has gone up to 80%. Okay, so up till now, whatever we have covered, including Barrett, we call this as extrapolation method. But these methods have reached their limit because there are some cases where it is not ATR on the posterior surface, and they would defy the Barrett nomogram. In addition, Barrett assumes that the PCA axis to be 90 degrees, and now we know by many readings that it is not 90, but it can be slightly, somewhere between 70 to 110, and it will exert a different effect. Estimation of the posterior corneal astigmatism is non-existent in abnormal corneas, the lecture nicely taken by the previous speaker. So for directly measuring the posterior cornea, these are the methods. But the only two promising have been Pentacam and IOLmaster. Now, both of them, they estimate the anterior cornea and corneal thickness, and then therefore derive the posterior corneal curvature. However, Swepsor Society is definitely more accurate than Pentacam. I will skip this slide and save time because Dr. Lucy has covered them quite nicely, okay, regarding Pentacam. Okay, so PCA on Pentacam is studied either on elevation back or refractive 4 maps. And for LRI, Pentacam is useful because it gives you pachymetry at each and every point where you want to do LRI, and we can incorporate posterior corneal astigmatism in LRI. Now, this is an example of a patient with multiple scars, and luckily the refraction and all the 3 machines showed almost identical cylinder. And the posterior corneal astigmatism was 1.2 at 95 degrees. So we went ahead with a Barrett TK-leg formula where we found out the vector summation, by vector summation, the net corneal astigmatism. This is the Pentacam map of that patient. And this patient required combination, the T9 highest possible lens, non-customized, along with a pair of LRI. And the patient had 1.5, I'm talking to the right eye, 1.5 diopter cylinder residual. Now, considering the complexity of the case, this is a good result. We come back to the old previous slide that is directly measuring the PC. And here now we are talking about the new kid on the block, IOLmaster Barrett TK. TK stands for total keratometry. So it is a vector summation of actually measured ACA and measured PCA rather than estimated PCA. And it has shown improvement in the results. There are different papers which show different percentage, but approximately 13 to 14% improvement is there. In prediction error, if you see this box plot, you can see the last belongs to Barrett TK. The outliers have decreased and the quartiles have become somewhat compact. If you see absolute error, the first is the Barrett TK. Again, the same observation that it has become a compact thing. And if you see the percentages, for the first time, Barrett TK is giving us residual refraction within 0.25 in more than 50% of the cases, which has not been achieved up till now. But that is not the true story. There are instances where Barrett Universal 2 and Barrett Toric holds the fort, and the jury is still out. We are not sure which one to use, so we have to be cautious before fully shifting to Barrett TK. This is one example in our clinic where the Barrett nomogram showed an astigmatism of net astigmatism of 0.8, and Pentacam showed a net astigmatism of 0.6, and Barrett TK showed a net astigmatism of 0.4, and we did not intervene from astigmatism point of view, and patient had a residual no astigmatism. Now, Zeiss has come up with central topography, 3 mm cornea topography is done, which is supposed to improve the accuracy of the posterior corneal astigmatism. But we do not know yet the results. Thank you very much.
I think that was an excellent presentation. And there were some questions related to TCAT. I think Dr. Gitansha has already answered on the chat box. And now I think if there are no questions, the next talk can be taken up.
I would like to ask a question about TCAT, if that's okay.
Yeah.
So depending on whether it's a centered cone or a decentered cone, you would also be inducing some hyperopia or myopia when you do a topoguided treatment. So would you like to take that into account if you have pachymetry available, or would you just focus on the cylinder in that case?
Gitansha, are you there?
Yeah, if Dr. Gitansha is not there, see, it has to be taken into account. If you're doing C3R, it induces around 0.75 diopters of hypermetropic shift. So you undercorrect the myopia by around 0.75. And if there is hypermetropia, you have to treat it completely because that would actually decrease the central ablation and may give you slightly more ablation for cylindrical correction. That point was covered by her in the lecture.
Okay, but would you focus more on this because because you would want to correct 80% of the cylinder, right? So would that be more of a focus than the induced refractive error? Because the goal here is not really to get the refractive error.
Yeah, see, basically now, if we do only C3R, sometimes the patient is 618, 612 partial, or even 624. With C3R and topo-guided PRK combined, patient many times improve to 6.6. That itself is a gift. And then whatever refraction is left behind, it just does not matter. They're very happy with that. So whatever glasses they're willing to wear, as long as they can see better.
Yeah. Okay. Thank you.
So we go to the next speaker. Yeah, I'm sorry. You wanted to say something?
No, it's okay. I wanted to call Himanshu to give his.
Okay.
Yeah.
Yeah, I'm.
Yes. So, Dr. Himanshu, please start your talk on IPL and IPCL planning.
Okay. So, thank you, everybody. Thank you, Rohit, for giving me a talk in this wonderful conference. My talk is quite different, and he told me to talk on Pentacam for phakic, and I was wondering what am I going to talk. But then I realized that there are many things which we can take up, and I have kept this presentation more of a problem-based learning. So it's a case-based scenarios where I'm not going to talk much about the detail of theories and everything. I do not have any financial disclosure here. Basically, when we talk about phakic oil, we are essentially referring to ICL and IPCL, ciliary sulcus fitted IOL currently. And I do not have any financial disclosure with either of them. So the question arises, why do we need topography before phakic IOL? I mean, it's not mandatory. They don't tell us to do that. So let's see one example. A young male with compound myopic astigmatism who has come for the phakic IOL, and everything was fine except the left eye vision, best corrected vision was not 6/6. And when we look at the Pentacam of this gentleman, you realize that there's significant asymmetry on the corneal curvature in the central visual axis area. Now, this is not the best thing. Without topography, you would seldom be able to pick up this kind of asymmetry. Now, what happens that whenever we do either say keratometry or anything, we just average out the meridians, and finally we end up actually averaging out everything. So in absence of any topographic instrument, you would not be able to see the asymmetry on surface. And if you do not pay attention to this thing, your visual outcome may not be the best, because this person, you're just going to treat the lower order aberration, sphere and cylinder. And this asymmetry is going to be quite glaring, and patient might have severe ghosting. So rather than just phakic directly, I might want to resurface the cornea first and then think of phakic. So corneal topographer, whatever you have, would be must before I go ahead with any phakic oil. The second question is, why do we need tomographer or elevation-based topographer? Let's see another case. Now, another gentleman, this time mixed astigmatism, has turned up with a report which is a placidus-based topographer eye trace report, and which essentially says it is normal, and the previous clinician had taken a central pachymetry value and which ultrasound pachymetry value, and which showed that 500 micron in right eye and 510 micron in left eye, which if you look at both of these things, well, they would look normal, and essentially you can think of going it with refractive surgery. If you look at the pattern, well, this pattern seems to be with the rule astigmatism pattern, and I would be quite okay with that. However, can we go ahead with LASIK here? And when we did a Pentacam, we realized that the thinnest point, unfortunately, wasn't in the central part of the cornea, and hence the person who had taken the central pachymetry wasn't the thinnest pachymetry, and the thinnest pachymetry was 475 micron. And in such kind of cases, I would not be very keen on doing laser refractive surgery. And in such cases, I would rather go ahead with a phakic IOL. And hence, such kind of cases where there can be changes on the posterior surface, or the thinnest point may not be in the center part, your elevation-based tomographer or your Pentacam kind of devices can actually pick up these things, and they can be better than your placidus-based topographer. The question arises now, yes, we agree that elevation-based topographer can be better than the placidus-based topographer. Now, question arises, there are many of them, and why we talk about Pentacam alone? Well, let's take one more case. This time a young lady who was interested in LASIK turns up with a refractive error of 6.5 diopter, not much of a significant history. Both the eye maps look pretty decent, except a small posterior elevation, which may not be as significant. But having said that, previous speaker did speak about those things. We'll come to that. But one side of my brain said that, well, go ahead. It's fine. Yeah, Pentacam normal, good pachymetry, robust thickness, best corrected vision, 6.5, only sphere. Why should we worry? Whereas the other part of my brain said, can we miss something on a Scheimpflug-based topography also? And then the answer is that if we look at the Belen-Ambrosio enhanced ectasia or exclusion map, we see that there is a possibility of a small hidden cone on or the posterior elevation of formophrastic keratoconus in such case. And I won't be very keen on any weakening procedure, and I would rather look at something which possibly gives me a little more stable cornea, such as phakic IOL. So if I have a elevation-based topographer such as Pentacam, in such kind of cases, I may actually end up choosing proper case for my phakic IOL. So I would say probably this would be something which I would keep in mind. The next question, how do we use Pentacam for phakic IOLs? Now, practically speaking, whenever we talk about phakic IOL, the most important outcome measure where what we look at in phakic IOL is what? The vault we know is nothing but the gap between posterior surface of the lens and the anterior surface of the crystalline lens. And the vault, ideal vault has to be from 250 micron to around 750, 800 micron. If the vault is very high, there can be pigment dispersion, angle closure, endothelial damage. If the vault is very low, there can be chance of cataractogenesis or rotational instability of the lens. When do we accurately estimate the vault? Well, post-operatively, it depends upon the method you have taken. I prefer hydroinsertion, where I insert my lens under saline. Again, there's nothing right and wrong here. Whatever works in your hand. I do not want to say that hydroinsertion is the only way or that's the best way. Whatever works in your hand, it's fine. Now, with hydroinsertion, because there's no visco behind or in front of the lens, the vault becomes more reliable pretty immediately. Whereas in case of visco insertion, if the residual visco is in front of the lens, the vault can be falsely low. If it's behind the lens, vault can be falsely high. So depending upon what kind of method you have chosen, you can have an idea about the vault. And when come back to Pentacam, though Pentacam can actually show you the vault. In fact, this was the first diagnostic device which showed us the vault, and this is how we used to measure the vault. As you can see, a low vault here, but later on when anti-segment OCT came, it became much better way of measuring the vault. But having said that, Pentacam can still give you a vault where you can get a fair idea about the vault. The parameters required for phakic IOLs for the sizing, most important parameters are AC depth and horizontal white to white. Now, anterior chamber depth can be measured using different devices, from contact devices like A-scan, ultrasound A-scan, or UBM, or optical devices like optical biometers, or tomographers such as Pentacam. We prefer to measure it from endothelium to the anterior surface. You can also use anterior segment OCT, but Pentacam does work very well. The important part, apart from the anterior chamber depth, is the iris topography, what we can get on Pentacam. So we can see iris configuration, whether iris configuration is convex, flat, concave, whatever way, and that's equally important, just not just the center anterior chamber depth. The second parameter, white to white measurement, ideally is supposed to be measured using a digital caliper in supine position, in patient in supine position, and under surgical microscope from mid-limbus to another side of mid-limbus. I always would suggest that we use two devices to confirm that one digital caliper, which I use as a confirmatory device, and primary measurement I take from an optical device, which can be anything. It can be your topographers like OpScan, IOL Master, or my preferred method would be Pentacam. Now, please remember, the measurement taken from different devices can have significant variability. As you can see from here, my own right eye measured on different devices has significant variability. So you cannot keep interchanging the devices and then probably try to assume the correlation between them. It does not happen. But the interesting part about Pentacam, why I love to use Pentacam here, is that what I prefer is the direct measurement, what I personally take, where I take the horizontal Scheimpflug image, I do the image inversion, I take my digital caliper, measure the horizontal white to white there, which is like essentially measuring on a patient. This thing which I get, I feed it on my digital caliper and then put the patient on a slit lamp or a surgical microscope and confirm. Now, this way, it's more reliable and it's not first Perkins based image measurement, which normally most of the instrument take. So as you can see here, this is the direct image of Scheimpflug, then image inversion. I take that measurement, feed it on my digital caliper, and I just confirm that am I accurate or not? And this gives me pretty accurate white-to-white measurement, or more repeatable white-to-white measurement, rather than taking an advantage of first Perkins image-based measurement, what most of the intuitive measurement are given by instruments. Why Pentacam for phakic oil and keratoconus? Now, when we talk about keratoconus and phakic oil, we usually agree that it should be reserved for the visual rehabilitation purpose. Very useful for keratoconus with action myopia or significant myopia, best suitable for central cones. Now, when we talk about such kind of thing, let's see one example here. A young male with significant myopia and keratoconus underwent cross-linking and had a decent vision. And I promised him that we will definitely do a phakic oil. I did an ICL, and post-op outcome was exhilarating, 6/9 vision, and I was very happy. Unfortunately, patient was not, because patient had uniocular diplopia, or ghosting. The reason was patient had a decentered cone. So I treated the lower order aberration sphere and cylinder, but the comma part, which was induced by decentered cone, was right there. And in fact, when I treated the higher order aberration, the comma became so enhanced that patient was not happy, and I had to go ahead with the second procedure of topo-guided treatment on top of that. So topography is must before doing a phakic IOL. Now, let's take the second example here. One more patient of mine, again, a lady who had come to me for treatment. When I saw this cone on Pentacam, and I was like really excited that a central juicy cone, and I would be really happy to do the treatment, because even the AC depth was like 3.2 millimeter internal depth. So I said, don't worry, we'll do cross-linking and followed by a phakic IOL. I promised her that, but later on when I realized that after the treatment, when I looked at the topographic axis, which was 70-degree steep meridian, and there's no doubt about this thing. But when my optometrist gave me the refraction, he said the steep axis is 20-degree. There's a 50-degree difference between both of them. And I tried myself, but patient would not accept it. Now look at this thing. Intuitively, it looks patient cannot have any other axis but the steep axis at 70, but subject to acceptance was totally different. As we treat subject to acceptance with phakic IOL, ideally we have to go ahead with the refraction. But looking at this cornea, I seriously cannot accept that the refraction can be like this thing. And ultimately, I decided possibly this was not the best case suitable for my phakic IOL. So when in doubt, please avoid it. And this is what was the advantage of using a Pentacam or a topographer. Many times in keratoconus cases, the central anterior chamber depth what we can get can be falsely high, because the cone which is there in the center part actually mimics a high anterior chamber depth, and which is possibly a false anterior chamber depth. So when we do phakic IOL there, we may end up in crowding of the angle and high vault. So be aware that whenever you do such kind of cases, look at the Pentacam and look at the peripheral AC depth and overall view of the anterior chamber. So to summarize, why I prefer Pentacam for phakic IOLs: one, to assess the topographic irregularity in these cases. Second, to rule out any early keratoconus, or to avoid any laser refractive surgery, where I can rather do such cases as phakic IOL and not laser refractive surgery. For the pre-op sizing, I prefer anterior chamber depth on Pentacam, and also would prefer to look at the iris configuration. White-to-white measurement I would prefer on Pentacam, especially using the digital caliper there on image inversion, and post-operatively can be used to assess the vault. Thank you very much.
Yeah, thank you, Himanshu. Quite an elaborate talk on Pentacam use in a phakic IOLs. Now we invite Dr. Gaurav to make his presentation.
Thank you, Tityal sir. And I think Himanshu's covered it so well. I'll try to stick to just a few things that I thought might be useful. And I would like to congratulate KLB Instruments for organizing such a wonderful webinar. They've been a big supporter for Pentacam for so many years, and especially Rohit for making it so interesting for all of us. So I hope my screen is now visible.
Yeah, it's there.
Thank you, sir. So I think, when I came to know that Himanshu is speaking just before me, and I know that he does such a great job, I said, I'll have to just stick to a few things. So we all understand that, when we do a refractive surgery workup, we do, measure on many devices, as Dr. Namrata also mentioned that, and Dr. Tityal sir and everybody else, that don't rely on just one device or just one map. And I, really go crazy when people come with that one printout of a Pentacam saying that, sir, this is my report. It's like seeing a ultrasound B scan report of one printout and trying to comment on that. I always end up telling them that I'll have to repeat it. Sometimes we do it free of cost because patient has just got it done 2 days before somewhere else and come up with a print. So I think that point was well taken home. So the Pentacam, in addition to many other devices that we use for refractive surgery workups, can give you a lot of interesting stuff here. And of course, we've gone through all of them. When it comes to phakic lenses, what Himanshu tried to tell was that sizing is the thing that actually interests us the most. So the vault and the sizing, these are the two things which would interest us most when we are looking at all these devices. And when we are doing a preoperative planning, amongst all the other things, I think the wide to wide, the pachymetry and the AC depth, these come into the domain of instruments like the Pentacam and the others like the OBSCAN, the OCT and the UBM and so many others. And then we can also do the STS. So there's been, ever since I started doing ICLs, maybe 15, 16 years back, we've had, gone back and forth for sulcus to sulcus and then to the white to white and then the other things. And, after everything, I think we are still back to the white to white and, it still seems to work the best. But then how do you measure the white to white and the AC depth predictably? Pentacam, I think, as Himanshu showed, does a great job. I have a few other things to share. Of course, we all know what is the ideal vault, and we are all aiming for the ideal vault, and then we do have the range in which it can still work. So all that can be judged better using the, Pentacam has been very useful. And in fact, the day a Pentacam Pro breaks down, Divakar gets a call from me. I cannot even work for a day without the Pentacam in my refractive surgery workup of patients. So let's start with few of the things that, it might immediately show when I look at a patient first, and I've already decided that I'm not doing a LASIK or a SMILE for the patient or even a PRK, and I'm starting to look for ICL. First important thing I purposely put this here is that make sure that you're not reading the external AC depth. By default, sometimes the Pentacam maps tend to give you the external depth unless you go into the settings and set it right. You may be mistaken. Sometimes it'll show you a 3.3 or a 3.4 and you'll be excited. And actually the patient's AC depth might be just 2.8 after subtracting the cornea. So please make sure that this shows internal, and that can be done from the settings. After that, there are other things which you can measure. So I like to also look at the AC depth profile. As Himanshu just mentioned, it may be, one thing in the middle, especially in keratoconus patients or other patients. And I like to, from the drop menu, you can pick up the AC depth profile and look how much it is in the periphery, whether the central depth is the area where it is the most, and any irregularities in the AC depth. You can again, of course, look at the iris configuration, and I won't go into the details there again. Now, another important thing which comes out from the first map when you open the map is something that you can see over here, and I've zoomed it out for you. You can look at the chamber volume, you can look at the angle of the iris, you can look at the pupil diameter, the AC depth. Again, you have to make sure that it's not the external and it's the internal depth that you're measuring. And then here, which was something which has been added recently, was the horizontal white to white, which is automated on the Pentacam now. It wasn't so a few years back. And this again is very, very useful. So I made a short video clip to show you how, I measure it in two ways, and Himanshu showed a beautiful way, which I do as well. And then I also use the iris image option. So you can, from this drop menu here, you can choose the iris image. Now, typically the iris image will show you many things, and you have to switch off a few of them. You can switch off the, central topography in which it shows up in the Pentacam. I don't like to use that. You can switch off the automatic limbus marker as well. I like to see it without. I'll just show you how it works. And you can use the calipers, which are somewhere here, to switch on. And then you can take these manual measurements yourself like this. So it'll tell you whether this is, for example, 11.54. Then you can repeat a couple of measurements. I remove the limbus marks. and then I try to use the white to white. These images are very, very good quality, and these measurements are very, very accurate. We've done a study over the last 2-3 years of about 123 eyes comparing manual measurements, Lenstar measurements, and Pentacam. And frankly, I trust the manual measurements. And then now today, Pentacam and the manual measurements have shown almost complete accuracy, but not so with a few other devices like the eye trace and the Lenstar that we use. Now, this is the other way to look at it. So, on the holiday map, holiday report, you can again have a look there. I'll just pause it here for a moment. And if you look here again, the horizontal white to white is here. So it's in a couple of places, but I always like to cross-check it myself manually. One of the two ways, as Himanshu showed you on that shine plug image, or also on the iris image, you can do it either way that you like and prefer. Now coming to what data, what literature has shown us. So this is a study which showed compared ASOCT for measurement compared with the Pentacam and the UBM. And they were trying to do the measurements pre and post-op for the AC depth, the central ICL measurement, and the vault measurements. And the result, this is how it worked. The ICL depth, the full AC depth, the vault, and the three things were measured on the three devices. And it came up with very good agreement between the three. But the conclusion said that the ASOCT demonstrated significantly higher value, while Pentacam showed a significantly lower value than the UBM, probably because UBM is done in the lying down position, but they showed very good consistency. So typically the three things have shown excellent consistency, but they cannot be interchanged with each other. They have to be used on their own. So as Himanshu said, and I agree completely, you can measure on 5 devices and they're all pretty good, but rely only on one of them to actually do your decisions and don't keep interchanging them. So one or two more studies and then we'll call it a day for this talk today. Another study which compared the discrepancy in the horizontal white to white measurements using calipers versus the Pentacam, and it compared the accuracy and found a strong correlation between both methods regarding all parameters. Again, you can't interchange them completely, but whatever you're going with is what you should be using. But there is very good consistency between the consistency. And then again, another study which compared interchangeability for two parameters, the AC depth and the white to white between the IOLMaster, the Pentacam, and a few other devices, and we'll restrict ourselves to the IOLMaster, the Pentacam, and the OpScan. So it concluded that you can interchange the Pentacam HR, the OpScan 2, and the IOLMaster 500 readings. Now, I don't like to interchange them, but they are pretty predictable. And for the AC depth, let's just see, this was the comparison. For the AC depth, you can see here that they're pretty good. There's very little difference. But again, when in doubt for an AC depth, please do it with 3 devices. I like to do it with the optical biometer, with the Pentacam, and I try to also do it with the A-scan and then take a decision. Similarly, on the white to white, you can see that there's pretty good consistency between the caliper at 11.77 plus minus 0.3 and the Pentacam at 11.75 plus minus, and the others I typically try to ignore unless I really need it. Now, theoretical interest, you can use for anybody, if he still does the Pentacam, there is a PIOL software on the Pentacam, and that can be used for iris claw lenses. And with that, we do follow up our patients. As Himanshu said, for 15 years, we were following up on the Pentacam, and then last 5-6 years, we do it on the OCT because that tends to give you a little better readings. But if you don't have a good OCT for the AD segment, you can still use the Pentacam and use it very effectively for measuring vaults. We keep measuring vaults on ICL patients on post-ops. They tend to go down over the years, and you have to keep a watch on them. And with that, I'd like to stop here. Thank you. It's invaluable for us. So with that, I think I'll be happy to answer towards the end if anything is there.
Thank you, Gaurav. Nice coverage. I think both of you have done a wonderful presentation on phakic IOLs. We know that Pentacam does have value in workup of these patients, and post-op analysis also can be done very nicely with Pentacam. I think if you have the densitometry with your Pentacam, you can do analysis of your lens also, because if you do a long-term analysis, you can see densitometry of a crystalline lens, which may be also helpful, which is not there with other systems. Yeah. I think there it will have an advantage, But correctly said, it has improved a lot for our phakic IOLs also in recent time, the new softwares. Thank you for both of you. Are we ready with the live presentation?
Yes, so next I would like to, yes, sir.
Yeah, okay.
So next I would like to invite Dr. Sujni Shroff. She's a glaucoma consultant and she extensively works on imaging in glaucoma, and she's going to show us how the Pentacam tool can be useful for glaucoma screening. I'll be doing a live demo and she'll be explaining about the same. Dr. Sujni?
Hello?
Yes, we can hear you, Dr.
Am I audible?
Yes.
Yes.
Basically, I
Thank you,
think
Dr.
we
Rohit,
need
for
to
giving.
show that fast screening. If you can tell us what this fast screening
Yes,
report.
the fast screening.
Yes.
Yes. Can you, Pooja, can you open the fast screening?
Yes, please.
Of the first patient?
Yes, this is the first patient.
Yes. Yeah. Thank you, Dr. Rohit, for giving me this opportunity. So fast screening is a very quick way of gaining an overview of the patient's details. So the patient details are compared to the normative data and it's converted into indices using suitable algorithms. So the black line that we can see at the center represents the patient's values and its position on the gray bar will show the position in comparison to the normal distribution. So the light gray is is 1 standard deviation and the dark gray is 2 standard deviation. In the red-green chart, the green represents the normal distribution and the red the pathological group. The navigation bar at the top leads to the other relevant maps, and if the map is detected to be suspicious, it will indicate the map so that it can be explored further. The lower part of the fast screening map shows whether the corneal elevation data are within normal range or if there's keratoconus and what is the degree. And the cataract grading is also given by the Pentacam nuclear staging. The literature which has been used for these normative data are actually given at the bottom of each graph. As a glaucoma specialist, for us, the three main things that we commonly use is the anterior chamber depth, the anterior chamber volume, the angle, and sometimes the pachymetry. So, Pooja, can you go to the overview map?
Yes.
So,
yes,
as Schlemfler imaging does not directly view the angle, the anterior chamber angle is usually derived by extrapolation. So it's not always reproducible. But the ACV, the anterior chamber volume, has been found in various studies that an ACV of less than 113 is more suggestive of an occludable angle when we compare it to a gonioscopically narrow angles. So the general overview provides a 360-degree Schlemfler image, and we can also enter the, Pooja, can you enter the IOP there? So we can actually enter the tonometrically IOP which we've got, and usually the Dresden formula is used to calculate the corrected IOP. So this is what we generally use when we're seeing for a glaucoma patient. But the fast screening is something which is very important to help us make the patient understand what exactly is the eye condition. So here we have an example of a patient. Pooja, the fast screening of the example, patient 2.
Just give me 1 minute.
So this was a patient. She was a 47-year-old patient who came to us with complaints of decreased vision, pain in the left eye. And on examination, her best corrected visual acuity was 2/60, and her IOP was 30. It was a shallow AC, occludable angle on Schaffer's 1 on gonio, and a cataractous lens. We counseled her for a cataract surgery after adequate IOP control, but the patient was just reluctant to proceed until she could actually compare her eyes to other normal patients. So that's why this fast screening actually helped us a lot in actually showing her that this is what your value is. So her black line shows that all her values, that's the ACV, ACA, and the ACD, were lesser than normal. So that's how we could explain to her that this is how your eye compares to the normative patients, and it would be better for you to undergo the procedure planned. So when we look at the overview map also, we can so we can see that it's a very shallow AC and she has a cataractous lens. So all this actually helped her understand her disease, especially the fast screening. The graphical representation helped her proceed with the plan of treatment. So the ACV, the ACA, and the ACD have been used in many studies in glaucoma of pre and post LPI to study the changes in the anterior chamber. So the fast screening can be one of the first things that we can see to see which map has an abnormality so that we can go directly to that map. Or in our case for glaucoma, we usually look at the first 3 maps in that. Thank you.
Thank you, Rajini. I think there is one question which is not related to this, but I would request Rushad or Lucy or any one of you can answer this. What is this is from Gulam Qureshi. What is the role of art max value in all the surgeries involving the cornea? Vishal, would you like to answer this? Rushad?
So Artmax is one of the parameters that we take into account. It's not specifically got an indication in refractive surgery. It is supposed to be one of the most discriminant variables. So I would again look at it in the context of all the parameters of Pentacam, not go by it as a solo parameter as such. Lucy or Tushar, any comments on that?
Gairek, would you like to add anything?
No, sir. I mean, very well put it was. So, nothing, no more comments regarding that.
Thank you. I think we'll move to the last session on the cases. We'd like to start with Namrata ma'am and invite all the panelists for this session to have this discussion. This is a very short presentation and lots of cases. And this is one of the most interesting part of this meeting is this particular session where you talk about different cases, because this is where we're going to use a lot of our brainstorming here. Dr. Namrata ma'am.
Thank you, Rohit, for making this program so interesting. And thank you, Mr. Devakar from Oculus for organizing this user meet. I would be talking to you about application reliability and limitations of Corvus ST in different clinical scenarios as we have come across them. And much has been said about this, that what indicates a softer cornea and what indicates a stiffer cornea. So this is just to put it all in a nutshell. Now, the first case is a 34-year-old male with keratoconus, and there are 4 maps which are there, which are the refractive maps. So you can see OD is a mild keratoconus, and OS is a severe keratoconus. And if we see the Kmax, the posterior corneal elevation, and the central corneal thickness, the parameters are pointing towards that in the right eyes and as well as in the left eye also. Now, if you look at the biomechanics of this, again, we look at the dynamic corneal response display, and all these parameters, which in mild keratoconus should be increased, which tells you more towards the points towards the softer cornea are here. And here again, in the severe cases, it is there. And if you compare on a numeric to numeric basis, you would find that in severe keratoconus, it is all these parameters are more severely affected as compared to in mild keratoconus. Now, if you look at the CBI, TBI, and the BAD of the same, then the BAD is 5.05 here and BAD is 14 here, which is expected. But look at the CBI and the TBI. TBI here is 1 and TBI here is 1 and CBI here is 1 and CBI here is 0.93. So these kind of don't correlate, and we don't expect them to, because those were probably not, not thought of when they were being looked into, and they were not meant to differentiate. They were not meant for more severe grades of keratoconus, but were meant to differentiate the normals from the mild keratoconus, and that is why this disparity is there. But the only thing is that when collagen cross-linking would become available to even thinner corneas, then probably we would need to revise this concept further. So this is mild and this is severe, and this is just to show the same. And again, if we look at in the mild and the severe ones, again you can see that there is a clear distinction between the corneal deformation in both the types of cases. So Pentacam corvus in keratoconus differentiates well between normal and form-first or subclinical, but does not quantify the biomechanics in keratoconus linearly in severe and more severe cases. And probably we would need to develop parameters on this angle, and may have connotations in future when thinner corneas will be possible to cross-link, because that is the work which is going on in future. Now we see a case of this, case number 2, which is SMILE and 30-year-old male, 4 diopters at 7 months follow-up. And again, if we look at the various parameters here, The CBI is 0.35, which is in the suspect zone. The BAD is normal, the TBI is normal, but CVI after the smile is 0.07, which is also within normal limits. So if we probably saw this, some people may also argue that we should have done a PRK and not a smile. And again, this is, something which needs to be looked at. And if you again compare the parameters pre and post operatively, then some of the parameters have remained the same post operatively and some of the parameters have changed. So again, this is not very linearly reflected the way the surgery has been done. And again, this is just to show the same thing that as far as the biomechanics after smile are concerned, it probably the deflection doesn't change much and remains pretty much the same. So smile results in biomechanical weakening in comparison to pre-op, but post-op SSI is comparable with the normal population. If you see here, the SSI is 1, value is 1 even after a smile procedure. So it, I don't know, like it was being said that we cannot quantify it. Probably 1 is normal and that too for 50-year age group. So we need to even find out the values for younger age group, such as in this case, which was 30 years. Now, if we look at the PRK again, 21-year-old with 2 diopters of astigmatism, which was corrected. And this is at 3 months follow-up. And we see the parameters here again, the biomechanical tomographic assessment post-operatively. Now, CBI is again 0.49 pre-operatively. But if you see the CBI laser LVC, it has come out to be normal. And BAD was 1.39 and TBI was also normal. So again, we need to, we are yet not there. There are many questions which are still unanswered. And this is again a pre and post PRK picture, which again shows that not too much of change has occurred. So in this case, if you look at the SSI pre and post-op is again the same, 1.1. So SSI score is unaltered after surgery. Maybe it is expected, but we don't know if it causes much change or less change. And in the previous case, we saw that after smile also, it was pretty much the same. So the biomechanical parameter is not altered in mild myopic corrections. I think it has a role to play also how much refractive error is being corrected after PRK and after smile. And suspicious CBI may still allow normal biomechanical strength after PRK, as we saw in our case. And PRK does cause minimal alteration in the biomechanics of the cornea. But if you compare PRK and smile, there are a lot of things which we need to look at. De-epithelialization versus the laser and the lamellar dissection. I mean, smile is a visible procedure. It is you can say there's nothing subjective about it. It is objective. You can see the lenticule of the lenticule which is actually coming out, whereas by laser you are kind of vaporizing everything. And then one has to see laser vis-a-vis mechanical separation, how it is going to affect the biomechanics. Now, this is yet another case 4 of LASIK, where 4 diopters of myopia was corrected. And this is the dynamic corneal response of the same pre and the post. And there's a paradoxical increase in the SSI score here. The score before is 1.1 and now it is 1.3. From 1.3, it has, it is 1.3. So really don't know how sometimes even these values behave oddly, or is it the way we capture the images, that is why they are behaving oddly. So you can get aberrant results like this also. Then again, I'm sure it is not meant for this, the biomechanics, but when there's a post-LASIK ectasia such as this and you are doing Intacs and CXL both, then again, you really don't know what to look at, whether to look at the mechanical factor of Intacs or to look at the biomechanical stiffening of collagen cross-linking. And if you see there's no change in SSI at all, if not because of the Intacs, because of the CXL, one would expect some amount of change that should occur. But I think this is again a subset of cases, which has to be looked into. So as clearly as of now, Pentacam Corvus ST probably does not have a role with Intacs, but we need to generate normative data in post-LASIK ectasia, such as in this case, and mechanical effect of Intacs need to be evaluated. And you require an independent quantification when Intacs are combined with C3R. Now this, I wanted to highlight the fact that this is a 10-year-old child with vernal keratoconjunctivitis. And if you look at the CBI, it is 0.47, which is in the area of being suspect. If you look at the BAD, it is 1.45, and TBI is 0.49. So it is a biomechanically weak cornea. Although if you go by the parameters of CBI and TBI, it is a biomechanically weak cornea. But if you look at the Pentacam, of course, is going to be normal. And so in this case, the biomechanical instability is the earliest sign indicator of keratoconus, and we need closer and longer follow-up to detect changes, especially in VKC. And I think Pentacam corvis is something which should be done in these cases. And also, like I said before, in pediatric eyes, again, we need normative data as to what is the biomechanics, and that too in Indian eyes. Now, again, this is a case of keratoconus, again, pediatric, bilateral, so symmetrical that every single parameter in the right and the left eye matched. And if you look at the D value, 6.3, 6.31, also matched, very symmetrical picture. And if you look at the CBI, the BAD, and the TBI, it's exactly the same. There is no difference between the two at all. And again, like I said, we do need to standardize the data in pediatric cases. And SSI index is based on 50-year-old population, and this varies in different age groups. So standardization of the biomechanical parameters is required in different age groups and in different pathology. And this I did out of just curiosity, because I wanted to know what happens in keratoplastic cases. So this is a case of PK in which the Descemet's membrane was involved. So this is suture and tax operated PK. So you can see that the map is quite okay. But in cases where in this case, on the other eye, fellow eye, the sutures were removed and there was some amount of ectasia also present. So you can see that there is, it's an ectatic cornea and operated PK, and sutures intact with operated PK. And if you look at the D value, again, the same thing is reflected. So these are right and left eye of the same patient. And if you look at the CBI, TBI, and the BAD, again, the same thing is being reflected. So we need to see in this, the effect of intacts, all the foreign things that are there in the eye, the effect of sutures, etc. again needs to be, titrated and seen as far as the biomechanics is concerned. Now, this is a case of post-DALC and 5-year follow-up of DALC in keratoconus patient, and just see the SSI is normal. But again, we can probably understand that this is not meant for corneal transplanted eyes. This is only meant for virgin corneas, or corneas which have not been at least transplanted. I shouldn't say virgin corneas, because this can be used for cross-linked and after laser vision correction. So role of SSI would also probably need to be evaluated in different age of donors when you are doing corneal transplantation. And this is again very interesting to show that when you remove the sutures, the SSI has decreased. Just the removal of the sutures has decreased the SSI from 1.3 to 0.9. And again, the role of this needs to be validated, why SSI has decreased. Now, this is again case of LASIK, and as expected, we would expect here the SSI in this case, again, ironically has increased from 1.1 to 1.3. So sometimes these aberrant situations may be there. So to conclude, it probably in major set of cases, or we can say in almost 90% of the data, it differentiates between normal, form first, or subclinical keratoconus, but does not quantify the biomechanics linearly in very severe corneal ectasias. Then the PRK versus SMILE, the debate will still continue, although biomechanically they are said to be more stable than LASIK. And consistency and standardization in values in various refractive procedures, which we are still understanding is there. The presence of intacts, the presence of sutures, etc., again needs to be seen, how that will affect the biomechanics, and maybe we have to combine it with brilliant microscopy or with some other tool. And standard data in Indian population, I think at all age groups is required, and it should come out, and that should be the first thing that should be done. I would like to acknowledge Senior Resident Dr. Rahul Bafna, Dr. Manu Murli, our JR, Mr. Chetan, Ms. Anita Gupta, and Professor J.S. Tityal for this presentation. So thank you very much for your kind attention.
Ma'am, I think a very nice set of cases. I know it has it has multiple permutation and combination of how it is behaving to each thing. One thing I would like to ask you, and I would like to take Dr. Prema's also opinion because she's done work on SSI. If you can look at all those patients where the stress strain index, which should actually come down, which increased in your patient. That means after LASIK or any procedure, it should actually decrease, and it did a paradoxical increase. I would look at the densitometry in these patients. If you go and look at the densitometry in this patient, clinically you may see a normal cornea, but if your densitometry has increased at the interface or someplace, then even though if you have made a LASIK or cut the cornea, the scar would actually increase your strength. So sometimes when I see that, especially in PRK, because your PRK showed that there is a change towards better. I mean, once you burn the cornea, it should be opposite. It's very difficult for it to show a paradoxical increase. And the SSI is not influenced by intraocular pressure and other factors, which could happen when you give steroids and other things in these patients. So looking at their densitometry will probably be very useful in looking at what is really happening and why are they changing for the other side. Dr. Prema, ma'am, would you like to, because it's a very important, very nice cases ma'am showed, which tells about these subtle changes.
Absolutely, Namrata, that was a very interesting set of cases that you showed. And Rohit, I completely agree that if there is a change in densitometry, it could affect it. Whether the scar makes it stiffer or whether the scar introduces artifacts, I do not know. But I would imagine that that is possibly an explanation for the paradoxic change in SSI.
In one of your videos, of your biomechanical videos, the pre and post, there is definitely some reflectivity in your Corvus video. That means that
One of the cases did have, and I completely agree that densitometry is something again which should have been corroborated. But yes, in cases of PRK or SMILE or LASIK, but other surgical procedures, I think we are yet not there as far as the biomechanics is concerned. We are far away from there, and that is something which should be looked at.
that's a very interesting question from one delegate. Does the biomechanical weakness in VKC patient without a topographic evidence of keratoconus call for a vigorous treatment of
Probably doesn't call for a vigorous treatment, but it calls for a very meticulous follow-up of these cases, because before, a lot of VKC patients, and our cohort also, we discussed of about 116 eyes, we found that almost about 60% of those had VKC. So you do require, and in Indian scenario, I think VKC with ectasia is more common than in reported in Western literature. So I think it makes sense that all VKC patients should be very closely follow up, because they tend to get ectasia because of eye rubbing or because of the factors. It requires for treatment in the sense that, of course, they should not be rubbing their eyes, because they would then go from they will cross the border from, say, a form first keratoconus or from subclinical keratoconus into a frank keratoconus. So that way they should be treated and they should be followed up.
no eye rubbing.
No eye rubbing, of course.
And one thing to sum up before we move to the next talk is CBI, TBI, and bad D are cannot always be in sync, because all of them are looking at different parameters of the cornea. The bad D looks at only the tomography, the TBI looks at a part of tomography and a lot of biomechanics, and the CBI is more of the biomechanical assessment. So physiologically, all of them are looking at different parts of it. So it is very, very difficult to pick up which among this will be the most sensitive one. And that is one of the reasons we presented that case where we looked at complete physiological link to this. So until unless we have a huge database of those, it will be very difficult. But at this point of time, BAD-D has been validated very well, and many people have said that. Even Shreyas also beautifully said that TBI would be one of his parameters to look for, but it keeps changing. And now you have an SSI for progression. So this is my take on this, and we'll move to the next speaker, Dr. Kumar Doctor, for his set of cases.
I'm only going to show, first of all, thanks, Rohit, fantastic webinar, and thank everyone from Oculus. I'm going to show only two cases, which I thought was a little interesting. 68-year-old lady presented with diminution of vision, had undergone LASIK 25 years back, with a 6/12 vision in the right eye and 6/9 in the left eye. IOP was normal, cornea was okay, there was a cataract, and the retina was fine. So we did investigations on the Pentacam, we did the IR master, the AL scan, the corneal wavefront, and the video. And if you look at the K reading here, it is 43 and 43.4 and 44. Okay, so if you look at all that, that is all fine. If you want to look at even the anterior elevation, you can see it here, and this is the posterior elevation below. And again, look at the 4 refractive map. Again, here you have the 43 and the 44. And if you see here, it's 43, 44, 44, and 43. So here, the biggest confusion was what did they undergo? And so I also get an IL master done for this patient. Now, if you look at the EKR value at 4.5, as this was discussed initially also, this is what I'm getting. And then the average is 44.60. And here it is between 42 and 45. So before I show you the next slide, let me see what's the next slide. Yes, here again is the anterior sagittal curvature. It's 43, 43, 43. And the total corneal power, total refractive power is 42, 43. And here again, if you look at this aspect, it is the total wavefront analysis of the cornea. So if you see, all that is also quite okay. Now the question here is, can you hear me?
Yes, sir.
Yeah. The question here is, Rohit, what do you think had this patient undergone? I don't want to show you the next slide. What kind of laser surgery must have been done for this patient?
Sorry, what is the EKR value?
44. Hello?
Is it some kind of a central island or something there? Or
yeah, so I was damn confused. I sent for an IOL master because I have a AL scan and I have a lens star. I got one more reading done. Why is my slides hung? 1 minute. I'll have to stop sharing this, I guess.
Or there is some amount of epithelial remodeling in that space. But again, the corneal thickness is not great in that zone. I mean, there is some amount of thickness there.
Yeah.
It could be some epithelial remodeling or some issue with the laser delivery at all.
Yeah. So now this is the EKR, which Namrata ma'am wanted to see, 42, 43. Now I was really confused because then I was not sure. Now this is the right eye. I'm going to show you the left eye, which is a little more clear. But if I did a topo, now this is all Pentacam. So sometimes what I'm trying to give you a take-home message here is, I did an Opticon Keratron Scout. And this gave me a better picture that this was more like a hyperopic LASIK and not a myopic LASIK. Because the side periphery, which I could not find anywhere in the right eye. So this was a confusion in my mind as far as the rest of it goes, that what and how do you calculate? So I'll show you the calculation. Now let's look at the left eye. And if you see, the left eye is 44 and 45. Okay. And again, look here, 44, 45. And here it's a little better. If you see the anterior sagittal curvature is 45, 46, 45, and 43.
Yes,
so
please.
here
See the slides. Seeing the right eye, Kumar. We don't have your left eye. Yeah.
Oh. This is the left eye. You can't see the left eye?
No, its slides is not moving at all.
It is not moving. I think you have to unshare and then share again.
Yeah, that's Is it better?
Yes.
This is the right eye?
Yes.
Okay, so this is the right eye, now the left eye. So the left eye here, if you see the anterior sagittal, it's little better. It's 45 and the periphery is 43 and 42 and 41. So here, yes, it did guide me a little bit towards that, but sometimes these old cases, you can't really see the flap because there's an arcus and it's real confusion. And this is the sagittal, again, if you look at the total corneal curvature, anterior sagittal front. So here the EKR is again at 4.5. If you see, it's between 43 and 47, if you see that. But the topography on the placidos really showed the peripheral ablation. So now let's look at the Pentacam K. We got the 43, 44. The lens star was 43 and 43. The axial length was, of course, 23.96, the IL master and all this. So these are the three readings I got from three different parameters. And now if you do a question is, what are we dealing with? And then, yes, because of the topo, the Placido's disc, I was 100% sure it's an hyperopic LASIK. Of course, the left eye, the Pentacam was a little better in giving out the information. If we really calculated this, I went ahead and did a calculation, and I did a myopic calculation as well as an hyperopic calculation, and we found a difference, okay, between the two. Obviously, the difference is the one diopter. So this is a calculation of hyperopic LASIK. You can see 21.22, and if you do a myopic LASIK calculation, it's 22.32. So there was a one diopter difference that we see between the two. Of course, I calculated on hyperopic LASIK. I went ahead and did a Symphony IOL. This is, and so I put a 21 diopter because it was 21.22, and post-op I got a 6.9 with a +2 at 40 and 6. Now the patient, of course, wanted the other eye and wanted N6 for sure. So here, of course, I knew that it was hyperopic LASIK, so I decided to calculate the other eye again with a hyperopic LASIK. And here I decided to put a Technis multifocal. Okay, although it's a contraindication to put multifocal IOLs when they have undergone hyperopic LASIK. I've done this. I'm sure many of the panelists would have done this, and patients are extremely happy as far as the end result is concerned. Here I decided to put a 21 diopter +4 Technis multifocal. So just to tell you that we can do a mix and match, patient can have undergone, and now we're going to see a series of these patients as time goes by. And I got a patient with a good end result of 6/9 and 6 at 35. I'll show you only one more case. A 45-year-old female, again diminution of vision in the right eye, had undergone RK 20 years back. A lot of 18 cut RK, the 6/18 and 6/12. The left eye was 6/9. There was the RK cut. So this is the topography that can be seen, and you can see this. It's a 39 and 40, so not much of astigmatism. You can see the flattening that has happened in the center, of course, because of the RK. Here, I want only one take-home message that if patients have undergone RK, don't have much astigmatism. You can see again at 0.66 and 0.94, you can see the bottom. And this is the anterior sagittal frontal curvature, 8.4, 7.5. Again, we can see that. This is the other eye. Here, I went ahead, just one more take-home message is that if patients have undergone RK, I have not much experience in putting multifocal IOLs in such cases. I went ahead and I put IHANS IOL. So again, this is the other eye, and this was the calculation. So here I went ahead and put, again, if you do an RK calculation, I did a 25, you saw 25.19. I went ahead and I put a 25.5 Technis IHANS. And this is the other eye, this is the same eye calculation, the sheet which is there, and the other eye calculation. And the other eye was 22.5. There was an actual length difference between the two eyes, and that's the reason why there was a difference. So I got excellent post-op results of 6.9, 6.9 +2, and I had a 1.5, which we all know. So again, here I feel that if the RK is done and patient has compromised cornea, they do extremely well with this IOL. Of course, it's not related to the refractive subject, but this is what I've done, and the patients are extremely happy. I also like to thank Smita and, of course, Rohit and everybody else who have helped me. Thanks, Rohit, once again for letting me in. I'll try to stop sharing this.
Thank you. Can we have the small discussion here? Dr. Somshila ma'am has just joined. I think she was in the OPD today. And would you like to add anything to this case, ma'am?
I just hello, good evening, and I've been enjoying the meeting whenever I get a chance to attend, and I really got a chance to listen to Dr. Namrata's talk, and I think that what she has done is she has managed to put down 5 verticals through which we need to go through, and the patient with PRK, the patient with SMILE, the patient with corneal surgery, or if you're planning for surgery, and the pediatric patients. So each of them, I think that she showed beautifully how to think about what we need to do with the Pentacam Corvus that's come up now. I am sorry I couldn't attend Dr. Kumar Doctor's talk.
Oh, no problem. So anybody else would like to add? Dr. Susan ma'am is here. Would you like to say anything about this case? Two things about, or anybody who was there, because of the delay in the time, a lot of people are joining late. So anybody who can comment on this?
Katyal sir is there. I think he's dealt with such cases, and I don't know whether
Dr. Vavika sir wants to comment. He's
Yeah.
Dr. Vavika, Dr. Lucy.
Yeah, RK corneas are multifocal, and sometimes they do surprisingly well with even monofocal. That means even with monofocal, they have N8, N6 vision, and with multifocal, they do well. The only problem is what is the amount of dysphotopsias they get at night time. So if the aberration profile is good, they actually become a very good case for multifocal or trifocals.
Dr. Lucy, first, do you want to comment on Lucy? Is very good, and Lucy, Dr. Naren, on the first case, what do you think? Do you think you'd have done exactly what Dr. Kumar has done? Do you think you'd have put in a multifocal? Because the only challenge is there is some amount of change there. There's some amount of spherical aberration there because you have a flat cornea and you have a elevated one. You have both a SA and also some amount of coma.
I mean, definitely a wonderful series of cases, sir. And I mean, we really follow the same rule. I think the rule of suitability of multifocal or a trifocal lens absolutely doesn't change. But Eyehance is something a little different lens. It's not a regular monofocal lens. It's got that extended, good intermediate vision also. So even in these cases, it should do well. But definitely in RK patients, I wouldn't put a multifocal or a trifocal lens. Monofocal is perfectly fine.
So if I can add, so in the first case where there was difficulty in diagnosing whether it is hyperopic LASIK or not, if we change the settings in Pentacam, like what you had shown in the map was 8mm scale. So if we go on to 12mm, probably like after having suspicion based on the left eye, if we change the scale for the right eye, probably the hyperopic LASIK path would have been clear. And so in the second case, because it was post-RK calculation, do you prefer to change your target refraction? Because you've put a Eyehance based on the current refraction, especially because it's a 16-cut RK. So expecting the hyperopic shift later on, would you want to give a target refraction more towards myopia?
So I targeted -1.
Okay.
So it will settle down over time, but I've seen that the 16-cut RKs do much better than the 32-cut RKs because there's not so much edema that develops post-op. So the stability comes much faster in the lower cut RKs than the 32-cut RK or something like that. So I had targeted a little more myopia. Anyway, the target, I had put a little more higher diopter than what was necessary anyway.
And also,
yeah, even in these eyes with RK, we know that there is a diurnal fluctuation in the patient's refraction. So that's where I think instead of putting a monofocal, an extended depth of focus lens is to an advantage for this patient, because as the corneal curvature changes from morning till evening because of the desiccation effect on the cornea, so even if there is a slight change in the power and the focal point, the extended depth of focus, the patients will be much more comfortable because they will be able to, utilize that parameter. Multifocals, I wouldn't be too keen on placing where, your cornea is not very regular. But EDOF lenses, I think they may have an advantage over the standard monofocal lenses.
Thank you, sir. We'll move on to the next speaker, Dr. Susan Jacob. She'll show some nice topographic images of keratoconus with
Hi. So thanks. I hope I'm being heard. Yeah, I think so. So,
perfect.
all right. Thanks a lot, Rohit, and everyone from the Oculus team for having invited me here. Great talk so far. I had to leave in between and then I rejoined, so I missed. And I realized that my PowerPoint got shut off, so I was busy scrambling and trying to put it on during Dr. Kumar's talk. I missed most of it. So my talk is on tomographic outcomes of ICRS, and I'm going to be mostly limiting myself to my experience with the CARES, or the corneal allogenic intrastromal ring segments, as I like to call it. I must say that I have a patent pending for these shape segments and the devices and processes, including the refines. So the reason I started this procedure off was because of the complications that are often seen with artificial intrastromal ring segments in terms of mills, necrosis, migrations, and sometimes even infectious keratitis, and a lot of which I am sure as corneal surgeons we've all experienced. This is a double-bladed refine that I had designed and is available with Madhu Surgicals. And here is the stromal tissue that this refine basically cuts. Just to show this procedure in a little bit more detail, that's a donor corneoscleral rim from which you remove all the epithelium and the endothelium. That's those are two circumferentially placed blades, and you take this basically de-epithelialized and de-endothelialized cornea, and you cut this ring of stromal tissue. On the other hand, you could also cut it before you actually remove the endothelium, and then you could use a central part for a penetrating keratoplasty, and then you could use the rings also for cares. So once you've done that, you remove the endothelium, you make sure you remove the endothelium, of course, and then you insert these into femtosecond laser dissected channels. These are the basically the tissue allogenic segments, which can be used beautifully to replace synthetic segments. And you can see that they're relatively easy to insert, unlike what would be thought and expected. And then in cases which are progressing or young patients and other indicated cases, I go ahead and do cross-linking also. Of course, you could also do this as a sequential procedure, one followed by the other. These are some of the post-ops. I always implant it at about 50% depth. Of course, there are lots of things that you can change just as an ICRS to change your effects. Unlike synthetic implants, these which cannot be implanted in very thin or very steep corneas, because you have to have about 400 microns above synthetic implants. These kind of contraindications are not there with CARES. So you could implant it in very advanced cases as well as mild and early cases. So your spectrum of cases for which this is applicable is really much more than in the synthetic implants. And you can also implant larger arc segments or shorter arc segments. So you could also, another use which I've used it for very beautifully is for post intact mills. And what you can see is this is a case where the intact as the overlying stroma has melted. And what I do is I basically remove that intact and put in this care segment. And just for the sake of time, I'm going to just rush through this. Basically, I've put anchoring sutures and bridging sutures, put a little bit of fibrin glue over it, and put a BCL. And that's basically the care segment which has replaced that intact and helps to act as a very beautiful cure for this often faced problem. So you can see this patient has a intact on one side and a cares on the other side. We published this in GRS, and it's been a few years now since I started working on this. Now, just coming to the Pentacam evaluation, it's really very interesting how you can evaluate these patients. This is basically this is a keratometric map, and in this particular patient, just showing you a few examples. Pre-op, he had a vision of 6/36 with a 0.75 and 3.75, 3.5 cylinder improving to 6.9. Post-op came to 6.9. And 6.12 and 6.9 part. And what I did was implant about a 110 arc segment. You can see it's really, Pentacam has beautiful maps by which you can evaluate your results. So you have the difference map, which is a very, very nice way to find out what exactly, what the kind of effect that your segment is going to be having on the cornea. So this is pre-op, the central one is pre-op, the first one is the post-op map, and the last one shows you basically the difference, the A minus B. So you can see how much it has flattened out. The changes in the K1, K2, mean keratometry, astigmatism, and so on and so forth, and also the Q values. You can see in this case, you've got a good overall regularization of the cornea, and also you've got a flattening. So the beautiful effect of these segments is that you've got a flattening in the steepest axis preoperatively, and also you've also got a steepening in the flat area, which leads to the overall regularization of the cornea and an improvement in the vision. So as you saw, from 6/6, the patient improved to 6/9 uncorrected, and all of that is kind of accounted also by the overall regular topography. The chord mu also you can calculate from the pentacam using the X and Y axis, and you can see the chord mu is also improved slightly in this patient. Here are some other maps that you can use to evaluate these patients. This basically is the corneal ring map, which has all these pre-calculated values given in case you're implanting synthetic segments. I don't use that because I'm implanting cares. So I don't go at 70% of minimum thickness or 80% of minimum thickness. I generally implant at 50%. And you can see the coma values and the axis of coma and all these other things. And in this same patient that we just saw, we can see the decrease in the coma from 1.867 to 0.646 in the 5 millimeter zone, and from about 2.6 to about 1.4 in the 6 millimeter zone. So you can see there's a lot of decrease in coma with a slight change in the coma axis as well. And you can also evaluate the Zernike polynomials, and again you can see an overall decrease in the coma from -2 to about 1.36, and better optics thereby. So here's another patient uncorrected of 6/60, and again improved to about 6/9. And this is the segment that has been placed. This is day 1 post-op actually. This patient was already cross-linked, so you can see a little bit of stain there that I had used to mark the side of the segment. And this is a nice software which I use basically, which is from my friend Shady Awad, and he's got this nice corneal analysis software. It lets you calculate the arc, the surface area, and all these other things on all the things that you're doing on the cornea. And here's the pre and post-op of this patient as well, showing you the selectable maps which I've selected, and on this side the post-op map. Again, the difference map, you can see the difference in the K1, K2. We've got a good difference here for about 5 diopters of flattening in the K1, and K2, K mean, and also K max, which shows about 10.7 diopters of flattening. If you come down to the difference map, you can see up to 13 diopters of flattening over here. And you can also see that the steepest areas kind of tend to flatten more. And if you also compare it with the placement of your ring, that's the picture. And again, if you just see that, you'll see that there's a lot of flattening within the ring, and that area of flattening extends upwards. So you can, once you know how this ring changes the cornea, you can actually use it to your advantage and place it where you want it to be placed, and get your results really good. So again, you can see the coma decreased 2.467 to 0.7, and 3.4 to about 0.35 in the 6 millimeter zone. All of these obviously lead up to good visual acuity for the patient post-operatively. And here again, you can see the wavefront error changes. The total RMS has come down dramatically. The lower order aberrations have come down. The HOA RMS has come down. All these values have come down. And if you look here at the coma, it's from 3.407, it's decreased to about 0.177. And these are all nice ways that you can actually analyze these patients. Here's another patient, just some examples which I'm showing you. Again, I've placed an asymmetric segment here, and you can again see that effect of the segment, and also flattening in this area and a steepening in the other area just above that, which leads to this regularization of the cornea. So you can see overall, instead of having highly aberrated values in the center, it's got values that are much closer to each other, and thereby better visual acuity. Again, a drop in the coma from about 3.1 to about 1.4, and 4.0 to about 2.7. The axis has been maintained in this case. And finally, I think this is one more patient which again showed an improvement from 636 to about 612, and also a decrease in the cylinder. You can see a very quiet segment there, and very good regularization of the cornea, as you can see here. Difference maps again shows the difference, and you can also use this other software which is called the GoNutrans to kind of try and calculate where you place your segment and correlate with your pentacam maps. These are other examples. Again, the difference map, you can see the flattening and the steepening in the previously flat area, all of which leads to good post-operative visual acuity. In this particular case, the cylinder dropped from a -7 to a -2.5 post-operatively. And the other eye of the same patient, just to show you how thick segments and thin segments can be used to your advantage to bring about more or less effects. So here you can see the degree of flattening is much more using thicker ones, and here the degree of flattening that you get is much less with thinner ones. So you can use these for all grades of keratoconus. Again, one eye cross-linking with cares done, and one eye pure cross-linking done. You can see not much change in the pure cross-linked eye, but a good effect in the cares with cross-linked eye. And that patient came back again for implanting cares in the post crosslink dye, and again once we did that, that's the scare segment. Now here you can see that that area of flattening. So these are bilateral segments that have been placed. Again, just another example of two segments placed in one eye and only cross-linking done in the other eye, and you can see the very good flattening. So the Pentacam really helps you in evaluating and kind of getting an idea of your results using various different kinds of maps. It's been very helpful. There's another map that I really, another comparison, a way to compare, which I really like. This video was actually sent to me by Jack Parker from US, who's also been doing a lot of cases there of cares. And you can see this is something that's also very easy to explain to the patient as to how this brings about a flattening when you place it in the cornea. Here's an example, pre-op, you can see the much steeper curvature, and post-op the flattening. And this is really a very easy, visually appealing way to explain to the patient. And here in the this map, you can see about almost about 20 diopters, 21 diopters of flattening secondary to the segments. You can have the direct comparison here, and you can you select the axis basically, so that you're selecting at the same axis. And you have the pre and the post, and you can also kind of align it so that it matches at the lens. So you're basically matching the lens pre and post op. That's the contour that's being matched, and so you know how the cornea is changing. And this is just another example of pre and post, and I think I'll come to the end of my presentation with that. Thank you so much.
Dr. Susan, can you go back to the place where you measure the chord mu? It is very important, not only for this. Chord mu is something similar to what you have the angle kappa, if I'm right.
Right. Yeah.
And the chord mu is something. I mean, can you just tell people from? I mean, you get it in the holiday report. I think did you? I think you must have entered it.
I just calculated it. Yeah, I just calculated it. So basically, what you do is you take the x and the y from the pupil center, and you put it into, it's basically just the Pythagoras theorem that's being used to calculate the chord mu. So it's the square root of x square plus y square. And when you put that into the basic, easily available online calculators which are available, you just have to plug in the values and it gives you the result.
But and that here in the Pentacam, but you have to go to the holiday report. I'll try to see if Dr. Pooja can show a live demo of that. A lot of people have been asking about chord mu, because chord mu is something similar to what you have in angle kappa.
Yeah.
So you Pentacam, people have been asking about, can Pentacam give you an angle alpha and kappa? Alpha, no, I think, but the kappa, yes, you can. Or if you're good in mathematics like Dr. Susan, you can do your own calculation.
Can you unshare, Susan?
Yeah, sure.
So I had one question, Susan, for you, and that was that when you're using PMMA in tax, and I've been meaning to ask this earlier also in a webinar, but when you're using biological tissue, if we do intrastromal keratoplasty, we do DSEC, we do DMEC, everything that you place in behind the cornea, inside the cornea, over the cornea, it tends to decrease in thickness over a period of time. Even for our DSEC lenticules, they'll be thicker, and then over a period of time, they'll thin out when you do intrastromal keratoplasties, because the biological tissue tends to get thinner over a period of time. So you showed all the maps. So what would be the follow-up, and for how long does the effect last? And because the thickness of the biological cares is going to vary from time to time. 3 months it will be something else, 6 months it will be something else, 1 year it will be thinner. So do you think that is going to make a difference to the way your Pentacam stabilizes, or your I don't know if you've done any biomechanical studies on this or not?
Yeah, ma'am, no, I have not done any actual biomechanical studies because we don't have the Corvus ST, so that has not been done by us. But in almost all the cases, we combine it with cross-linking. So cross-linking kind of acts to freeze that that shape that we've got in place. Regarding the thinning out of the segments, I'm actually getting the data together now to plot out how it has changed over time. But clinically, when we see the patients coming back, we really don't see that kind of obvious regression in the effect. So the effect does continue to be maintained quite well, and I think probably cross-linking also has a major role to play with that. But what we see is the effect that you get just by adding the cares in the beginning to cross-linking is dramatic. By just a plain cross-linking, you'll not get that kind of effect. So cares helps you get that effect, and then cross-linking kind of freezes it in place, so that effect is maintained with time.
Quick questions for you, Dr. Susan, from 3 people. one from Dr. Supriya Dar, and she says, "Did you see any episodes of graft rejection, and do these people need immunosuppressives for life?"
Yeah, that's a very, very good question. Basically, I put them on steroids just like I put a post-cataract patient. That's all. So it's a very, very low dose of steroids. I give my post-cataract patients for about 6 weeks, and that's what I give for these patients. And I found that really there's no discomfort, there's no kind of overt signs of rejection that are experienced by the patient. And the reasons I can attribute to this is basically it's very, very low amount of tissue that's being transplanted. The amount of tissue, if you compare it with a DALC, is really negligible. And we know that DALC itself is associated with very low levels of rejection. So one is that.
I think to answer that, Susan, more important is the location. Now,
Yeah, exactly. One
it's
is
not
that.
at the limbus; it's in the
Absolutely.
clear cornea. So yeah. So
Second
location
is
is
it's in the correct. Like Namrata ma'am said, it's encased. It's kind of surrounded on all sides by stroma, and it's far from the limbus. There are no sutures there which are going to incite any kind of vascularization. Its keratocyte repopulation happens very quickly from all sides into this small bit of tissue. So all of these factors, I think, we have really not seen any problem cases where these patients come back and we have to deal with them. In the worst case scenario, this is something that I always say, in the worst case scenario, even if it does reject, it really doesn't matter because it's outside the visual axis. So it doesn't matter at all. And these segments, they're not seen outside from externally. You cannot see them in the eye. The patient doesn't look any different. It's only when you put them on the slit lamp that you can actually see them. So really, it makes no difference cosmetically or vision-wise, even if they do reject. But rejection, I have not seen. And as I told, I put them in very low doses of steroids. And no lifetime steroids at all. It's just 1.5 months, 45 days.
Thank you. Thank you. Can we move on to Dr. Kavita? And then I'll ask Dr. Pooja to show how to get the CordMu on Pentacam software. Because this is something which a lot of people is hidden somewhere in one of their huge software values. So at some point of time, she's going to check us.
I can show it now or later after this presentation.
Let Dr. Kavita present.
Okay.
Kavita, I think you're mute. You have to unmute yourself. It was clear, Kavita. I think you just have to, share it again. No problem.
Is it seen now?
Absolutely. Perfect.
Great. Thank you. And thank you so much to Dr. Rohit. My cases, I'm just presenting maybe I think around 4 cases in total. The first category is patients who generally come for a second or third opinion. And some doctors have told them they're fit for LASIK. The others have told them they're not fit. The second is one patient where planned intact in post-LASIK ectasia. And the third is, post C3R, where some post cross-linking, how do we evaluate whether the patient the progression has halted or not. So moving on to the first category, this is a 34-year-old male. He's an architect. He's come for a third opinion. Like I said, the first doctor has told him he's fit for LASIK. In fact, this is very similar to the case that Dr. Ritin had presented earlier. As you can see, if the doctor has seen him only on a topographer, he's going to say that he's fit for LASIK, and this is pretty much what happened with him. And this is the bad, as again, you can see there is a posterior ectasia seen on bad. This is the other eye of the patient. The corneal diameter is lesser. Now, what both the doctors have missed is that this patient had a corneal guttate. So just correlating this case and also going back to Dr. Ritin's case. Now, obviously, in this patient, we are not going to do any refractive surgery. But, I think what we can discuss out here is whether, if we have a similar patient who has no corneal guttate, it happens many times where we see maybe because the corneal diameter is smaller. But if you're getting this posterior ectasia on the bad, do we then go ahead and we get the specular done? And then what is the role of corneal biomechanics in such a patient? I think we've already discussed this. So, Dr. Rohit, should I move on to the next?
I think it's something which is very important here to all of us to discuss is what I have noticed is when you see this kind of, those changes in your endothelium, more than the topography, I have always relied on, even when during the time of the ocular response analyzer, I'm talking about 10, 12 years back, the patients with this changes in your endothelium and who would probably later become a full-blown Fuchs, they always have a poorer biomechanics. And I have treated at least 3 or 4 patients with a near normal topography who developed ectasias over the last 10, 12 years from different places. And all of them had missed out endothelial change. They're not full-blown Fuchs dystrophy, but they're changes. But if you really look at them, I believe that we did a study sometime, we did not publish, but at this point of time, this is a study on ectotal relevance. That biomechanics is very important in them, because if you have a corneal thickness of 600 and you have a poorer biomechanics, that means that these patients would definitely have change for good progress more. So I think this is my personal opinion on this. Like I said, it's not been published, but I would like to take opinion from the rest of them, because poorer biomechanics in Fuchs is very well known.
Oh, if I can just add, Dr. Sanjay Patel has published a paper on how the Pentacam is going to change with Fuchs dystrophy, and he has given, various characteristics, which include that there'll be loss of regular isopax, displacement of the thinnest point of the cornea would occur, presence of posterior surface depression. So I think it's a paper published in ophthalmology, and it's a very nice paper. Just by looking at the Pentacam and looking at these 3 points, and he's done inter-observer and intra-observer, variability also. So you can actually predict the prognosis for Fuchs dystrophy by looking at the Pentacam. So if there is a patient of cornea guttata, and if you do a Pentacam, you can actually see those features here. So Rohit said that biomechanics would be altered in the case of Fuchs, and so much so that this can go and even alter your Pentacam maps. Like I told you, those 3 points for Fuchs dystrophy. So if it becomes a little more severe, then it can even alter your Pentacam maps. Right. And it's a very nice study in which it has been shown that Pentacam gets the maps get altered on.
I have a question for you, ma'am, and this is for Dr. Rajesh Fogla, sir, Somshila Murthy, and all of you. See this kind of endothelial changes, which is, you're not classically labeling it as Fuchs. Would you consider a refractive surgery? And if you consider, what would be your choice? PRK, LASIK, SMILE? Obviously, I don't think anybody would consider an ICL in them. Worry of we don't know how they decompensate later.
If they do have an endothelial pathology, I don't think I will consider a refractive surgery for them. I don't know what Somshila and Rajesh Fogla have to say to it.
This is something that people do ask me, in the sense that if you have somebody with a family history of Fuchs dystrophy, that means the mother or father had Fuchs dystrophy and a corneal decompensation, and they come to you and they have a myopia of 4 diopters, and you do a specular and you find a cell count of 2,800, but you see occasionally 1 or 2 gutted changes, then if you had to do a refractive surgery, I would consider a surface ablation. I wouldn't want to create an interface which would later on, when the cornea decompensates, would give rise to an interface fluid or some other kind of problem. Right. So that is one thing. And the other thing, what Dr. Namrata mentioned about the study from Dr. Sanjay Patel, that's really nice, because sometimes when you see a patient with the guttate changes and you want to make a decision regarding the cataract surgery, if you look at only the anterior corneal topography, you may not see any significant changes, because when the cornea starts becoming thicker, when the endothelial function is reducing, the changes occur more on the posterior curvature. So that's what he had studied on the elevation map, looking at the posterior curvature. He found that you had a depression which is like towards the anterior chamber, and that could be picked up earlier, even before you start seeing changes on the anterior surface. And that would also reflect on the corneal thickness across the cornea, starting from the center. So the isopacks definitely help.
If I can...
Just a quick comment, Dr. Rohit, to add that almost in all endothelial dystrophies, whether it's primary or secondary, so we have noticed changes in PPMD, where the corneas are typically very steep, and everybody in the corneas who do cornea as well as refractive surgery would have seen such cases. And also in Fuchs heterochromic cyclitis, where there's a chronic inflammation. So we've noticed that a lot of these patients have steeper cornea, or they have with the rule astigmatism more than the general population. So these are some interesting findings. It seems like endothelial disease does seem to affect the cornea over a period of time, or maybe evolutionary, both of them might be involved.
Perfect. Can we go to the second case, Kavita?
Yeah, this was a 24-year-old female. She's an ENT surgeon. Again, like, one place she's been told she can go for surgery, the other she's told she's not fit. This was her vision and refraction. This is the right eye, the pentacam values. This is her bad. As you can see, again, the bad shows abnormality. This is her left eye. Left eye, the bad is the normal. Now, this patient had an iris coloboma actually in the right eye. So again, I was wondering whether it's because that the corneal diameter is smaller that the bad shows that posterior ectasia. So in this patient, definitely, I would not do LASIK, but maybe PRK. As such, I have not done anything for her. I've just asked her to wait at present. But if anybody on the panel has a different opinion.
You are worried more for your posterior elevation, is it?
Correct. But which I feel probably, because the other eye does not have it. So I'm really not sure whether that's just because of the smaller corneal diameter, whether PRK maybe is suitable for her.
Oh, but she has a cylinder, -6 sphere and 3 cylinder, no, if I'm not.
Yes, ma'am.
So with -6 sphere and -3 cylinder, PR -2.5 and -3 cylinder. So I think that is something this, if you do a PRK, I think may go into regression.
Yeah.
Especially the cylinder is so high.
Why not ICL for her?
Yeah, exactly. I thought as much.
Ma'am, with the iris coloboma.
Only with the iris coloboma, how would you'll have to get a customized.
I missed that part.
Okay. Yeah. That's the reason I was wondering, and then she's being a surgeon and all of that. So.
Best is not to do anything. She's an ENT surgeon.
Yeah. Right. Okay, so I'm just moving on to the next. This is about planning intacts for post-LASIK ectasia. Sorry, this is a 24-year-old female. It's not a male. She's a housewife. She was underwent cross-linking in both her eyes in 2015. That was elsewhere for post-LASIK ectasia. I saw her in October. She had decreased vision for 6 months. She was advised to repeat cross-linking in the right eye elsewhere. This is her vision. Her best corrected in the right eye was low. It was 618 and this was her refraction. Now this is her pentacam, as you can see. And in fact, I had shared these particular maps with Dr. Rohit also. The corneal pachymetry is around 404, 400, and there is this decentered cone, so to speak. So we decided, to go ahead with intacts. Following this nomogram, we decided to go ahead with a single ring, inferior ring. So initially, in fact, the intacts, people also are quite skeptical because they felt, they're not sure if this is going to improve. But we did go ahead and use an SK ring and a single ring. And I've been seeing her consistently, like last follow-up was on 8th of October. So sorry, it was in August, 10th of August. And she was doing really well. Like her uncorrected vision was 6.9. So, and this was the pachymetry. So I just thought, points to discuss is that, in post-LASIK ectasia, if the corneal thickness is less, decentered cone, poor BCVA, maybe they are good candidates for intacts. And cross-linking, maybe now this lady has already been cross-linked earlier. So I don't know, in this, now I have around 9 months, 8 months follow-up, 9 months follow-up. I think, I don't think as of now she needs cross-linking according to me. But if it was a primary case, then probably, maybe in a month or so, we could have cross-linked.
In fact, intact one indication of intacts which is even today's context, it works very well is post-LASIK ectasia.
Right.
Cornea is so biomechanically weaker, and just the cross-linking sometimes does not work, and because you are only cross-linking the flap and some amount of stroma. So if you add some additional measures like intacts, it works like a double effect. In this case, I think you already cross-linked, so I think it's good, very good results. Single ring does very well in these cases.
Great.
So if at all you had to plan you were thinking of doing a repeat cross-linking, then why not do it at the same time when you're doing the intacts?
Yeah. So this was done by somebody else, I think. They had,
Yes. That was in 2015, ma'am. She was already cross-linked. Then she came to me for another opinion for a cross-linking. At that point, I felt, why not just do an intact first and see. And then since she's doing so well and her uncorrected vision is great, and of course in between we had the lockdown. When I saw her in August, she was absolutely fine. So that's the reason I thought, I really don't feel the need for cross-linking her right now. So next is about, once we've cross-linked a patient, how do we know is the keratoconus progressing or not? Sometimes your patient also goes to someone else and they might tell them that, the cross-linking has failed, you need a repeat cross-linking. So this was a 24-year-old male, he's a corporate professional. Both eyes cross-linking, I did the Cretan protocol in last year, June and July. He was to fly out, so I did both the eyes back-to-back in a month. And then he came back, of course, before lockdown. And recently he had another follow-up, which was local, not with me. And in July, where he was asked to do a repeat cross-linking in the left eye, like that's 1 year post his cross-linking. When I saw him on 5th of October, this was his vision and his refraction, which seemed absolutely fine. This was the pre-C3R values. And again, this is post-C3R. If you see on follow-up, like on September, and this is March, and this is 5th of October, the keratometry, in fact, it has gone down in March and it has stayed stable in the right eye, similar for the pachymetry. Now the left eye, let's look at the left eye where he's being advised to repeat C3R elsewhere. As you can see, it's gone down in March, but here again, it's showing a little bit of, obviously the keratometric value is high, but if you look at the corneal thickness, it looks almost the same. So I really felt that I told the patient he does not need a repeat cross-linking at this point because his refraction is stable, his pachymetry is stable, and I feel that it's always better to observe and wait. So I wanted to maybe to throw this open to the panel as to what they felt or their point of view.
I think when was the C3R done in this patient?
It was a year back, sir. More than a year back, July 2019.
Lot of changes happen in C3R epithelium of the cornea. I think fluctuations in curvature happens because of epithelium. So I think till 2-3 years, lot of changes can happen, and it's just not. I don't think we should call it a failure till 2 years. So I think you shouldn't be even bothered about it.
Yeah.
Dr. Somshila, Dr. Fogla, you want to take anything on this? Because people keep asking, when do you call it as a success and when do you call it as a failure, irrespective of what topographies we use?
So very good cases, Kavita, very interesting. The last case, I think that it's too short term as exactly as we decided, better to observe, and there would be fluctuations, as Dr. Rohit said, could be due to the epithelial remodeling that keeps happening, continues to happen for at least some years. So we wouldn't call it a failure, especially in these situations.
How long, sorry to interrupt, how long would one recommend waiting? So I think around 2 to 3 years after that, if you're seeing that, there is thinning along with a curvature change, how would you then label that as a failure of cross-linking? And when would you repeat a cross-linking? I think I have repeated cross-linking in children, but not so much in adults. So I just wanted to know what the other panelists.
Sometimes you call them back again after 2-3 months and you repeat it. You see that it looks different from the previous map. So I generally don't decide, though I may have been following up the patient, but if there's a change within 2 years or 1 year, when I don't expect it to have changed and I see that there is a slight difference, so I just wait on that, call them back again for a couple of months later, 2-3 months, and you see that it might go back to the previous. It doesn't really appear to have become worse. So I would still wait. But yes, 2 years out and consistently showing this change, consistently in the sense, not consistently thinning down, but showing that change, then yes, that's a time to probably consider if it's still possible.
And also maybe the refraction, that also could be an indicator. He was absolutely comfortable with his vision, and I'm not sure if that's an indicator.
One of the things, one of the signs in Pentacam, which is very important to look for stability of thing is to look for densitometry maps before you comment on anything on progression or stability. If your densitometry map is not come back to at least 90% of the pre-op level, it will never come back to the pre-op level. because there'll always be haze. To come back to pre-op level, it takes around 3 to 4 years. That's the time the new keratocytes would have completely replenished the older ones, and which would have become myofibroblasts because of your cross-linking. So if you want to look at what is happening, your clue is always in the densitometry maps. If your densitometry maps is still fluctuating, that's what Dr. Pooja showed, that means your maps, keratometry maps, are not reliable at all. None of the topography maps are reliable during haze. The haze can be, you may not even see the haze on your slit lamp, but when you look at the densitometry, it will completely be different. So epithelium and your stromal densitometry play a very important role in your assessment of the outcome of good and bad outcome of cross-linking. So for me to call it failure, it should have progressed by a diopter after the haze has completely gone back to the pre-op level. That means come back to the pre-op level and then it has progressed. That means it will usually take 2 to 3 years. Otherwise, very rarely you see something called as a failure. So many of the failures of cross-linking are actually pseudo failures because our image is not picking up the real picture. Dr. Fogla, sir?
I completely agree in the sense that we should not be in a hurry to label somebody as a failure of cross-linking, especially if the patient has undergone the procedure elsewhere, and if you're looking at a tomography on a different device, sometimes the two different devices, the parameters may not exactly reflect the same measurements. And also after the cross-linking, in the first 3 months, there will be definite lot of changes in terms of thinning, and the cornea may look steeper after the cross-linking. So for me, any kind of measurements are usually taken into account after 3 months following the cross-linking. And also remember that because of the changes in the corneal stroma, the densitometry changes. When you do a tomography, the posterior curvature measurement may not be very accurate, and that can reflect as a abnormal corneal thinning as well. So I usually use the anterior segment OCT pachymetry values to compare what is the actual corneal thickness, because that works on a different principle. And also, if I have to label somebody as a failure in progression, I usually look at my own data set. That means if I have a patient whom I have examined, and then I review the same patient 3 or 6 months later, and I find that the changes are, definitely there is a further steepening, or there is a progressive worsening of the cylinder, and the refraction is also correlating with that, then I think you can label that, okay, there seems to be some progression. But I think just one single measurement and label it as a failure or progression, sometimes it may be a little difficult unless the change is of a very high magnitude.
There are two questions which both questions are linked to each other. Something very interesting. Thinning without progressive flattening, what would you do? Again, thinning on any Pentacam or any devices is very, very unreliable when you have haze. We published this, the repeatability of thickness map is 24 microns compared to 4 microns in a normal eye, in a keratoconic eye. 8 microns in a keratoconic eye, 3 microns in a normal eye, at least 22 microns. That means if you have haze, your cornea artificially looks at 2 times you, and you will have a 22 microns. So 22 microns looks like the cornea is completely thinned out. So actually it is not thinned out, it's actually difference in your repeatability. So that is something we need to be aware of. And are there any factors to predict excessive flattening? On topography, one of the things which we have been seeing that excessive flattening can be seen, which is the indicator when you're using any topography, including Pentacam, is thickness of your cornea. When you have a very thick cornea, you actually see more reaction in them because you have more keratocytes in them. The thinner corneas never ever get haze, even if you treat them with the laser, because there is no keratocytes for them to become scarring. So that is very important factor, because if you are doing a cross-linking on a thicker corneas, you always expect them to have excessive flattening more. The second thing is their exposure to UV light. When you, just like PRKs, cross-link patients also sometimes we never ask them. PRK patients, we ask them about UV light. Sometimes excessive UV light also they expose them to UV light can also have a lot of flattening. These are the two factors which I have seen in my practice, especially to do with the flattening. And can we move to Dr. Vivek? He has some cases. Vivek is a consultant cornea refractive at LV Prasad. And Dr. Vivek, are you ready with your cases?
Yes, Dr. Rohit. Thank you, Dr. Rohit, and thank you all the panelists for sharing the wealth of knowledge with us. So is my screen visible to all?
Absolutely, absolutely. Perfect.
Okay, thank you, sir. So what I'm going to do is, so having discussed about the corneal biomechanics and finding something which was hidden, what I'm going to do is present two cases where something which was very evident was missed, and I'm going to take everyone back to the corneal textbooks. So the case one is a 32-year-old gentleman presented to us in May 2019 with complaints of gradual progressive vision loss. And he gives us an history of undergoing microceratum LASIK 6 years back in 2013. And after 5 years, he also underwent both eyes collagen cross-linking at the same place. Now, when he presented to us, his best corrected visual acuity in the right eye was 20/40 with -3 diopter spherical and -2.5 diopter cylindrical error. The cornea looked absolutely fine. The flap was well opposed. There was no clinical signs of ectasia in the right eye. This was a ASOCT map of the same patient belonging to the right eye. However, the left eye was not absolutely fine. You can see a melt-like picture which is seen inferiorly, and so there's some scar which is visible in the inferior region. And the left eye vision was 20/40 with -3 diopter spherical with -2 diopter cylindrical error. So the ASOCT here shows something which is very hyper-reflective at the interface. If we see the bottom scan, there is a track which is open here, and we can probably see the cells which are seeping in. So probably this was a case of epithelial ingrowth. Probably the trauma happened during the second surgery during collagen cross-linking, or probably it happened during the primer surgery. We are not very sure about that. So we went ahead with the topography for this patient, and the right eye, as you can see, it shows inferior steepening. However, point to note here is the thinnest location is 456 microns. And the left eye also had an identical looking scan. The curvature map shows an inferior steepening and with the thinnest location of about 445 microns. However, this inferior steepening is primarily because of the epithelial ingrowth or the ectasia. We're not very sure about. Now, the patient had only a couple of scans, preoperative scans with him. This was the aberrometer that he had where we could decipher the preoperative refractive error of the patient, which was close to -5.5 spherical equivalent for both the eyes. And luckily for us, he had the topography with him. Now, let us try to elucidate what are the various red flags which are present over here. So it's very important not to jump directly based on the colors. It's always better to look at the scales that the scan has presented here, because each machine and each surgeon will have their own scales. So the foremost red flag sign here is the asymmetric bow tie with inferior steepening. And there's not much of IS asymmetry there, but however, there is skewing of the radial axis, which is around 46 degrees in the right eye. In the left eye, we have that typical crab claw appearance and inferior superior asymmetry about 1.6 diopters, and there is definite skewing of the radial axis about 54 diopter. So these were the possible red flag signs. So we made the diagnosis of both eyes possible LASIK, status post LASIK ectasia. The patient, because patient was already cross-linked, we decided to give him a trial of contact lenses. In another case, a 31-year-old gentleman who complained of blurring of vision in both the eyes since 1 year presented to us in March 2019. He also gave a similar history of undergoing LASIK in 2016 elsewhere. And as per the record, he had a pre-op refractive error of about -5.5 diopter spherical. Now, these are the scans that we, the topography scans that we got after once he reported to us. You can see there is a very irregular looking cornea, the curvature map, and the point to look here is, notice the Paki here is 399 microns here. A similar looking scan in the left eye, irregular scans, inferior steepening, and thinnest location is 340 microns. We do not have a slit lamp picture for this patient, but then a Schimflag image for this patient shows the right eye. The right eye does not show very evident ectasia. He was improving to 20/20 parts with minimal refractive error. But in the left eye, there was definite ectasia, which could be seen in this Schimflag image, and his best corrected visual acuity had dropped down to 20/40 with -2 spherical error and -2.5 diopter cylindrical error. So this was the preoperative scan here. Let's look what are the preoperative risk factors or any red flag signs which the patient has in the right eye. So if you can see, there's hardly any steep points, though the color coding is can be misleading here. The steepest point was close to 45 diopters, and there is hardly any asymmetry between the inferior and superior zone. However, there is the color changes shows there is an asymmetric bow tie appearance. And the thickness was lesser than 500 microns here. The thinnest location here shows 496 microns. For the left eye, almost a similar finding. There is asymmetric bow tie with inferior steepening. The maximum keratometry values is again to the tune of 45 diopters here. The Paki, the thinnest Paki here was 508 microns. So again, we diagnosed this patient as status post LASIK ectasia and left eye more than right eye, and we plan for the left eye collagen cross-linking in view of the advanced nature. The point here to note is that none of the patients we could get the percentage thickness ablation calculated, and even in retrospect, if we look that these patients, just in case if they present to us with the scans that they had, would we really operate on them? The answer would be no. The questions to the panelists would be all the scans, the indices that we have, the like it was pointed in one of the lectures earlier that every investigation modalities, investigative modalities have their own indices, but still we rely on the indices which were set so many years back, and those indices were set on a placebo-based devices. So how relevant do you feel are these indices in the era of Schimflug imaging, and what is individual view on with the various scoring scores which are available to guide us for the preoperative risk ectasia, for the risk for ectasia?
Thank you. I think you can stop sharing this.
Yes.
Very nice cases, Vivek. I think it are all simple cases which each one of us would see in our practice. I would like to ask with Dr. Fogla, sir, do you believe, okay, because each one of us are using different topographers, but let's start with those scoring PTA, Brandelman scores and all that. Do you really believe in it? And if you say that if there is one score which is high, do you really put how much weightage do you give them, basically? You're muted, sir. You have to mute it. Unmute it.
I think because we have been doing refractive surgery for almost more than 2 decades, each of us, I think, have our own way of assessing the preoperative investigations. Although these new parameters are there, which can help you in, kind of evaluating the patient and finding out the risk factors, I think I still go on personal evaluation of all the pre-op investigation. All these scores by themselves, I don't think they are absolute. So you cannot rely just on PTA or on the ectasia risk scoring system, but they can act as a guide to at least highlight that there may be something abnormal. So, but they cannot be used, you cannot depend on them 100%.
Absolutely.
I would still look at the topography, to look at the abnormality in the bow tie pattern, skewing, the radial asymmetry. Then I would look at the thickness, the thinnest point, the displacement from the apex. I would look at the posterior elevation. And all of these have to speak with each other because there are so many false positive and false negative. So unless you qualitatively evaluate the map rather than just looking at some of these parameters, you may be either wrongly screening out a patient where refractive surgery can be performed, or you may go ahead and perform a refractive surgery where you should not have.
Perfect. So can we move to the next case, Dr. Sushmita? Can you share your screen, please? And unmute yourself, please.
Yeah. Good evening, everyone. Are my slides visible?
Absolutely clear. Go ahead.
Thank you so much. I thank Dr. Rohit Shetty for including me in this excellent webinar on Pentacam integration. Slide is not moving.
Click on the slide itself. Last time,
Yes.
Prema ma'am also had the same problem.
Yeah. So this was a 32-year-old lady who was referred to us with complaints of decreased vision in both eyes, and also with a Pentacam map, which my referring colleague felt looked very odd. So when we evaluated her on retinoscopy, we found scissoring reflex in both eyes, and following refraction, her best corrected visual acuity in the right eye was 6.9 and 6 with a correction of 0.5 sphere and minus 5 diopter cylinder, and a very similar refraction in the left eye as well, plano with minus 5 diopter cylinder at 180, improving to 6.9 and 6. Slit lamp evaluation, the right eye, we could see a focal scar involving the superior cornea just abutting the pupil. A very similar scar was also noted in the left eye, slightly in the superior nasal cornea. And when we looked at it with a slit view, we could see a posterior excavation of the posterior slit on the slit lamp, and which was noted in both eyes, and there was overlying scar on the area where the posterior excavation was. Additionally, in the right eye, we could see a focal pigment deposit within that area of posterior excavation. Now, coming to the Pentacam map, I've kind of kept both together because they look very symmetrical. The right eye, as you can see here in the anterior sagittal map, there is like a central stiffening within the central 3 millimeter, and also it's a very similar picture even in the left eye. The central 3 millimeter that does look steep. However, when you look at the elevation maps, sorry. When you look at the elevation maps, we could notice that there is a flattening of the anterior corneal curvature in the area overlying the scar, as we saw on the slit lamp photograph, and the corresponding area there was a steepening of the posterior corneal curvature. And when you look at the difference map, the anterior corneal curvature looks absolutely flat, while there is a steepening of the posterior corneal curvature in the difference map. Again, very similar picture in the left eye. We can see there is a flattening in the superior cornea in the area where the scar was, and correspondingly there is an increased elevation or steepening of the posterior corneal curvature corresponding to the area of the corneal scar. And in the difference map, the anterior surface again looks normal, while the posterior surface we do see some amount of ectasia. Coming to the thickness map, again we see that there is a localized thinning of the cornea in both the eyes, and that thinning area is of course corresponding to the area where the scar was, and it's somewhere around 430 micron, whereas the remaining, the central cornea, looks pretty much of normal thickness. Now, comparing it with the serous, here we see a focal area of thinning superiorly, but the central, the anterior float does look steep centrally, but overlying the area of the scar, there is flattening. The posterior float is definitely steeper, and an exactly similar picture in the other eye. Anterior segment OCT. The area of the pathology shows an increased concavity of the posterior corneal surface with overlying scarring and the pigment nubbing, as we could appreciate on the slit lamp. In both the eyes, the pigment nubbing wasn't there in the left eye, though the corneal scarring and the concavity of the posterior surface was much more in the left eye. To summarize the clinical findings, we have a young female with bilateral focal excavation of the posterior corneal surface, corneal scarring and thinning, and the tomography showing increased stiffening of the posterior corneal curvature with thinning, but no corresponding increase in the stiffening of the overlying anterior corneal surface. So what is this diagnosis? This is a very classical case of bilateral posterior keratoconus, which is a rare non-progressive ectatic disorder of the cornea, which is characterized by increased curvature of the posterior corneal surface. And it has been classified into two types: the generalized posterior keratoconus, where there is increased steepening of the entire posterior corneal surface, and the localized posterior keratoconus, wherein you see focal stiffening of the posterior corneal surface. This is usually congenital, unilateral, and sporadic, although acquired bilateral and familial cases have been reported. Now, the classical slit lamp features include scarring and thinning of the stroma overlying the ectatic area. We could also see endothelial pigment nubbings involving the affected area. And there could also be an epithelial pigment line very similar to the flesher ring as we see in a normal keratoconus. Now, however, the changes here are suggestive of anterior chamber cleavage syndromes and have nothing to do with the conventional keratoconus that we are always discussing. And because it's a developmental disorders, the developmental group usually may have associated ocular and systemic abnormalities. However, since we're discussing curvature maps here, I'm not going to go into details of all that. Now, conventionally, initially, it was thought that because the focal abnormality is in the posterior corneal surface, the anterior corneal surface does not have any associated change. However, that theory was refuted when this was the first paper describing the corneal topography using a Placido-based topographer by Dr. Manis, and he had this case of a bilateral central posterior keratoconus, and he described steepening of the anterior corneal surface overlying the cone, along with flattening of the paracentral and the mid-peripheral cornea. This was followed by this landmark paper by Dr. S.K. Rao sir and Prema Padmanabhan ma'am, in which they proposed an expanded classification scheme of the posterior keratoconus based on Placido disc topography as well as slit lamp evaluation. So they proposed to further classify the localized posterior keratoconus into two groups, the central, paracentral, and the peripheral variety. And they, based on the Placido observation, said that the central paracentral cone is usually associated with increased steepening of the overlying anterior corneal surface, while the peripheral cones are associated with flattening of the overlying anterior corneal surface with relative steepening of the adjoining area. They further said that the generalized posterior keratoconus is usually associated with a generalized steepening of the anterior corneal surface. Now, this was in the pre-Schimflach, pre-OCT era. Let us see what the recent literature has in store for us. So this was a paper of showing a unilateral central posterior keratoconus, the multimodal imaging. The authors have beautifully described. This picture is using the RT view. And they have also commented on the thickness. This is the overall thickness, and you can see that there is a thinning in the central area corresponding to the where the lesion is. They also have commented on the epithelial thickness, and then feel that the epithelium is quite thin in the area there, and they found a lot of difference between the minimum maximum in the epithelial map. However, I could only find this was the only case I could find in the literature, so there's no other thing to compare this with. The Oculus keratograph showed steepening corresponding to the area of the cone, and this was the series of the same image showing steepening both of the anterior as well as the posterior corneal curvature. This was another review article published in the BJO, where they just have one scan and they report that there is severe irregularity of both the anterior and posterior corneal surface. And this is a very recent paper. It's published, it's actually coming in the November issue of Cornea. This again is from JIPMER, India. And they have possibly the largest series of 13 eyes of 12 patients with posterior keratoconus. They do describe the keratometry of all the cases, but it's not really very clear because they've used both the series as well as an autorefractometer, autokeratometer to describe the keratometry. So we're not really very sure whether they have, these are the readings are from the from the keratometer or from the tomographer. However, they say that the presence of iris nubbings, that is pigment nubbings, is quite significant and found in more than 50% of their cases. So this is kind of one of the important signs to diagnose posterior keratoconus. The presence of that definitely indicates that the eye possibly has keratoconus. And sometimes this entity can trouble you when you're trying to do IOL power calculation for your patient. So the authors here, they landed up with a huge hyperopic surprise in a patient when they used conventional optical biometer IOL master to calculate the IOL power. And then they recommend that you should use a true net power direct from the Pentacam for IOL power calculation, because according to them, these are eyes, they are almost similar to the post, LASIK eyes, where the anterior and posterior curvature, they really don't have this symmetry, it's lost. So so it's not advisable to use the conventional method. However, even if you're using a true net power from the Pentacam, you need to still possibly, counsel the patient regarding the possible need for a secondary piggyback IOL in case these increased surprise still happens. So talking of management, well, the most important is to possibly minimize the amblyopia, especially if the patient, comes to you in the pediatric age group, because the amblyopia is very common, especially in unilateral cases. The main reasons being the presence of corneal scar and astigmatism, though the astigmatism is not very irregular here, but then they can be significant. And the whatever has been proposed is possibly to do a pharmacological dilatation of pupil, or even do an optical iridectomy. And even in very severe cases, you may need to do a keratoplasty. If the patient presents to you as an adult, what we need to do is rehabilitate the patient visually through glasses and contact lens. That's what we did for our patient. And since this can be associated with other systemic anomalies, we may need a pediatrician or a physician referral. To summarize, posterior keratoconus is a distinct clinical entity which all of us should be aware of, but it has nothing to do with keratoconus, which we are always discussing about. The tomographic features, it definitely shows steepening of posterior corneal curvature along with corneal thinning. And anterior corneal curvature could be flat or steep depending on the location and nature of the cone. However, we do need larger studies or based on tomography to understand this better. Management includes timely diagnosis, minimizing the risk of amblyopia, and visual rehabilitation. Thank you, sir.
Thank you for bringing us such a beautiful case on classic posterior keratoconus. You can stop sharing the screen.
Yes.
And we can have discussion at the end if you have time. So I would request Dr. Rushad to present his case. So we can just come to the highlight of the points, Rushad. So
yes,
I know you are very good in summarizing things, so I kept you at the last.
Is my screen visible, sir?
Yes, absolutely. Perfect. Go ahead.
Okay, sir. So I have just a solitary case. Thank you for the opportunity to present here. This was a lady with keratoconus with no other significant family history, with a worse vision in the left eye, which showed about a cylinder of 4.5 diopters at 135 degrees. So the keratometry also showed astigmatism about 6 diopters. This is what the slit lamp finding was, which was a posterior subcapsular cataract in the left eye. There were no other significant anterior or posterior segment findings. When we did the Pentacam, this is what we saw. That's the axial curvature map, the 4-map refracted. She wanted a toric IOL. She was a doctor. I counseled her saying that there still would be a residual cylinder despite doing a toric in her case. Now, this was what we got on the IOL master readings, which includes the total K values. As you can see, that there are 4 formulas that we've used in these printouts, which are the Holiday, the Hoffer-Q, the Barrett TK, and the SRKT. And I've done this at 2 separate time points, and there's a discrepancy of about a diopter in the values that are calculated. But what's interesting to note is that the SRKT actually gives the most myopic result, which has been shown in various studies to be true of the SRKT formula, where it over estimates myopia in normal eyes, which is a helpful thing in keratoconic eyes because we tend to have a hyperopic surprise. As we discussed earlier, this was the EKR values. What was consistent in this was that the axis of the astigmatism and the value of the astigmatism was around the same. which meant that this patient was a good candidate for a toric IOL. So what were our thoughts while deciding for a toric? Well, in this patient, the pros for a toric IOL was that the auto-K, the IOL master, and the Pentacam axis was matching. The patient wasn't a contact lens user, so she wasn't going to have an issue with the change in the astigmatic axis. Magnitude matched reasonably well between the auto-K, manual K, and the Pentacam. However, the IOL master was a little bit higher. And the EKR showed a consistent axis and magnitude in the central 4.5 millimeters. The cons for the toric IOL was that the IOL master total K magnitude was much higher. The IOL power calculation in keratoconus is tricky. This is because the keratometric index, which we routinely use, changes because the ratio is not maintained between the anterior and the posterior corneal surface. The Virgin's formulas which predict ELP also go haywire, and the corneal curvature measurements can also be inaccurate in these patients. However, looking at this particular patient, we went ahead with a toric T9. What I took was actually the 15, the higher myopic value of the IOL power calculation. And we used, as I mentioned, the SRKT formula, as it is shown to have least hyperopic predictive error. And this is a publication mentioning the same, where they even compared it against the Barrett Universal, which tends to give a more hyperopic surprise. With regard to toric intraocular lens implantation, there are different predictive values, prediction errors, which are seen across different grades of keratoconus. So in a mild keratoconus, there's no significant prediction error. This was a moderate keratoconus, which shows about a 0.3 diopter prediction error. And when you have a keratometry more than 55, then it's better to actually go with standard K values because of the higher prediction error. So since this was a moderate case, the biometric prediction error was assumed to be about minus 0.3. This is what we got when we fed in the IOL master readings into the toric calculator. What we can see is that there's still a very high amount of residual astigmatism with, in fact, the highest value of the toric lens available, which is the T9. When we looked at it with the auto-K values, again, it gave a T9, but the residual astigmatism was less. Similar with the Pentacam. And we also did it with the EKR values, as Lucy had discussed earlier in her presentation, which gave the least amount of residual astigmatism with the implantation of a T9 toric IOL. So this is what we finally went ahead with that. Post-operatively, 1 month following the surgery, the IOL was stable. There was no rotation. The uncorrected visual acuity was 6/9 in the left eye, and the corrected was with a minus 1.25 cylinder at 160, she improved to 6.6. The specular count showed that there was no significant change, and the patient was happy with the outcome on the whole. So the take-home points from this presentation are that it's important to confirm the cylindrical axis and magnitude on at least 2 devices. In keratoconic eyes, it's always better to target a myopic refraction, and the SRKT formula has actually been shown to be the best in terms of giving least amount of hyperopic error. The Pentacam EKR map is a useful tool while planning this, as we had discussed earlier, because you can look at the actual magnitude and the axis across various zones at the 1, 2, 3, and 4 millimeter zones. And that tells you whether it's going to work, the toric IOL will work well in the patient or not. Just food for thought. Thoughts from the panel on the approach to this particular patient. Was choosing a toric IOL appropriate in this case? And could anything have been done differently? A thank you to my DNVs who also helped me put together the presentation. Thank you.
Thanks, Ushad. Any questions?
Tushar, I mean, we'll wait for somebody to join. People must have just gone out for. Then we'll ask about your case, Tushar. Tushar, are you ready?
Yeah, I'm ready. I'll just share the screen. Sorry, there's something wrong. I'll just have to grant access from my system. I'll just take a couple of seconds.
So can we go to the next one and then we'll come back to you?
Yeah, that's fine. I'll just do it.
Ritika, would you do quickly your presentation?
Yes, sir.
Ritika is a fellow with me, and it's a very interesting presentation. It's all about how do you look at the centration when you're using a topography. It's a quick. These are all very small presentation. You can see there are only 5 slides. Let's go.
Yes, sir. Thank you, sir. So I hope my slides are visible.
Absolutely.
Thank you, sir. So good evening, everyone. I am Dr. Ritika Malik. I am a fellow at Narayana Nethralaya, and I'm currently pursuing my fellowship in cornea refractive services, optics, and clinical research. So as we know that the cornerstone of successful laser vision correction is the accurate centration of the ablation zone over the pupil. Symptoms of poor visual acuity, poor quality of vision, loss of contrast sensitivity, halos, glare, starburst, and ghosting of images have all been reported after refractive surgeries. And this is a cause where the patient is unhappy post a refractive surgery. So, but till date, we do not have a clear definition for the same. So we went back to a literature and we saw that Dr. George Quinones and his team had defined what a large decentration is. He said that more than 1 millimeter of a decentration is a significant decentration, which leads to such symptoms, and there's a post-operative unhappiness. So how do we classify a good decentered, good ablation? So this is a classical topography. This is a holiday EKR map for the same patient where we see one sharp peak and we see an eye trace for the same where there are minimal aberrations and the patient is happy after the surgery. So we move on to 5 such cases where post-operatively the patients had come to us. They were all in between the range of mid-30s to early 40s. They had all undergone refractive surgery such as SMILE, LASIK, and PRK. Everybody had undergone the surgeries 10 to 15 years back. They came with similar overlap.
Smile was not there 10 years back. Other surgeries.
Yes, other surgeries, sorry. So they all had similar overlapping complaints of difficulty in driving at night, ghosting and shadowing of images, starburst, and a little bit of blurring of vision. So there's the eye traces were also done, which showed aberrations. And the topography had a common denominator of being a decentered ablation. So we will take a quick case in detail. So the 37-year-old male patient underwent a LASIK surgery 15 years back. His primary complaints were difficulty in driving at night. His vision was not yet that compromised. His topography revealed a decentered aberration. Then the aberration maps, the Zernike pyramid, showed that there were coma, trefoil, and spherical aberrations present. The eye trace corroborated for the same. And the holiday EKR map showed a broad base, multiple peaks were present, ranging over 5 diopters from 33 to 37 diopters. And this is what I will ask the panel, that we should discuss this case and the managements of the case further.
We go back to the slide. One important take-home point in looking at Pentacam, they talk about decentration of 1 millimeter. 1 millimeter, I think, is from the, I'm not really sure whether it's from the center of the pupil or the visual axis. Whatever it is, one of the things about decentration is many times you may have a decentered ablation, but the patients are quite comfortable because maybe it's there, that's from where they're seeing their, that's where the visual axis is. One of the things which really helps to see if it's a centered or a non-centered is looking at the corneal zernical aberrations, especially the coma and all the trefoils and other things. So looking at decentration is just not looking at the blue map or the map which is well centered. It also has an important role in looking at the aberrations. And that is the most important take-home point in this presentation. You can stop sharing. If there's anybody else has anything else to add on deciding decentration, Rushad, anything else you need to add? How do you look at decentration? You have to unmute yourself.
No, sir. Specifically, I didn't have anything else to add in this particular aspect.
Perfect. Tushar, are you ready? Thank you, Ritika. Good presentation.
Let me share my screen.
can summarize it well so that we'll only get the gist of the main things, so that whatever already been discussed, you can just ignore it.
Sure. So just take a couple of minutes, I think. So I'll be talking about a pretty unusual case of post-LASIK IOL power calculation. So this was basically a 35-year-old lady who had undergone LASIK about 12 years back. And there's no prior history that we have, but the vision now is 636 in the right eye and 612 in the left eye. She had an immature cataract, both eyes, nuclear sclerosis, grade 2. So in this case, we were not able to get any measurements from the optical biometer. And on the axial length, what we got was 33.46 in the right eye and 34.65 in the left eye. But basically what's really unusual here is when you look at this keratometry, it's an absolutely flat cornea. I mean, the K mean here is 25.5 diopters in the right eye and 26.9 diopters in the left eye. So we don't know how much ablation was done, but a huge amount of ablation has been done. The BAD-D map, not too significant here, but here again, when you look at the EKR map, extremely flat keratometries, and there is a significant amount of intrazonal and interzonal standard deviation as well. So normally, as Dr. Lucy had explained really well how we go about calculating with the ASCRS online calculator, I fed in these values, but what really happens here is that these values are too low. The ASCRS calculator doesn't accept these values. So the lowest value that the ASCRS calculator accepts is 31, which is at least 5 to 6 diopters higher than what we were getting in the 4.5 mm zone of the EKR map there. So arbitrarily feeding a value of 31 diopters, you would get an IOL power of 16.69 diopters. Again, arbitrarily feeding a value of 31 diopters on the optical biometer data, you would get a Barrett true K of about 16.7 diopters. But really, there is no way to calculate the IOL power here because the calculator wouldn't accept these values. So how would you go about this? And to me, there was no direct way to really find that out. It's just that you know that the cornea that you have is significantly flatter than what you've entered. So the IOL power has to be equivalent or higher than, about 5 diopters higher than what the calculator is telling you. So there is no direct way to calculate. We went ahead with an IOL power of 21 diopters, and we did fall a little short. We had a post-operative outcome of 1.5 diopter square. So if we really knew the IOL power to implant, we could have probably gone closer to 0. And again, we had to plan the left eye based on this refractive error now. So we decided to go a little higher in the left eye again, because you want to get as close to 0, but you don't want anisometropia either now. So here it was a little closer. We got to 0.5 diopter square. The patient was 6'9" uniocularly in both the eyes, but clearly not an ideal way to calculate the IOL power in this case. And I would like to ask the panelists if there is a more accurate way and if we could have really managed to hit bullseye by any other method in this particular case. Thank you.
You can stop sharing. Lucy, Rushad, Narayan, any one of you can comment. Pooja, Lucy.
Yes, Tushar. You didn't get anything on the optical biometer, right?
No, we did not. Yeah, because it's too flat, I think, for it to be able to measure 24, 25 diopters. And if you look at the zones, 1 mm, 2 mm, it was about 21, 22 diopters in those zones. So unbelievably low keratometry values.
I don't think there's any other way to calculate.
Somebody has said here, somebody said that you can leave it aphakia and do an aphakic refraction and do a secondary implant.
Yeah, then that would be the only other option.
Or if you have an intraoperative aberrometry or aura, would that be maybe at someone at RP Center can comment on that? That would be probably the best way.
Yeah, because doing an intra-op refraction also is not possible with such flat K. So it is difficult to get a correct refraction also in these cases.
Namrata ma'am is here.
About the intra-op aberrometer, I think it's a good tool to have, but most of the times it is okay after post refractive surgery, post LASIK, post RK. But yes, it will definitely add one more way of confirming whether you are doing it the right way or not. So that is definitely there. So that can be used, and it has been, we have used it in quite a lot of eyes, where which have come with post-refractive surgery and when you need to calculate the IOL power. So that is one thing which can be used in this case.
So we have last three small talks. These are all advances, and this is something called as a Pentacam wave. And I would request Dr. Sneha to share the slide. I mean, it's very interesting because Pentacam is going to change. All of us have used one type of Pentacam. What is going to be the next wave in Pentacam is what Dr. Sneha and her colleagues are going to show. This is just a small presentation that should get over in 5 minutes time. And Dr. Sneha, would you continue? I think that video has already been played.
Yes, sir.
So you don't need to play the video again. Just briefly describe the Pentacam wave because all this is extremely new to all of us. Dr. Sneha is helped me a lot in planning this whole program, the cases with her committee and all of them. And Sneha, please. Be very brief and to the point.
Yes, sir. Good evening, everyone. At the onset, I would like to thank Dr. Rohit Shetty, sir, and Oculus for giving me this opportunity to be a part of this webinar. I'm Dr. Sneha, a fellow in Cataract Refractive Services, Optics and Clinical Research at Narayan Nethralaya. We have been working on the Pentacam wave, so I'll be basically discussing how this Pentacam wave is different from the other topographers and tomographers. We have come a long way from manual keratometer to automated keratometer, Placido disc-based corneal topographers, OpScan, and Pentacam. Pentacam has evolved from measuring corneal tomography by HR to measuring axial length in addition by the Pentacam AXL and measuring the total corneal and ocular aberrations as well as the objective refraction and retroillumination by the Pentacam AXL wave. Thus, corneal tomography, optical biometry, in addition to aberrometry, everything is performed by a single machine, that is the Pentacam wave AXL. The corneal tomography works on the principle of rotating Scheimpflug, the axial length measurement on partial coherence interferometry, and the aberrometry on the Hartmann-Shack principle. The new full sequence in the examination icon helps us to acquire the corneal tomographic maps, the axial length and the IOL calculation, the aberrometry, and the visual performance. This is how an aberrometric scan is acquired. The quality of the scan can be seen in the left-hand side of the icon, whether it's a good one or a bad one or a borderline. The visual performance display tells us the visual quality from the total cornea, that is the anterior as well as the posterior surface of the cornea, the true internal visual quality coming from the lens or the IOL, and the visual quality from the total eye. It measures the corneal aberrations from the total cornea, including the anterior and the posterior surface, from the total eye, and also the objective refraction of the eye. The wavefront the Hartmann-Shack sensor helps in assessing, shows the retroillumination that helps in the preoperative assessment of the lenticular opacities and the postoperative assessment of the IOL position and the IOL inclination. It also measures the axial length that helps in calculation of the IOL power through an IOL power calculator incorporated in the machine. Thus, it's a single device that performs 5 major functions in one single measurement and therefore is very practical and useful in these COVID times. Now my colleagues, Dr. Reshma and Dr. Div.
Not only COVID times, I think it's all times because it is very important that you have to have one machine which does everything. But there's 2-3 slides is all about how repeatable and how good are these measurements because it's a new device. And 2 of the colleagues will just speak about it and we'll open it for discussion.
Yes.
Good evening, everyone. I'm Dr. Reshma Ranade, currently pursuing fellowship in cataract, refractive, optics, and research at Narayan Nethralaya. At the onset, I would like to thank Oculus, KLB, and my mentor, Dr. Rohit Shetty, sir, for giving me this opportunity. My colleague, Dr. Sneha, just spoke about the Pentacam AXL wave in the future. And now, whenever there is any technology launched in the market, the first question that comes to our mind is, what about its repeatability? So I've had an opportunity to work with this machine for the past 1 month, and we decided to study the repeatability of aberrations and keratometry on Pentacam wave in normal patients, in keratoconus patients, and in post-refractive surgery patients. So after a basic evaluation, which included the visual acuity and the subjective refraction, the patients were subjected to 3 scans, which were taken 5 minutes apart by the same observer in a dark room on the Pentacam wave. The repeatability was assessed taking into account the within subject standard deviation, the test-retest repeatability, and the coefficient of variation. Coming to the parameters, we found that the range of repeatability for the steep K was 0.1 to 0.5. For the TCT was 8 to 10 microns. For the aberrations, the spherical aberration was minus 0.03 to plus 0.07. For the LOA was 0.86 to plus 0.21. For HOA was 0.21 to 0.51. And for coma, it was minus 0.01 to plus 0.13. Now, what is the coefficient of variation? It determines the dispersion of the values around the mean. So the RMS HOA and the spherical aberration showed the coefficient of variation in the range of about 24 to 25%, which was still found to be acceptable. We also studied the agreement of wavefront refraction on Pentacam wave and the subjective refraction. The wavefront refraction was measured in the optical zone of 4 millimeters, and we found a good agreement between the sphere and the cylindrical values when compared to the subjective refraction. The corneal aberrations and the total aberrations were measured for checking the agreement between the Pentacam wave and the eye trace. Bland Altman's plots, which are the scatter diagram plots, were plotted, and the solid line represents the line regression, while the dotted line represents the 95% confidence limits. We found that there is a good agreement between aberrometry regarding the corneal aberrations and the total aberrations when measured on Pentacam wave and the eye trace. Thank you.
Good evening, everyone. I'm Dr. Divya, Fellow in Cataract and Refractive Services, Optics and Clinical Research at Narayana Nethralaya, Bangalore. Now, in addition to the studies on repeatability and agreement as discussed by my colleagues,
Divya, just unmute yourself, please.
Yeah, unmute. Divya, please unmute. Divya?
Divya?
Dr. Divya?
Just hold on a minute, please. So Divya will be basically talking about the role of scatter and tear optics and how it actually alters the repeatability of the instrument. We'll just try to unmute her and get back.
Basically, I think you can have the slides on. I will just do the thing because she's come back. I think she can speak. Spoke about a lot about the machine's repeatability, and this is very important study. It just talks about how your tear film can make your repeatability to become worse. And this is a very important topic. I think all of us should know that a dry eye patient will not have the same kind of repeatability in compared to a normal patient. And just quickly, briefly tell this, summarize it, please.
Yes, sir. So the research question was, do tear film optics impact the repeatability of Pentacam wave? For this purpose, we categorized patients into 2 groups, those with a normal OSI that is less than 1 and those with a higher OSI. These patients were subjected to 3 scans on the Pentacam wave and then checked for repeatability. We found that the repeatability of Pentacam wave for keratometry and aberrations was poorer for patients with a poor OSI. So a higher OSI was associated with a larger range of repeatability on Pentacam wave. What you take home from this is it is difficult to acquire a scan of optimal quality in patients with poor OSI. So in a patient with ocular surface issues, a single measurement or a single reading may not be reliable. Thank you.
You can stop sharing the screen, please? I think this is a very important taking point, is in a patient who had a poor ocular surface of any kind, don't rely on one measurement, because if you want to compare this for the second time, the one measurement is going to be completely haywire. And that is the most important take home point in this presentation, these three presentations they showed. We come to the last presentation, and this is going to be given by Dr. Abhijit. And Abhijit is here.
Yeah.
So Abhijit and Gairek, both of you can summarize this presentation in 8 to 10 minutes, and this will be the last presentation for the long evening. I think Dr. Namrata ma'am, you should give us a record for having the longest webinar or for a one small machine.
I know. I think everything threadbare was, discussed by all the experts, and there was nothing which was. If somebody looks at this webinar, then it's the whole machine, and everything, and the futuristic directions, and all that is required of from Pentacam and from Pentacam Corvus.
This particular thing, what Abhijit is doing, I request all the panelists and everybody to be part of this, because this is a very, very important tool which the team has developed. This will kind of one day be part of Oculus machine also. And Abhijit has just 6 or 7 slides. So I think he's going to talk about something very, very futuristic driven software, which will bypass a lot of known indices. Dr. Abhijit?
Yeah. So thanks for the introduction. So the title of my talk is AccuSimX, and as you can see, it's kind of an acronym for simulating the unknown. So over the evening, I think a lot has been discussed about, combining Pentacam and Corvus, and how we have a huge array of indices, BAD-D, CBI, even SSI is there. And I think the general consensus is that, to use these indices to evaluate and and even more predict where the cornea will end up after the common refractive surgeries that are performed can really go a long way in trying to avoid ectasia in these patients. So we have been working on this for quite some time, and that's basically the primary objective here, is to predict where post-operatively the cornea would lie, and this would give an indication to the surgeon to decide the appropriate course for that particular patient. Now this is an example of a patient, healthy cornea, CBI, TBI, all okay, BAD-D is also okay. Yet the patient ended up developing ectasia. And we can see the lacunae in the current indices, and some of the reviewers have also spoken about it. So the big challenge with the current indices is that, the machine uses empirical analysis and does not really address the true scientific method of evaluating tissue biomechanics. Now, we don't expect clinicians to know everything about tissue biomechanics, because that's altogether a different field of science. But what we are trying to do is to enable surgery-specific preoperative modeling, okay? And for this, we know that there are 3 forms of surgery. You have SMILE, you have LASIK, you have PRK, and they all have a different impact on the collagen fibers post-operatively in terms of how the stroma is modeled. And there are a lot of other intrastromal features that also go into it. So we published some years back that we can actually predict where the corneal stiffness of the particular patient would end up after refractive surgery, and we could predict this with a very high amount of accuracy. So now the issue is that these are very sophisticated tissue mechanics simulations, and combined with artificial intelligence, which we can do it in the research frame, but how do we translate this into the clinic? And also in a manner where the clinicians can use it in their day-to-day practice. So we went around designing a software, and this is basically showing the performance of the software where compared to what was measured in vivo. So you can see that on the y-axis, and what we predicted from a software, we got an excellent intraclass correlation of 0.95 across all platforms of surgeries. And really the best intraclass correlation would be 1. So this is how we went around designing the software. So we have the Corvus machine, we have Pentacam. We design the software to calculate the preoperative stiffness. Then we also design the software to perform the surgery in a virtual setting. So basically, you can input different parameters for the specific surgery of your choice, and then see what the predicted post-operative corneal stiffness would be. So now, if the prediction of the software would end up matching what you actually got from the patient post-operatively, there's no action needed, and you actually have a favorable outcome. But just in case the predicted post-operative corneal stiffness is outside the normal range that is predicted by the software, it may be a cause of concern. So of course, whether the patient ends up with ectasia will be only known with time, and that is what the software is aiming to solve for the physicians in the clinic. So now we have a novel way of doing these sophisticated biomechanics simulations in the OPD without, without too much complexity. And I'll just show a small demo of the software, which we are going to launch with Oculus very soon in the next few weeks. So I'll just go to the share screen. So this is basically the software. As you can see, the window here, you have a format for refractive surgery simulation. You can export Pentacam files. You can import Pentacam files. You can import Corvus files. So I'm just clicking on the Pentacam file here. So this is an example. And the software automatically pulls in the relevant information from the Pentacam data. We can also import the Corvus data files, and you can see both informations are automatically pulled into the software. Then you can choose whichever surgery you want to test out for this particular patient. So for example, if you want to test out for LASIK, you can enter the parameters of choice. You can, depending on what you do in your day-to-day practice, you can have the refraction of choice. And you can also have the option of a uniform epithelium thickness, or you can have an option of a customized thickness. So what is this customized thickness? I think we briefly touched upon in the earlier talks about the epithelial maps. And with the newer generation tomographers, which will hopefully come out in the near future, one of them is already out though, where you can get a spatially varying epithelial thickness profile also. So that can be also fed into it. And once you have selected all these parameters, you basically just start the simulations. So what kind of outputs do you get? So basically, once the simulations are done, you get these completed messages. And what kind of outputs are obtained? I will just share one last screen. Just kindly bear. Yeah. So I'm going to share this screen. Okay. So I hope you can see the screen. So basically, you get a very nice report of for this particular patient with respect to what is the surgery that's simulated. You have these nice population databases, which I think most Pentacam users and even Corvus users will be familiar, which shows for our normative population. And please keep in mind that this is Indian population that we have trained it for. So this is probably the best suited for our population as of now, where we have the preoperative data set here. It shows this yellow curve histogram there, and then what these patients ended up post-operatively after the surgery was done. And these vertical black lines show for this particular eye what was the pre-op stiffness and what was the predicted post-op. The change in the stiffness, that is a post-op minus pre-op, is also shown in this figure below. So now, in summary, you get what would be the predicted stiffness post-op and what would be the predicted change in corneal stiffness. So the idea is to have more patients lying on this side of the within the distribution of the blue population database that you see in change in corneal stiffness. So in terms of clinical role, what we are really looking to achieve is to have a virtual platform where you can simulate any of these surgeries and see what would be the expected change of stiffness, and also compare it with respect to what a normal population would give. And this would help you in probably assisting the choosing the right surgery for this patient, so that you can, for all purposes, you can completely avoid ectasia. Now, similar reports can be generated for PRK and LASIK as well, for SMILE as well. And we are also in the process of incorporating data for topo-guided treatments also. So this will be probably the first virtual platform of its kind where sophisticated tissue biomechanics tools as well as artificial intelligence will be combined to give you realistic predictions before even you have made a single cut in the patient's cornea. Thank you.
Thank you, Abhijit. Wonderful presentation. I think we come to the end of this talk. Anybody has any questions on this particular talk? Yes, ma'am.
Yeah, that is excellent, Abhijit. It's such a pleasure listening to this. How does the intraocular pressure matter in these patients in the software?
Yes, it does. So the software automatically pulls in the intraocular pressure, which has been measured by Corvis. Okay. Now, if, for example, you want to change the intraocular pressure, you also have the option to do that. So again, in the physiological range, the impact of plus minus 2-3 millimeters on the corneal stiffness is very less. So fortunately, we are safer in that respect. However, if you want to simulate a corneal response of 15 millimeters of mercury versus 25, that's a big change, But if it is 15 versus 17, it causes a very minor change on your predicted postoperative stiffness.
And corneal thickness? So
the corneal thickness is factored in the simulations by default. Okay. So so that's the beauty about this. So we discussed a lot on, I think, SSI. So they planned SSI to be independent of thickness, but they did not plan SSI to factor in the patient-specific tissue modulus of the cornea. So SSI assumes the same tissue modulus for every simulation that they conducted. It is not a patient-specific value. So that's the reason why SSI has a lot of overlap between populations. But with this simulation platform, you can calculate the corneal biomechanical properties specific to each eye. So it doesn't matter how many eyes you want to simulate. What is the eye field? What is the corneal geometry? What is the corneal thickness? What is the IOP? It takes in all the patient-specific values and helps you calculate the patient-specific corneal biomechanical properties.
That means basically you feed, for example, he is fed in, say, Dr. Pooja. It's fed in Pooja. For Pooja, does SMILE create less biomechanical change? PRK does less, or LASIK, or all are the same?
Yeah.
If all are the same, then it doesn't matter. If PRK is best, then you choose that a PRK is best. So this, and the advantage of this software is that Dr. Gairek, in the for the paucity of time, we did not ask him to present it, but his area of work is doing his PhD on AI with me. He's a cornea refractive surgeon. He did fellowship, and now he's taken up AI. This whole work is part of his PhD work, and he has already had 2 papers which has bypassed a lot of these values and build an AI on the indices. So without presentation, can you quickly tell Gairek, what did you find about this AI as the next big thing in all these machines, and what a clinician like all of us should know?
Normally we are, looking at it just monofocally, looking at just a set of indices or just one index, which, sometimes we look at either BAD-D, look at only Kmax. But what AI helps us in quantifying or differentiating, looking at multiple indices which we normally don't look at. Okay, for example, we ran an AI on progressors in keratoconus, where we wanted to basically find out whether in progressors, what are the indices which tell us that this patient's progressing, whether a progressor in a keratoconic patient is just a focal change or a global change. So what we found was there are a set of interesting indices which were a combination of both keratometry and aberration derived indices. And these are not the conventional indices. For example, something related to ISV, IHD. These are set of indices which we normally don't look at when we are looking at topography or looking at a Pentacam map. So AI in that way can change the way we think, change the way we look at or approach patients. So we're also in the process of looking and integrating molecular data, integrating demographic data to make it a more robust model. So AI is the way forward, where we not only look at indices, we also look at biomechanics, we also look at epithelial mapping, as well as molecular and demographic profiling. So that is the way forward. There has been considerable work in this, but yeah, we are a long way forward now.
Basically, when we look at classifying a progressors versus non-progressor, for all the Pentacam users here, we'll say, okay, we'll look at BAT, we'll look at corneal thickness and all that. But what was interesting to all the clinicians here is the AI never looked at any one of them. From the data here, he had more than 3,000 odd images analyzed. It took 2.5 years just to get the data out. And the AI just ignored these values, picked up its own combination of values. And that was very interesting because we had never looked at those values in Pentacam at all, because we thought that those values are not important because brain only looks at the obvious ones. So that is, I think, how I think AI and these kind of simulated modules is going to change the way we look at these indices in a different way for a refractive surgeon versus a keratoconic eyes. Any other questions or any others, madam? Dr. Namrata, ma'am, thanks for staying for all the 7 hours. And I want you to do the summing up. I think Professor Titial is not here. If he's there, then we can ask him. Okay, ma'am, you can do the...
I think the last part was really promising, and I'm sure that is going to be the future. And you've already integrated it and done it. And I think the best part is that we always keep harping about Caucasian eyes, Caucasian data, and Caucasian patients, and not Indian patients. And that has been done here in India itself. So it is going to be reverse, leading from here to the Western world rather than from there to here. So as far as the whole webinar goes, like I said, there's nothing which is, left to imagination. Every single detail on how to check for decentered ablation, what are the fallacies, what are the advantages, what are the disadvantages, where we can go wrong, and some of the places even where probably the manufacturers don't know, the other people don't know where the fallacies are and what should be the future directions. I think everything was done threadbare. And congratulations to Rohit and his team, and to all the speakers who got out their different case scenarios, case discussions, case presentations, and gave us insight into so many things. Dr. Prema ma'am I think has also been here for quite some time and gave great presentations. And I think we've not exceeded too much of time. It's only half an hour past what we had intended to. So this had been intended to be a long session, and I'm sure Rohit must have, thought that it is going to be a long one. Rohit anyway likes long sessions with detailed discussion, which should be the way to go on areas, which are not as clear to us. And Oculus, I would like to congratulate, because Oculus is one company, although all the other companies are also studying their topographers, but for quite some time and over a prolonged period of time, it has, standardized the whole thing and told us about long-term results, told us about short-term results when it had come. So again, Oculus, Mr. Divakar needs to be congratulated for having this done for all of us.
Yes, absolutely. Dr. Rajeev, sir, I think you started the whole session. Now you're here at the end.
No, I came in between in bits and pieces, but I guess this was an amazing session, and I must thank Rohit, all his colleagues, all the speakers, and I would say a big thanks to Divakar and his team. It was a fantastic session. I mean, it was a big learning experience for all of us, and thank you so much.
Thank you. Rema ma'am, if you're still here. You're summing a point.
It was just amazing, Rohit, just absolutely amazing. And like I said, I think with so many Pentacam users in so many ways, in which it's being used. It was high time that this meeting was organized, and I'm so glad all of you have been able to do it. Like always, I enjoyed every moment of this.
Thank you, ma'am. On behalf of our chairman, Professor Titial, sir, I think he must be busy today, and he was, and then all the panelists and all the speakers. Thank you all. Thank you, Divakar and Sri from Oculus, and we have had people from Peshawar, Lahore, and a lot of people. We are virtually logged in from all over the world. I think one Miss Ma'am, Namrata ma'am, and we both of us could recognize was we had one person from Kyoto also. And so I think this was a good webinar which covered a lot of things. And like I said, hopefully next year we'll have a physical webinar somewhere in the mountains. And with that time, I think Pentacam Wave will become more stronger as technology, because now it's just been launched. And we have answered most of the questions. I think this is going to be a recorded one, and it's going to be, I'm sure Divakar is going to give the recording. And I thank Dr. Pooja, Dr. Sneha, Krati, and all my young fellows who put a lot of efforts to get this program made during the COVID time, because it's a challenge, we start making a video and the videographer, the multimedia guy becomes COVID positive, somebody else becomes negative. I mean, this whole process we have realized that things which otherwise would be so easy to do become so complicated, even to run an organization. So I thank everybody, and thank you, Namrata ma'am, for all the encouragement all the time and staying till the last.
Thank you, Dr. Rohit.
I think it was a great learning for all of us. I mean, even we learned so many things. I think it should be recorded, edited properly, and should be, can be used as a demo kind of a webinar, which tells everything right from the inception of the Pentacam until your Acumix, which is going to come.
It's actually going live on YouTube, so you would have a link always there.
Yeah. So we can just edit the parts, which are not related to the discussion.
Rohit, today has been a Pentacam wave.
Yes, ma'am.
Thank you. So we can